Halo, halo, cek. Halo, halo.
চিক 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 চিক। হ্যালো, আপনার ওখান থেকে কপি নিতে পারবেন না? আমি এখানে সব ফ্ল্যাট করে রেখেছি। ঠিক আছে।
In 2023, you will be diabetes free. It doesn't matter.
Achyutam Keshavam Krishnadamodaram Achyutam Keshavam Krishnadamodaram Keshavam Krishnadamodaram Kesavam, Krishna
हेलो अली। नहीं 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 नहीं, कुछ मत कर। यहाँ पर आया। ज्वाइन भी तो नहीं है।
Good morning, everybody. Fewer in number, but we can start with a bright morning. Good morning, everybody. Sure, everybody else will join us very soon. So, welcoming all of you at the Eiicon 2023, organized by the CSI West Bengal branch. Can we have a big round of applause? 2 days long conference, lot of exchange of ideas, knowledge, and enriching session back to back. We are running a bit late, so we'll directly start with the first session. Journey of oral semaglutide from concept to reality. I would like to invite on stage Dr. Dilip Kumar, sir. Kindly, sir. Big round of applause.
So good morning, everyone, and I hope the conference will be a super hit because I'm the opening batsman, and if it doesn't go well, then it's my hard luck. So it will be, I think, it will be a big success, and we are starting with a molecule which holds a lot of promises. Journey of oral semaglutide from concept to reality, and we all scroll through our TCTMD website pages almost every day. And what we saw a few days back that FDA has given a warning about this molecule that this is getting out of stock. So GLP-1 receptor analogs are getting out of stock in US, and that came as a warning from FDA. It has never come earlier like this way. And there is an ongoing trial which is called SELECT trial. If it becomes positive, then I think we will see and witness something which has never been witnessed in the history of medicine. So a drug so costly getting out of stock. So these are my financial disclosures, and right from our habits and our perceptions, we don't want anything injectables, be it from vial and syringes, be it from once daily pen injections. Pen injection seems so convenient that just you push it, you don't get a pain, something like pinprick, and for 1 week you are done. Even with this kind of pinpricks, we are uncomfortable. But what we want is oral administration because we feel safe, and we have many apprehensions while taking injectables. And these are in fear of injections. We are taking something going inside our body, pricking us. Perception of last resort treatment. We feel that it's last resort. What will happen after the injectables? Fear of hypoglycemia. If something we are taking, it can cause hypoglycemia, too many injections, fear of weight gain, poor communications with physicians can also mislead a patient that it can be detrimental. So 76.5% of type 2 diabetes prefer a once daily oral tablet versus once weekly injectable medications. And the most cited reasons of tablet preferences were convenience and dislike of needles. So we don't like needles. And here we come. After 100 years of a long journey, it started in 1922 when Dr. William Banting and Best first isolated insulin, and the discovery of insulin was made. And it came with a surprise. You see, Dr. Banting was a captain, a decorated captain in British Army. He got injured in First World War, and he relocated himself to Canada. He started his own practice. And for his first 1 month of his practice, he got one patient. So after getting totally disheartened, he left the practice and he went into research. And what came out is the insulin. So this is how destiny plans for you. Something else is planned for you. If you want something else, it won't work. Finally, we got insulin. And since then, 1920s, there was a quest of oral insulin, which started. And now we have realized this dream in form of oral peptides, that is GLP-1 receptor analogs. So the quest for first ever oral peptides, the oral administration of peptide is challenging. Now getting realized, what are the challenges which we're getting faced where there was a enzymatic degradation of the peptide which we take. There's a limited permeability, low oral bioavailability. So what we need is to do enzymatic stability, bring enzymatic stability to the drug, to the product. we have to enhance the permeability and avoid food effects. Means if you take something with food, it is going to get, mixed up, and things won't work. So this is how insulin versus GLP receptor analogs, which can be better, which can be suitable. So GLP-1 receptor analog can be, a notch better than insulin in terms of dosing convenience, in terms of pleiotropic benefits, in terms of safety. And that is why we see emergence of molecule, and now it's orally available. So these were basically the need of oral GLP-1 analogs in diabetes management, what we all just now discussed, the challenges. And these were extra, challenges to all of us, like there was a poor glycemic control in managing diabetes, non-adherence, compliance, early and efficient treatment. So we needed a drug which is efficient, which can bring down HbA1c like very strongly, and these have multiple benefits. And this came into effect with 3 modifications in the molecule, the GLP-1 analogs at position 8, 14, and 34. So 14, 8, 18, and 34. So at the 8th place, amino acid substitution against DPP4 mediated degradation. There was a substitution which basically helped protection against DPP4 mediated degradation. There was a substitution at 18th molecule that helped C18 fatty D acid, it allows slow degradation and reduces renal clearance. And finally, amino acid substitution at position 34 prevents C18 fatty acid binding at wrong site. So this is how it started working. Semaglutide has 94% homology with human GLP-1 analogs. And these are the many sites of semaglutide. One molecule has got all the actions, the octet, what we call the physiology of pathophysiology of diabetes. It acts on almost all, arms, limbs. You see here, it has got a additional cardiovascular benefit, reduces the obesity. It also acts on non-alcoholic steatohepatitis. It reduces the progression of kidney disease. It also acts on Alzheimer's disease. So we needed a formulation which can be synergistic, and we take a drug which can work, but it needs to be absorbed, assimilated, and going into circulation. And that is why this NAC came into picture. SNAC, this is an absorption enhancer. So what we see here is a drug which has got long half-life, but it needs to be absorbed. And what was happening was, once we take this drug, once it gets into the stomach, the tablet erodes. The drug was getting damaged by the pH, low pH at the stomach, and that is what SNAC does. It causes a transient localized increase in pH, protecting semaglutide from proteolytic degradation. And it also facilitates a highly localized absorption of semaglutide across the gastric mucosa in a concentration-dependent manner via effects on transcellular pathways. So oral semaglutide gives you benefit. It increases the bioavailability, increases the absorption by these mechanisms. And there was a Nobel Prize Committee for Medical Innovation endorsed this drug, oral, and they recommended that oral semaglutide deserves this year's Prix Galien in the category of primary care. It's a true breakthrough. And probably in coming days, more and more cardiologists, just like SGLT2 inhibitors, will going to adopt this drug and gives maximum benefit to our patient. The thing which really retards us, inhibits us to writing this molecule is our inability to convince the patient and tell everything what is required for this drug, how to take this drug, what are the problems they can encounter, and what are the benefits they can have. So the drug should be taken in empty stomach with half a glass of water, approximately up to 120 ml. Wait for 30 minutes, preferably in a sitting position or standing position, and don't take any food within 30 days. Start with 3 milligram dosing and gradually up titrate with 7 milligram and finally 14 milligram in 2 months, 8 weeks time. So in summary, Peptides are challenging compounds and require engineering to optimize their in vivo performance. Peptide analogs can be designed to offer improved stability and prolonged half-life, which a formulation approach can facilitate improved absorption. Absorption of oral semaglutide takes place in the stomach and requires conformulation with SNAG. And mechanism of absorption is shown to be compound-specific, transcellular, and without any evidence of effect on tight junctions. And development of a peptide in a pill, oral semaglutide, represent an advancement in treatment possibilities of chronic disease by transforming injectable therapies to tablet-based oral formulations. Thank you so much for the patient hearing.
Yeah, thank you, Dilip, for a nice elaboration of the subject. This has always been a problem because peptide in a pill has been our dream, and now it has come into being. And I think this molecule, which has come up the ladder, as we know, in the treatment not only of diabetes but also in atherosclerotic cardiovascular disease. But we see a lot of subclinical atherosclerotic cardiovascular patients of diabetes who doesn't manifest kind of issues that MI or angina or something like that. So I think we should catch them young and hit them hard. And that's why these kind of molecules should be preferred over other conventional drugs. Yes. This is my opinion.
Yeah, first of all, congratulations for a very nice presentation. I think the initial apprehensions about the tolerability has been overcome. So we are more or less confident that if you give the right kind of directions to the patient, it is well tolerated and we can go up to the target dose in many of the cases. What is your experience so far?
We have prescribed only a few, only a few patients, and till now, I think we have gone up to maybe 14 milligram in only one patient and 7 milligram in most of the patients. They tolerate well, very limited number of patients. That's why I am unable to comment. I think Dr. Hajra can tell. He has prescribed many drugs, many semaglutide to his patients. But for sure, it holds huge promise. And there's a development called GLP and GIP-1 analog, tirzepatide, and that has really shown benefit in reducing body weight. So with these two drugs, GLP-1 analogs and GIP plus GLP-1 analogs, if they reduce body weight up to 20%, so recent reports have shown 20% reduction in body weight. So it's going to be a game changer. But all we strive, we go into gym, we try to cut down carbohydrates. This will come automatically. You will not feel like eating anything, and you will reduce weight with minimal side effects or almost no side effects. Yeah.
Right. I think that story started from Gila monster. The Gila monster is a lizard in Mexican desert, and how many times she eats in a day? She doesn't eat in a day, not in a week, not in a month. She eats only 2 to 3 times in a year. So from her saliva, we thought there must be something in Gila monster saliva which prevents their appetite or satiety suppressed. So even she eats 2 to 3 times in a year, she stores enough of her energy for the rest of the year. And the excedent base, then it was started with Michael Nock. And the Michael Nock, there is a lady called Nicola. The Nicola, she was very enthusiastic about this medicine, and she was giving. And unfortunately, on 7th month of her study, she died in brain tumor. She had glioblastoma, she died. Then the Michael Nock took it over. I think it is such a molecule that he deserves a Nobel Prize. So it has won many accolades and many prizes in the world. And from my experience, I'm using it for almost 2 years, more than about 1,000 patients. It's a game changer, not only for diabetes. You can take out the insulin, you can take out oral hypoglycemic agent. It gives complete remission of diabetes. So this is conjectural and intuitive thoughts. And invariably, everybody has lost weight to the extent of 20, 30 kg. 20 to 30 kg to be recorded. Like, this is the only thing which in oral form, peptide in a pill, you can change the whole game. Yes, Anjada.
You for your excellent presentation. Interestingly, although it reduces body weight, it takes care of the liver part of metabolism, but its effect on lipids and blood pressure is not to that extent as expected. What is your comment? Reduction of weight is there, taking care of glucose is there, but surprisingly, lipids and hypertension is not properly addressed.
It's not made to address those parameters.
That's because
Yeah.
these are overweight related complications.
Yes, and but it has shown to reduce LDL and triglycerides as well. So it has some effect on lipids as well, and definitely we have seen the reduction of obesity and weight. So it has got multiple factors.
Hypertension and static effect, lipids effect are not to that extent as
Hypertension.
body weight.
Actually, that effect on lipid and hypertension is a kind of secondary or passive. If you reduce your body weight and salt intake, if you reduce your body weight 5 kg, salt intake by 50%, you're going to reduce your blood pressure by 3 to 4 millimeters.
But this study,
This study actually was not looked for.
It was not looked for, yeah.
Not looked for.
And definitely we feel that some of the registry data have shown reduction of blood pressure. So if there is a 10 to 15% or 20% reduction in body weight, this is going to give you a reduction in blood pressure.
And the beauty, the unknown beauty of oral semaglutide is a only anti-diabetic drug which can work as a pacemaker. It increases heart rate. So it is a drug, pacemaker drug, like it increases the sinus rate by 2 to 3 beats. All the oral semaglutide. So it has got many more potentials in the treatment of cardiovascular disease. And thank you, Dilip. We are going to listen from Arindam. Arindam is going to speak on this cardiovascular disease and will elaborate with more discussion. Okay, thank you.
Thank you very much. Wonderful presentation by Dr. Kumar. And to be honest, blood pressure reduction was there in the study. In fact, body weight reduction, blood pressure reduction, and lipid parameter improvement were the other pleiotropic benefits, which were very, very clear in all the study. I'll show you the evidence. So mitigating the cardiovascular risk factor with type 2 diabetes mellitus with oral semaglutide. So these are my financial disclosure. Now, my agenda will be distributed upon the therapeutic inertia in diabetes management pioneer trials, which is the evidence. I'll briefly go through all the pioneer trials, and more so for pioneer 6, the cardiovascular risk reduction study with oral semaglutide, followed by summary. Now, as we all know, consequences of therapeutic inertia in diabetes, as Dr. Chakraborty rightly mentioned, many young patients where the diabetes is newly detected, but there are markers of atherosclerosis. So if we do not catch them young, what are going to happen? So increased macrovascular complication, we all know about myocardial infarction, heart failure, stroke, cardiovascular events. In fact, at one point of time, it was not very clear targeting HbA1c, whether it reduces macrovascular complications or not. But later on, after the long-term follow-up data of UK-PDS trial, we know if we catch the diabetic individual young and target a very stringent HbA1c goal, long run, maybe up down the line, 10 years, 12 years, it is possible to reduce the macrovascular complication as well. And this is the era where the new molecules such as DPP4 inhibitor, GLP-1, as well as SGLT2 inhibitor were not there. Still, if we catch them young, it is possible to reduce the macrovascular complication. Microvascular complication, the data is more linear and clear-cut. If you reduce HbA1c, we can reduce the retinopathy, neuropathy, nephropathy, no doubt about that. Now, if we do not manage the diabetic individual properly, there is poor outcome in terms of public health cost, and also reduced likelihood of achieving target level of HbA1c if we do not start it early. Now, GLP-1 receptor analog targets 6 out of 8 core defects of the type 2 diabetes mellitus. We all are aware of the ominous octet. Now, this slide is very important because if we see, it's not working anyway. So for 8 pathophysiological basic defect, decrease incretin effect. Yes, GLP-1 are actually meant for that. Decrease insulin secretion. GLP-1 also acts on the beta cell. Increased glucagon secretion can be taken care of. This is not taken care of majority of the anti-diabetic molecule. It also works in the brain, so neurotransmitter dysfunction is taken care of. It works in adipose tissue, so increased lipolysis and insulin resistance is taken care of. This is also done by metformin and other drugs. Liver, increased hepatic glucose production. This has been done by many of the anti-diabetic. It also works. Now, only place where it does not work is kidney. So probably combining this molecule with SGLT2 inhibitor is a very good idea, And the skeletal muscle, decreased glucose uptake. Yes, if we add metformin, then it becomes a complete treatment for all the diabetic individuals. So adding metformin and SGLT2 inhibitor will be complete taking care of all the pathophysiological aspect of type 2 diabetes. But mind it, this one molecule targets 6 out of the 8 important defects. Now, if we further see, the GLP-1 receptor analog provides multiple benefits in patients with type 2 diabetes. Weight gain, it is established. I'll show you around 5 kilo reduction of weight gain. CV benefit, it is there. Tolerability, if you give it in a proper way, it is very nicely tolerated. In my small experience, I have used it in around 10-12 patients, but out of that, only 2 patients discontinued the medicine. The rest of the 10 patients, they are continuing and they are in a good shape. So it also have a very potent HbA1c reduction property. In fact, the HbA1c reduction property is more than many of the oral hypoglycemic drug and minimal chance of hypoglycemia, which is an added benefit. Now, greater weight loss improves obesity-related complications. It's a well-known fact. If we reduce the weight by 0 to 5%, hypertension, hyperglycemias are taken care of. 5 to 10%, it prevents the type 2 diabetes as well as very robust effect on the non-alcoholic fatty liver disease. 10 to 15% weight reduction, cardiovascular disease, urinary stress incontinence have been shown to improve, and more than 50% there can be actually type 2 diabetes remission. Nowadays, if we go to social media, YouTube, Facebook, you'll get plenty of, advertisement regarding reversal of type 2 diabetes mellitus. And how they're doing it, basically, I think it is solely on the basis of weight reduction. If you reduce more than 50% of the body weight, your blood sugar will automatically be normal. So if this molecule reduces more than 15% of body weight, it has a remission property. That is something is very, very unique. And weight loss is associated with improved glycemic control. We can see the data is very, very clear. More the weight loss, better is the glycemic control. And one trial is look ahead trial. Look ahead trial, there was some controversy regarding the outcome and all, but there was 8.6% of the body weight reduction after 1 year, and that increased the, from 46% to baseline to 73% glycemic control goal attainability. So that is something which was seen in look ahead trial. Now coming back to the evidence for oral semaglutide, Pioneer group of trials were designed, and you can see Pioneer 1 to 10. So there are 10 trials which were designed. One was basically a basic trial, placebo control compared to diet and exercise. Now, Pioneer 2 compared this molecule with SGLT2 inhibitor plus minus metformin. Pioneer 3 compared it with DPP4 inhibitor. Pioneer 4 compared it with injectable GLP-1 analog. Pioneer 6-7 was flexible dose adjustment trial versus DPP4 inhibitor. Pioneer 8 was add-on insulin. Pioneer 5 renal impairment, and Pioneer 6 is very important because this is the cardiovascular outcome trial. Though it was a non-inferiority trial, but it's a very good, well-designed trial. I'll briefly go through it. And Pioneer 9 and 10, basically Japan, a country-specific trial, which I'm not going to detail. Now, if we see the overall, the results from the Pioneer group of trials, we'll see there was up to 1.5% robust HbA1c reduction and 5 kg of weight loss seen in overall trial, which is very, very significant value. And if we see the cardiovascular outcome in the, how it works, it has anti-atherosclerotic benefit. As Dr. Chakraborty mentioned, we should take care of the atherosclerosis. Type 2 diabetes mellitus is not a very simple disease. It's a very complex kind of disease. If we look into the natural history of type 2 diabetes mellitus, we'll find that high blood pressure and deranged lipid profile actually comes before the blood sugar is getting elevated. So blood sugar elevation is actually a late marker. So if we really want to understand the pathophysiology of the type 2 diabetes mellitus, we need to know more. And this particular molecule has some direct and indirect effect. So direct effect, it improves the endothelial function. It also reduces the vascular smooth muscle tone, by which it has a very robust blood pressure reduction property. And it also reduces the vascular inflammation. It improves the lipid accumulation. So these are the direct effect. And if we talk about the indirect effect, it is very robust blood pressure reduction property, weight reduction property, as well as HbA1c reduction property. By this indirect effect, oral semaglutide may offer atherosclerotic cardiovascular benefit by direct and indirect, and by improving the cardiometabolic risk of the patients. Now, benefit of different intervention in the coronary heart disease. So if we reduce the, these are the parameter, how much reduction of blood pressure is translated into reduction, we'll see very robust reduction. Risk of CAD can be reduced, and it has effect on blood pressure. As there was a discussion, oral semaglutide reduces systolic blood pressure very robustly compared to placebo. And by this, every 10 millimeter reduction of blood pressure translate into 11% of complication related to diabetes. So in diabetic individual, if you reduce the blood pressure, this is the result. 16% reduction of mortality related to diabetes, 11% reduction of myocardial infarction, and 10% reduction of microvascular complication. This is not about the HbA1c reduction. So in diabetic individual, if you reduce the blood pressure, this is the outcome. And this is very encouraging data. And semaglutide improves the blood lipid profile as well. Both LDL and triglyceride are very nicely taken care of. So this research indicates a need to focus on the triglyceride, because triglyceride many a time we consider to be benign, because all the intervention targeting triglyceride was negative. But now there are new researches, say for example, reduce IT. By reducing triglyceride, it is possible to reduce the cardiovascular mortality as well. So triglyceride is not benign, more so in diabetic, in Indian individual. So this molecule has direct effect on triglyceride. So effect on systemic inflammation, there were, evaluation of the HSCRP. This has a very robust effect on the HSCRP from the baseline and after uses. And this is a result from, Pioneer 6 trial. So oral semaglutide achieves primary endpoint of MACE reduction versus placebo, 21% non-significant. Why non-significant? Because this trial was meant to see the non-inferiority, and it proved its point. And a very nicely conducted trial known as SOUL trial is underway. And if you see the follow-up of SOUL trial, 3.5 to 5 years follow-up, it was initiated in 2019. And if the results are available, I fully agree with Dr. Dilip Kumar that it is going to be a game changer molecule, and I'm very, very confident about the molecule. Now, coming back to Pioneer 6, cardiovascular and all-cause mortality, it's a very promising 49% all-cause mortality reduction, 51% cardiovascular death reduction from non-inferiority point of view. So semaglutide reduces the risk of atherosclerotic event in cardiovascular outcome, and it is comparable. If you see the data of SUSTAIN 6, SUSTAIN 6 was a trial of semaglutide. It is injectable semaglutide. Needs to be given once weekly, and that was a superiority trial. It was proved to be superior compared to placebo in terms of reduction of cardiovascular event. And if we combine the oral as injectable semaglutide from SUSTAIN 6 and Pioneer 6, the data will be very, very robust, and there is very prolific reduction of HSCRP, lipid, systolic blood pressure, reduction in the waist circumference, 4.7 centimeter mean reduction of waist circumference. So it has shown clinically relevant weight loss across the Pioneer group of study. So average 5 kilogram of weight loss if you give it in a proper way. And that is why there is HbA1c reduction of 1.5%, systolic blood pressure reduction of 2.6%, which is very, very significant. And 5 kilo weight loss, oral semaglutide offers benefit with superior reduction in terms of HbA1c, greater proportion of waist circumference, as well as blood pressure and body weight. So proven safety of oral semaglutide across Pioneer trials. So it is very evident that instruction already mentioned by Dr. Dilip Kumar need to be taken at empty stomach, and nothing after nothing for next half an hour. And it's very important to make it a point, the half glass of water. You cannot take more or less, because if you take more water, that will also hamper the mechanism of action. The effect may not be there. So that is how you should take it. So factors decreasing semaglutide exposure, I already mentioned. I'm not going to detail. You cannot take food for next half an hour. So it can be conveniently used in larger population, elderly population, hepatic impairment, patients with upper GI tract disease, no contraindication, and no need of dose adjustment. So this is the summary. Robust reduction of HbA1c, robust reduction of body weight, systolic blood pressure to the tune of 5 millimeter. lipid parameter improvement, as well as waist circumference improvement. That is why this is going to be a game changer. Thank you very much.
Thank you, Arindam, for a very erudite presentation. You have very well highlighted the promises, big promises that this molecule hold, and we hope the outcome trials will be positive. Only flip side, we are a little apprehensive. I don't know. I mean, the retinopathy that we have seen with injectable semaglutide.
Yes.
Would you like to comment on that?
So injectable
Is there a concern?
semaglutide had some, warning sign of retinopathy, but very interesting. We are discussing on oral semaglutide. If we go across the trials of Pioneer group of trials, there was no safety signal from the point of retinopathy. But yes, more and more evidence we need to look for. Initially, when SGLT2 inhibitor came up, there was risk. People shouted about the bone fracture. So now we see it is not there. So amputation. We don't see patients who are taking now almost every alternate patient in our OPD, they are taking SGLT2 inhibitor. How many patients they come across the amputation and fracture? I don't see that. So yes, we need to see, we need to monitor, but right now we need not be cautious.
I think Arindam has done justice to this particular molecule, and we know that diabetes is no longer considered a disease of the sugar. It is organ protection, which is probably more important along with the glucocentricity. And this is one molecule which is going a long way to take care of the organs, particularly cardiovascular system, and the window of opportunity should not be missed. That is an important point. And as you say, SGLT2 inhibitor, the Canvas trial has shown some amputation, which has been nullified. So we do not know about the retinopathy. We need to look into it for further details. So Arupta, do you have anything to say?
Just a short, Arindam, thank you. Congrats. Good morning. Now, I have just a small question. Diabetes has been renamed as a group of disease, caramel, by Australian authors. It's a cardiac, renal, adiposo-metabolic, and this liver and eye. And he has already spoken about eye. Do you think this drug takes care of all these components? Because caramel has been compared to the sugar boiled as a liquid, sticky, brittle, bad element. Similarly, diabetes was also part of that. Do you think all the components are taken care of?
So taking diabetes mellitus not as a disease of sugar, rather vasculopathy, and take blood sugar or high blood sugar as a marker of the disease, not the basic pathophysiological problem. So if you take from that aspect, there had been research and they found that there are 8 points, ominous octet, which is the basic pathophysiological alteration. Now, this molecule I have shown in my slide, it takes care of the 6 ominous octet component. Rest of the 2, it do not have any effect on the muscle. It do not have any effect on the kidney directly. This molecule is found completely safe in CKD patient. You can prescribe up to very advanced CKD, but it do not have direct effect on the kidney. So majority of the pathophysiological aspect of the type 2 diabetes mellitus is taken care of, excepting direct effect on the kidney and muscle. For that, I suggest to combine this molecule with SGLT2 inhibitor and metformin. So it will be a complete story.
Quick question from Dr. Sahu. Yeah. You want to ask? Dr. Sahu.
This is a very good molecule, as I have heard also in all pioneer group trials, prevention of CP mortality, CV effects. So my query in young obese diabetic, moderate or morbid obesity, those who are coming for diabetes treatment, already on treatment or first time treatment, can we start in new cases as oral semaglutide as the fast drug, and we can combine metformin and other drugs with it? And like in hypertension management, stroke prevention depends upon the achievement of the blood pressure control. Like that, whether this oral semaglutide is going to prevent our cardiovascular complications, either macrovascular or microvascular. Thank you.
So very relevant points. I just briefly take the 2 components. The second component first, stroke is very important because there were some issues with stroke prevention with SGLT2 inhibitor. If we can remember, in some evidence shows that probably there is some numerical increased number of stroke because of hemoconcentration and other factor. So that is not found in across the pioneer group of trial. In fact, there was a robust 5 millimeter blood pressure, systolic blood pressure reduction. So indirectly, we can tell that from reduction of blood pressure, there will be robust reduction of stroke. So stroke, there is no confusion, it will be beneficial. Regarding the uses of this molecule in young individual, if we see the cardiovascular outcome trial, in fact, I mentioned about SOUL trial, the inclusion criteria is age more than 50 years. But why it is so? Because they wanted to see the events. It is not usual to find event in very young individual. So the trials are designed in that way. But in my small practice, also I interacted with other people who are using this molecule, and the evidence in the pioneer other study, you can safely prescribe this molecule in young individual if they're obese. And I also mentioned this point, this disease should be taken care of early. So early initiation, the benefit will be more robust. So no contraindication, you can easily go ahead.
In few patients, young around 30, I had started with 3 milligram. Of course, they came when I found there is a decrease in the blood pressure and decrease in the obesity, 2 kg they told. But in long-term follow-ups, whether they increased to 7 or higher doses, they did not report me with higher doses. But initially, I found certainly there is a benefit. So in the long run, with higher doses,
Okay,
what
thank
is
you,
studied?
Dr. Sahu.
Thank you.
One quick question from Dr. Nath, then we'll close the session. You want to ask? Sure? Okay. Okay, so thank you, Arindam. And on behalf of my co-chair, thank you very much. And thank you, Novo, for supporting this session. So over to the organizers for the next one.
Thank you.
Thank you so much, sir, for your wonderful, enriching words. We'll move on to the next session, gamut of cases, case presenter for CD competition. I would like to invite the chairpersons on the dais kindly. I would like to invite Dr. Monutosh Paja, sir, Dr. A.L. Dotto, sir, Dr. Arup Das Biswas, sir, Dr. Anjul Lal Dotto, sir, Dr. Anando Bagchi, sir, on the stage as chairperson of this particular session. The panelists for this particular session. Also, I would like to invite Dr. B.R. Nath on the dais as a chairperson kindly. As panelist of this particular session, I would like to invite Dr. Shomo Patro, Dr. Raja Nag, Dr. Sanjeev Mukherjee, Dr. Ayon Kaur, Dr. Kuntal Bhattacharya, Dr. Siddhartha Mani. Also, since we are clubbing the two session of this two hall together, so I would also like to invite as chairperson, Dr. Amitabh Bandhopadhyay, Dr. Gautam Banerjee, Dr. Kirti Kumar Bhavishi. Sir. Dr. Shumanto Chatterjee.
Yeah, I'll instruct. So, yeah. So, she will announce. She will announce. And I'm really excited for this session. And Avijit has come all the way from Pune. And thank you for coming. And he wants to present a beautiful case. And this time we have announced the best presenter of CD session will get a ticket to TCT, San Francisco, to and fro, round trip. And so how this session will go? We have few names. The names will be announced. Then where from his coming institutions, the content of the presentations, and presentation itself, like the delivery, finishing in time, and clarity of your presentations. Oyan, you can come. Oyan, you are there. and ultimate debug. So you have 10 marks. Out of 10, how much they get? And if there is a tie, then we'll have again veto power to Dr. Panja, Manutosh Panja. And we can have then discussions before offering the final prize. So we have 2 sessions today and tomorrow, and most probably we'll get the best out of it, and it will be quite educative, and it will be a memory to remember for future generations and future conference. So Dr. Panja has promised me that in his conference, he's going to introduce the same fashion style of presentations involving young graduates, postgraduates. And I'm looking forward for this session. And thank you, sir. I just announced, sir. So 4, you have 1 hour, so you can have a good discussion, sir.
It's 8 plus 2.
8.
Our first,
Plus 2.
our first presenter, Dr.
See, I was going to be on stage.
So presenters are requested to make it sure that you finish your deliberation within 8 minutes. If you cross the time limit, you might lose your points as well.
Might or must.
Oyan, you are one of the panelists. Oyan, where is Oyan? And special commentary from Dr. Dilip Kumar and Arindam.
Yes, chairperson.
One of the presenters. Yes. No, what are event management?
I would like to invite our first presenter,
If we ask for.
Dr. Obhijit Palshekar, our first presenter. Big round of applause, everybody. Total, we have 7 presenters. We are clubbing 2 sessions of 2 halls together.
10 plus 10 এর মধ্যে ফাইনাল রেকর্ড এভারেজ করতে হবে দুটো হেডিং আছে কন্টেন্ট এন্ড প্রেজেন্টেশন না I got your point, but what's the individual mark distribution? So content is 10, presentation is 10, or total is 10, or 5 plus 5.
Arup, total marks is out of 10, you give the right.
No, in the sheet there is no overall, that's why.
I'll make it 15 then. 15, 5, 5, 5. 3 heads, na? Make it 5, 5, 5, 15. Out of 15, you give.
Good morning, everybody. In last 16 years of my practice, I have been looking for a thrombus suction devices, which has to be effective. Many a time we know in intervention, initial days we used to use them very frequently. Then came the time then they went out of flavor. Everybody started using with the GP2 inhibitors, Brilinta coming in. The use of thrombosuction has gone down and it never come to the class 1. A typical story, a guy with infarct, and we see the LED, which is 100% occluded like this. We know this is thrombus only, predominantly, nothing else. RC is normal. PAMI situation, we try to push a wire blindly. We try to balloon. Initial days, we used to put a thrombustor, but everybody know the thrombustor are very stiff to go inside. The caliper is very low. When we aspirate, many times we pass multiple passes. We really don't get the thrombus on this side of the mesh, and we are stuck. And we don't use the thrombus suction. Many times we see the no flow, no reflow, and then we are stuck with giving adenosine, nicorandil, SMP, and everything, and then we are stuck with the myocardial damage. So this is the one new equipment I got. Is the CAT RX, the mechanical thrombectomy device, which is of larger caliber, and it has got constant negative pressure by the machine, and it absorbs the thrombus. Initial days, I started using this thrombuster, the CAT RX, for the pulmonary cases. This I have been using for almost a year now. I treated a lot of pulmonary thromboembolism cases on the oxygen, RV dysfunction, hypoxic, hypotension. I use this and the thrombus clear on the eyesight, and then ultimately patient drastically improve. So I used almost 5-6 CAT RX for the pulmonary initially, and I was actually waiting for this for the coronary indication. So this I did the case, a couple of cases. We can actually see the chunk in the mesh of the machine, which creates the negative suction basically. So this equipment I have found very, very user friendly. The way it passes in the coronary. First one I show going down the LED was very smooth, although you can see the suction lumen is quite big. It can suck a thrombus. And one very interesting mechanism I found against the contrary, we use the thrombustor is what they taught us doing is go proximal to the thrombus. Don't go across as we go with the thrombustor and take multiple runs. Go proximal to the thrombus. Keep that machine in a negative mode. It keeps sucking and suck the thrombus. Once the thrombus is sucked, it goes the continuous blood flow. You can see it is stuck with the thrombus, and with the pressure, it goes away and the free flow starts. Then you go a little further, then suck the thrombus. And this is the way you go down the line so that complete thrombus is taken over. You can see the diameter is 5.3. Obviously, it cannot be used with the guide liner or buddy wire, but then lumen is quite big. And to my surprise, it passes against the mechanical thrombus aspiration. It does smoothly goes across the pulse. And reuse, because I had to reuse for the obviously financial reasons, but the reuse is also equally smooth going in. So this is the new kid on the tech. I found it very good. This is how the engine looks like. It is a negative pressure, almost 30 atm, and it is the continuous negative pressure. Whereas we suck with the syringe, when some fluid comes in the syringe, the pressure drops down, so we cannot maintain that. And the innovative thing is that we have to go to the proximal segment, and this is how engine is there. You put the catheter, connect the catheter. Once the engine is ready, you make the switch on, and then it sucks this thing. As far as the trials are concerned, there are many trials supporting the thrombus suction. Still, it hasn't come to the class 1 indication, but many times we know it is thrombus, and it really helps in our practical this thing. Initially, I use this thrombus suction because it gives sustained suction. The ease it goes below the line is very good. Many times we find difficulty in where this guy is going to be. So this Pumra engine, this is associated with the Sejanan. So you can catch up the Sejanan guy and tell them to get this machine, and looks very promising. I have treated initially pulmonary embolism, massive, like we tried with thrombolytic therapy. You can see this particular diverter which can break the thrombus there. Unfortunately, I had no chance to use it because it was not available. But in pulmonary embolism cases, you can easily go into pulmonary arteries. We go by CT scan, and if we are sure, many times we go like this is the massive thrombus you can see on left pulmonary artery. And the catheter is quite malleable. It is very soft, doesn't harm. And you can see it, I passed in multiple directions. It has got a little bent, and it can very good give thrombus suction. And you can see this has all cleared basically, and multiple runs on multiple branches. Obviously, you can manipulate with a JR or multi-purpose, and you can enter multiple branches. After doing this, I had a chance whereby patient had a MCA infarct. Unfortunately, neurointerventionists were not available. Neuroradiologists were not available. I used this engine on the middle cerebral artery. With little manipulation, of course, we as a cardiologist, we have to learn how to manipulate in the cerebral arteries. They are very delicate. We cannot go very fast. We have to be very slow. Obviously, our technicians are there to hold us back. But this, even with this machine, I could do the mechanical thrombectomy of the middle cellular artery very successfully. Very soft catheter. So probably we can learn when young individual with multiple thrombus burden, we can see we do give Brilinta, we give the 2B3 inhibitors, but this thrombus suction looks very promising because it is very smooth. New thing it has taught me is go from proximal to distal, and runs are very smooth. You keep it very nice, clean, so you can reuse very smoothly. So looks a good kit on the block. Thank you.
Hello. Good morning. Thank you for coming from this all way distance and presenting this nice case. Now, you know, there has been a long debate over thermosuction to do or not to do in ACS. But can you say that this is better than not using this? Definitely, as in case of that after that debate in thermosuction, that thermosuction should not be done, etc., etc. But whether this is better than that, and what is the mechanism of that?
Till now, sir, I mean, ACCH and all guidelines, the thrombus suction hasn't come to class 1 indication. It has always been 2 or something below. But in our practical experience, when we see the angiogram, we know the thrombus burden is high. When we stent, then we end up in a no-flow phenomena. Then it is always better to push a thrombus suction, get it out, and then stent up instead of then regretting like we haven't done the thrombus suction. As compared to the thrombus what we routinely use, they are quite stiff. We know, and after first use, we use with the stillate. Second use, it becomes very difficult. I mean, the use of the thrombustor is very difficult. I mean, you have to always, and maximum what you get is a 7 French thrombustor. This is a much wider lumen and it is really smooth too. You can always experience that. I mean, it's really good.
Babaji, thank you very much. Actually, what is the reason? What is the mechanism of success rate of as well as the maze in Pranamba? Why? What is the mechanism?
Probably we prevent the distal microembolization. That is the mechanism it helps probably. I mean, doing the stent, ballooning and stenting, what we don't see actually, we see the macrolumen, but the microvascular clogging and no flow in that level is prevented. So distal embolization is the one which we are preventing.
Have you done the cerebral embolism?
Pardon, sir?
Cerebral artery embolism.
Yeah, I have done that. Yeah, because I was compelled to. Sorry, I don't go beyond carotids, but I was compelled because nobody is available.
Panelists, any question?
Yeah, it's going to be a very good tool for all of us. We have used it in peripherals and pulmonaries. So there's a kind of confusion regarding thrombosuction in acute STEMI, and there is a recommendation downgraded only for routine use. It's not a selected use. If you see a ostial LED being totally cut off, there's all 100% you should go for a thrombosuction because it will reduce the chances. It's such a large myocardial area. You need to do thrombosuction in these cases. So very rightly said, and since it requires a little higher French guiding catheter, isn't it? It goes in 7 French.
Yeah.
6 French also
French
it can
is
go. 6
compatible.
French also is compatible. So it's really going to be a wonderful device.
Yeah, but as a rule, I mean, when we use the aux material, I mean the reuse material, we go for a 1 French higher so that it doesn't give the friction.
One more comment. See, the entire problem started with total trial results, and they showed a very high chance of stroke, 6% high as compared to the control arm. Have we seen stroke in our cases?
Not really, sir.
Not really.
No, not really.
So it's all because how they do it. A fellow, a second year, third year fellow who is doing a intervention in Europe, they are going without a negative negative suction, and they're coming out. They're releasing that suction. This is leading to stroke. It's not the other way around. If you continue suction till you take out the catheter, nothing happens. In my 15-18 years of career, I have not seen a single stroke with thrombosis.
Yeah, even I haven't seen.
So entire
the thing is that, I mean, when we take out the thrombustor, many times we need to bleed the wall, right? Something is there in the catheter. We don't take it out and we push the dye. It is going to embolize.
Okay.
So another very important point. This is wonderful. Whatever small experience I have. So one of the very beautiful mechanism, whenever it goes towards a thrombus, it starts sucking. When there is no thrombus, it do not suck. So very wonderful mechanism of action by which blood loss is also limited. So
Actually, one AI tool is under their patency for this Pumra. This is a US company that has got a detector whether there is a thrombus or free flow of the blood. So it will, what will happen is there is thrombus, it will activate the engine. When there is free flow, it will stop the engine. So blood loss is low. So probably another year or so.
That one of the very important difference compared to our conventional previous tools. So by that we can reduce the blood loss and effectively remove the thrombus only.
Okay, thank you. Time is.
Just a minute. The most important thing of successful thumb suction is, apart from the devices, the time factor is very important.
Absolutely.
If you have STEMI within 2 to 3 hours, we'll find there is no thrombus. It's just like butter, like soft. The more the time goes, more it becomes organized.
Resistance.
So that is an important issue as well.
Okay, thank you very much. You know the next one.
Thank you so much. Inviting our next presenter on the stage, Dr. Moinak Mukherjee. Big round of applause.
Stroke issue, really, we should do some of our study, Dilip. We have really not seen any patient who has embolized clot from ear to brain. It surprised me. Yeah, we are doing for a long time. Probably. Yes.
Okay, so good morning, everyone. I'm really grateful to the organizer for providing me the opportunity to present my case in front of this august audience. So I'm going to present this case. I have named it as a nailing the ostium. I have nothing to disclose. My patient is a 53-year-old non-diabetic, non-hypertensive smoker with a history of drug refractory effort angina. His clinical evaluation was apparently non-contributory, whereas ECG showed some T inversion in precordial leads, and echocardiography revealed no RWMA with a preserved ejection fraction with a grade 2 diastolic dysfunction. And subsequently, I went for a coronary angio that revealed the critical Lippmann osteal disease that I'm going to show. And because of some consent-related issues, he was deferred revascularization after 1 week. So this is the left system. You can well appreciate over here the critical stenosis of the Lippmann ostium. And here is the right system. Apart from an intermediate disease in the PLV branch, there is nothing that significant. So 8 days after, he was readmitted for IVUS guided Lippmann osteal PCI. And I went for a 7 French gel guide femoral route. And I crossed the lesion with a run through floppy and pre-dilated the lesion with a 2.5 into 12, followed by 3 into 12, and then followed by 3.5 into 8 millimeter NC balloon, even as much high pressure as possible. But unfortunately, even after the 3.5 into 8 NC with a high pressure, I couldn't find that the Lippmann ostium could yield that much to my satisfaction. At that point, I went for the IVUS pre-run. It was an LED Lippmann IVUS with an OptiCross 3 French into 135 centimeter run. It is a 40 hertz IVUS system. And here you can see, this is from the mid of the LED. That's the diagonal coming in, and some amount of the concentric plaque we can see over here. This zone, the plaque burden is not that significant. This is quite an healthy zone. Now here comes the predominant fibroflatty plaque. The calcium is not that much of any significance. There's quite a significant plaque burden. There's a proximal LED. Now the LCX is coming into view. LCX ostium is not that diseased. but the LAD ostium is very much tight and critical. This is the left main distal and shaft. You can appreciate the side wear over here around 9 o'clock. Now, this is the LM ostium. It's quite a plague burden for sure. So this is the pre-run mathematics that I've simplified in this way, that the LM maximum diameter was around 4.7, but the internal luminal minimal area or the diameter was around 2.8 millimeter. Whereas the LAD is predominantly 4 millimeter maximum vessel size, and the ostium was around 2 millimeter and the proximal was around 2.7 millimeter. And the left main distal part is around 4.5 millimeter maximum size diameter vessel, and the inner diameter was around 3.6 millimeter. So I thought of taking the Wolverine ballooning. It was around 3.5 into 10 millimeter Wolverine cutting balloon, and I inflated it up to around 10 atmosphere of pressure. And after the Wolverine ballooning, I think there is the area looks a little bit better. So then I went for a 3.5 into 38 millimeter onyx. I took onyx because I will have to blow it up to around 4.5 for the 3.5 millimeter stent. And I did the ostial flaring also. And then subsequently, I post-dilated the LAD part with 3.5 into 12 and post-dilated the LM with 4.5 into 8. And this is the post-run IVUS. I've got a images snapshot for the sake of time. I'm just skipping it. And after the post-run analysis, what I found that I could achieve around 4.5 millimeter of left main ostial diameter with an area of around 14.5 millimeter square. And in LM distal, I could achieve up to 4.1 millimeter with an area of around 11.7 millimeter square. And in LAD osteoproximal, I could achieve of around 3.5 millimeter with an area of around 8.2 millimeter square. And in LAD proximal, I could achieve around 3.5 millimeter with an area of around 8.8 millimeter square. So as a whole, the result was quite satisfactory. This is the end result. So the post-operative follow-up is excellent and the patient is completely symptom-free. So ostium LM intervention, the definition that any lesion within the 3 millimeter of the ostium, that there are quite 3 important problems: high calcium and fibrous content, higher recoil, and higher neointimal hyperplasia. There are the 8 challenges that we take care of when we deal with any ostial LM intervention, like vasospasm. We'll have to exclude that I excluded during the angiography. Poor guide support and coaxiality. Then ischemia due to pressure dampening, aorto-ostial dissection, Milan seeding, risk of dislodgement, geographic miss, and stent deformation. So my take-home message from this case would be LM ostial intervention is always very challenging. Proper planning is extremely essential. Intracoronary imaging is practically mandatory in LM PCI, and we should always be very vigilant about the distal catheter tip and the proximal stent trot. And unless there is a financial issue, it is always better to take care of the area with the help of some plaque modifying gadgets like cutting balloon and others. Thank you.
Presentation. Can you hear me?
Yes, sir.
Okay. What is your message to the audience regarding 2 things? One is the selection of the imaging process in different LMCA position. I mean, comparison between IVUS and OCT. In which position what? Another is, what is your guide catheter positioning? After you have engaged the wire, how do you handle with the guide catheter? These 2 messages has to be given to the audience.
Okay. Whenever we're dealing with the ostium, it is always better to go with the IVUS, because with OCT, we will have to make it blood free, which is always a little bit difficult. And if there is any significant calcium burden not within the ostium in the other part of the LM, then probably OCT will play better than the IVUS. But with the advent of the 60 Hertz IVUS, I think we are getting quite a nice picture, even to some extent equivalent to OCT. And regarding the calcium scoring, although I was lucky that in my patient, I was not having that much calcium, but had there been any amount of calcium, again, I was also having a calcium score only on IVUS basis also, like on the basis of the OCT too. And regarding the guide cat that you have told that, yes, sir, that whenever we are removing the jailed wire or whenever we are dealing with taking out of the balloon or taking inside the balloon, many a times we are bound to use some Oxford materials. Then we'll have to manipulate the guide accordingly so that it doesn't hit the proximal part of the stain strut. Just manipulation with the left hand regarding some traction extra on the guide. But I will again also have to be taken care of that it doesn't get dislodged also.
What measure you have taken to prevent the blocking of the ostium by guiding catheter?
Okay, I just kept everything just outside the ostium. I didn't deep intubate it, and I just kept just around the ostium. And even if you can see that the last shots when I took the shot from outside the ostium. I didn't again go inside.
That's okay, but sometimes somebody use the wire in the aorta, just prevent the.
Yeah, we can keep one wire in the sinus, but again, it can be done. But in this case, I couldn't found any that
You have
much
not
of pressure.
taken any measurement.
Yeah, that can be done.
Do you think a surgical backup is necessary during left main ostial intervention? Number one. Number two, how do you plan to follow up cases after left main intervention?
Surgical backup is always advantageous. And in our institute, we are always having a very good CTVS team. But honestly speaking, over last 4 years, we have done quite a number of left main. In none of the cases, we needed any surgical backup. But still, it is always better to have a surgical backup on emergency basis. And regarding follow-up, what I feel, if the patient remains asymptomatic with a good quality of life, no other symptom, then I will never go for any check angiography at all.
Can I ask one question? Thank you. Suppose you have a budget issue and you have to use either Wolverine or IVAS. I don't know how much is your hospital charges. Usually Wolverine cost around 60,000. Now other cutting balloon, other plaque modified balloon, they are cheaper. Now if you have to choose between a IVAS in this case or a cutting balloon, which one you are going to choose?
In day-to-day practice, honestly speaking, in 90% of the patients, we do feel this budget issue. So we do take care in some other ways, but in practical point of view, I will keep IVAS as the first preference, because all the left main interventions, the ultimate outcome depends upon the proper sizing of the vessels and others, and IVAS will give me that picture. So my pick will always be IVAS first. I need an IVAS.
So OCT is not going to give that much clarity. With higher density IVAS coming in, it's always better to use IVAS in left main intervention.
Yes, sir.
OCT is proximal left main, not done usually.
Yes, yes.
I would request the audience to ask questions related to the competition.
I have one question. Suppose you are working in a periphery and you don't have the luxury of using any imaging. So how would you go about the lesion looking at the angiogram? Because I have seen you have used only NC balloon before imaging, and after imaging you have used a cutting balloon or Wolverine.
I will not do any left main intervention without imaging. I never do.
But we have been doing that because I have started intervention before IVAS was available. So I would do it, definitely do it without imaging also, but with a cutting balloon, of course.
Just a small comment. Yes, always better not to do intervention, particularly left main intervention without IVAS. But in fluoroscopy also, you have some markers. Say, for example, if you see a tram track calcification or a calcification which is persistent even after stopping the fluoro image. So in still image, if you can see calcification, these are the two marker which suggest that the calcification load is very, very significant and you need to do something about the calcium, and IVAS or OCT is mandatory. Otherwise, if you don't see that, this kind of straightforward ostial or simple left main, probably you can do without imaging as well. Without imaging, because data says some country they use more than 90%. Country, very advanced country like US,
it is only 30%. So you can still go ahead. I think so.
One thing I would like to add here, that even if there is no calcium, because of from developmental point of view, the development of left main and the LAD osteoproximal smooth muscle cell is completely different. They are having more mesodermal tissue. So we always need a higher pressure. And most of the times I will always keep in mind regarding this cutting balloon used in here. And even if there is no that much amount of calcium.
Last question, Ayankar, anything? Yes, panelist, Dr. Ayankar. Okay.
You are going to ask the presenter about questions which is related to the competition.
LMCA, osteal LMCA, one sinus OR is essential. I have used without imaging LMCA osteal cases, but for mid segment and distal LMCA, without imaging, one should not go for that is my message. Thank you.
Thank you.
Okay, time is over. Thank you very much indeed.
How many presenters we have?
Another two. Another two.
Inviting the next presenter on the dais, Dr. Saurabh Dash.
We still have 7 more presenters to the 7 more.
No, only 4.
Five more presenters. So take care. Make sure that you don't spend so much time asking questions.
Saurabh, you have to present them within 8 minutes, okay? I will discuss 8 minutes and 2 minutes.
There is an announcement, the program ongoing in the next hall also. So the organizers are requesting, if somebody is willing, they can join there. Otherwise, there is dark top, but audience opinion is there.
না ফুল স্ক্রিন এখানে স্লাইড শো দিয়ে
Next presenter নাম কি গো?
কেটে দিচ্ছি Hello, this কোন mic use করব, this or this? Okay. So good morning everyone, and my respected teachers, as most of them have taught me over here, my respected senior colleagues and my batchmates, few of them are there in this room. It's a great opportunity for me to present this case over here in front of all the stalwarts of cardiology. So without much delay, I'll present my case. This was, I have given the heading as it was a frightening experience in the cath lab, which was created and tackled in a normal coronary artery. To start with, this was a 69-year-old female, diabetic and hypertensive. If there was a history of CA breast. So we got a call from the onco department, and when we went, it was an effort angina, CCA SNIA function class 3. ECG, there was not much dynamic changes. It was a non-specific STT changes noted in V4 to V6. We advised for echo. There was no regional wall motion abnormality. LV ejection fraction was 60%, and there was a grade 1 diastolic dysfunction. And we thought we took a call that we'll take this patient for a diagnostic angiogram. For diagnostic, we use the right radial 5 French sheath and a 5-take catheter. Just I'll tell something about it. One of my DNB resident, and he told Dada, I will take the puncture. So I told, no, since she's a female patient and she might go into spasm. So let me take the puncture. I'll allow you to do the angiogram. So the puncture was taken and he hook the TIG catheter. He was unable to hook the left system. So I told him, you do it in the, do the right first. Usually I adopt the 30 LAO angulation. LAO, I always prefer to engage the catheter in LAO because it always coaxially engages with the ostia, coronary ostia. So, but he was doing in AP view. Okay, I just I wanted that. Okay, if he's comfortable with that, he can go. So this was the angio. This was the angio. He took the shot, and this was the angio. And I was like, when I could I could make some apprehension that something is going very wrong. So I immediately told him to get aside and took the catheter, took the TIG. When I took the shot, this was it. Almost, if you see the previous slide, this one, this was a normal right coronary artery, and there was some staining of the dye in the osteoproximal end. The subsequent angio when I did, complete occlusion of the RCA from the ostial end, complete occlusion. I was jittery, perplexed, tensed. I told why I gave him. All kinds of thoughts were coming. Patient started deteriorating. I couldn't forgive myself. But yes, I hold on to my nerves. I told, no, we have to do something to rescue this patient. We cannot, a normal coronary angiogram or a normal RCA cannot lead to the death of a patient. The patient had severe chest pain radiating to the back, hypotension, systolic blood pressure went to 50. Bradycardia, there was ST elevation on the surface ECG. Now what to do next? So if you see the type of coronary dissection, and this was type F. There was a dissection with total occlusion of the coronary lumen and no distal antegrade flow was there. So we took the patient in for rescue PTCA to RCA, and my situation was like this. I was literally like this, not feeling good, but still we have to keep our courage and go and do this case and rescue the patient. So hardware, we changed the sheath, radial sheath, say 5 French to 6 French. We took a right femoral venous axis for a backup of TPI. And I also took the right femoral artery puncture so that I can later on see the left system. But the main aim was to wire the RCA and restore the flow. So we used a 6-French JR guiding catheter. Ostial RCA flap was attempted first with Sion blue. That is the dictum when you are entering, when the choice of wire in a dissection flap is always a non-hydrophilic wire, because you don't know what is the extension of the dissection. So it is better to go with a non-hydrophilic wire first. So we first tried with run through floppy and Sion blue. We made several attempts, almost 20 minutes. The best part was that she was holding her heart rate. The heart rate picked up to 63, 64, but the blood pressure was constantly low. We gave NORAD support. We called our cardiac anesthesia backup team. Even we were ready to intubate the patient. Then this is what we are attempting. We are trying to negotiate. We took a Sion blue. We are trying to negotiate the flap, come across it, but But every time we were trying, the Sion wire was going into the coronary, into the coronal branch. So we tried all our best to just negotiate and cross over the proximal flap and get into the true lumen, but that was not possible. And later on, I'll just forward it a bit. Let it go. So you can see we are going into, you'll just see we will be going into the coronal branch. Okay, I'll have to forward this. Okay. So run through, we use the run through to wire. Next attempt was to, we took run through floppy wire. We tried to negotiate across the flap, was same result. We could enter into the coronal branch. But what you can see over here, once we are putting the wire into the coronal branch, and we took a scout, a very low force scout we took, just to see what is the extension of the dissection. That's why we were quite apprehensive in taking in these wire in the first go. Oh, we saw that when the wire is going to the coronal branch, a certain segment of the proximal part of the flap was being crossed, and that was helping in the dye to flow across it. So this was quite evident. There was a lot of evidence was there that there was no distal extension of this flap. So next we thought that let us give a try with a Fielder FC with a good tip load. So we tried with Fielder FC. So our main aim is to again try and negotiate across the flap. Same thing was happening. We entered into the coronal branch, and we were not able to enter into the true lumen, and somehow we came down, flapped in and we tried to enter the true lumen. So this is how we did. You see, it's coming up, coming down, and we try to negotiate it across the flap. Yeah. So what we did, we went across the right marginal RV branch. So we knew that we are in the true lumen. When it was going into the side branch, we knew that we are in the true lumen. We came back with the wire, and then we entered into the, after 30 minutes of this 30 minutes was, it was a complete nightmare for us. So we went into the RCA, and after that it was a big relief for us. Then we decided the patient was hemodynamic stable. So we decided, let us go with the left-sided angiogram. So we took through the right femoral artery. We kept the left system
So this was the result. After which we decided to go for an IVAS run. LAD to LM pullback was only done. And this showed that there was good stent expansion all throughout. The mid LAD segment, especially where there was overlap between two stents, required some amount of further post dilatation. The prox LAD was nicely dilated, and the LMCA, the stent expansion was very good. We achieved a very good area. However, we could do a bit more of apposition, as is evident in the picture. So with this informations, we dilated the mid LAD segment further with a 3 millimeter balloon. We went at higher pressures and a 3.5 millimeter balloon in the proximal to mid segment in the overlap zone. And we took a 4.5 into 6 NC balloon and did a dilatation of the LM up to the ostium. So this was the final picture. As expected, the chest pain got relieved. It had got relieved as soon as we had dilated the and stented the LAD. Patient was hemodynamically stable, was doing well. He was shifted to ICU and discharged after 2 days of observation. So we may conclude that ECG may not reveal significant findings in NSTEMI or NST-SES. Nature of symptoms and clinical suspicion always important. In a case like this with dextrocardia, with malposition of the heart and the arteries, simple adjustment in console setting helped us in the ease of imaging and taking good angles. Searching for the best angles in this type of case for optimal assessment of bifurcation angles and osteal disease severity is a must. And decision for dedicated two-stent approach was taken, keeping in mind the side branch was a good sized vessel covering a large area of myocardium, and it was 80% disease at the ostium. And imaging should always be encouraged, especially if there is left main involvement. Thank you.
Saurabh, thank you and congratulations for the beautiful result that you obtained. But I have a comment regarding the sorry. Basho, I'm extremely sorry.
No,
so, Shuman, I apologize to you also because he is your disciple. Now, overall, the results have been very good. Now, you had a knowledge that you are dealing with dextrocardia. So why didn't you go for image inversion from the very beginning rather than wasting some contrast?
So
because contrast, ultimately you find that a lot of contrast was required. This was a complex procedure. And you know, in anatomically, pivotal arrest may not be complete. So there could be different angulations, etc.
Yes, sir.
And you had to have devised special angulations for us. So why didn't you go for the image inversion from the very beginning?
So we confirmed dextrocardia from ECG and echo, but we were not sure about the position of the origin of the coronaries. So that information we did not have. So we first decided to
in mirror image dextrocardia, why do you think this was the coronaries were not usual thing as is found in dextrocardia?
Yeah, so that should be the case in most of the patients, but we could also see the coronaries clearly. There was some amount of calcium and we could visualize in the fluoro. So we decided to just take 2 shots to actually get what is the actual position of the arteries. And from that, we can, with that idea, we can get to better angles. Then much time was not wasted. We made sure that we do not waste the dye. So we took only 3 shots with 5 ml each. So 15 ml of extra dye was used.
What is the difference between nano crush and mini crush? Number 1. Number 2, why did you not choose decay crush?
So in mini crush, with the stent in position in the main branch, we actually try to pull the side branch stent into the main branch, and how much stent we should pull back, that we decide upon with the fluoroscopy images. And in many of the cases, we tend to find that there is too much stent in the main branch, which after crushing leads to a high metal burden in the main branch. And mini crush actually, nano crush actually with the balloon inflated in the across the main branch, it prevents excess pulling back of the or excess encroaching of the main branch with the side branch stent metal burden, which we have found. And also as the carina which is formed subsequently has is very well formed, it is very easy to recross the side branch in almost all of the cases. Which is not so in mini crush. In some of the cases we get stuck.
Why you use the scoring balloon rather than the valvuline?
In scoring balloon, we had to modify the plaque adequately. In LAD ostium also we would have used scoring balloon if we had found that it was not adequately dilated, but with NC balloon dilatation it was adequately dilated. But for LCX ostium, the angle was, we never know what is the actual angle of the LCX. So we straightforward went with a scoring balloon so that we can achieve good expansion, because often in the later stages we tend to neglect the LCX ostium, and we are not sure whether post dilatation would be sufficient, whether we would be able to do a good imaging. So upfront good dilatation of the LCX is a very good decision.
Yeah, last question and answer also. Dr. Dasbishas asked you about the imaging. So I think you learned from Dronacharya in this case two things. One is how to transform the image from dextrocardia to levocardia. And the other thing that he didn't use imaging upfront because he was calculating the Finnett's law on the background. If I am right, Dronacharya?
Last comment ছিল যেটা শুভানন্দ হাসলো
Finnett's law, sizing of the stents.
Sir, one question, what was it is a typical angina or atypical angina? In 2014, I had done one dextrocardia lady of 52 years who presented right-sided chest pain. Of course, it was an ostial LAD. I could do it initially reversing the image, which you did afterwards. And DK cross, I think, would have been a better in this case.
There is no, head-to-head trial between DK crush and nano crush. But we have published our data, and there are so many data coming out with nano crush, it is equally beneficial. So because we do not have a lot of data, we cannot say that this is better or that is better. But I can tell you as a technique, nano crush is much user friendly and you can do it in any place.
Actually, DK crush should be limited to the experience intervention. Just a minute.
Mini crush, nano crush. We are now started doing nano crush. Initially, we focused more on mini crush. So please, because many newcomers are there.
Yeah, this is, even we have seen this. You have not seen
before Subhanand speaks, I think as Arindam has raised this issue, I should mention that Subhanand has got special interest in this topic. He has been doing it for a long time. And in fact, at international level, he has been a proponent of nano crush.
Anyhow, the DK crush to be limited experience persons and limited centers with a huge experience of the DK crush. Second thing, and selected patient, DK crush to be selected.
No,
otherwise,
why we prefer nano crush? There are 2-3 important points, which is very domestic. Now, first of all, I don't know how many of you, do DK crush. In DK crush, at least you need 3 to 4 new balloons. I can tell you that. Do you agree with me? Yeah. Also, and in nano crush, you start nano crush and you will just see that you need just 1 or 2 balloons. At least it is half. No, not at all. We have seen it by microcity. We have proved it by bench test, and that has been published. And so basically when it is an easier process, less cumbersome, not having a lot of difficulties, why not? And point is mini crush, why not mini crush, and why nano crush? In mini crush, you put the 2 stents by your eye estimation. In a very narrow angle, you will have more stent in the main branch, and in a wide and obtuse angle, you will miss the ostium.
That is with nano crush. I mean, that is with mini crush. But with nano crush, when you are putting a balloon in and pulling the stent across the balloon, you are coming inside the main branch, but in a very small.
That's only nano crush, that the protrusion of the side branch stent, usually 1 to 2, that should be limited. That is only advantage.
Absolutely.
That should be small.
Absolutely.
Okay, thank you very much. Excellent presentation. Now,
In fact, many of us, before we came across the names like DK, Nano, Mini, conveniently did the same procedure for bifurcation lesions without knowing the names. Dr. Panja, our senior most judges here. Yeah, you can, or Tuli goes at Tuli.
And about the marks to the organizer.
So it has been a very nice session and the young boys and girls did so well that we are semi-mesmerized, not totally, but we have been doing justice to impart our knowledge and expertise to imparting marks. Let's have a total and averaging, then we'll declare with the results. So it is handed over to the organizers. Hey, তোমরা ইয়ে করো, সময়টা কি করে করবে? ইনঅগ্রেশনে চলে যাবে না রেজাল্ট আগে ডিক্লেয়ার করবে?
Okay, session is over and the result will come later on. Okay. Other session in there, so they'll take the decision later.
কে ফাইনাল কম্পাইলেশন রেজাল্টটা কে করছে?
আপনারা 5 জন বসে একদম পুরো আলাদা একটা ঘরে বসে ততক্ষণে আপনারা
তাহলে তো আমরা ইনঅগ্রেশন মিস করবো।
ইনগ্রেশনটা হয়ে গেলে
তোমার লোকজন নেই?
না,
তার কারণ আমি এটা ইস্যুটা এই জন্য বলছি, কেউ 10-এ মার্কিং করেছে, কেউ 15-এ মার্কিং করেছে, কেউ 30-এ মার্কিং করেছে, ওইটাকে ইকুয়েট করতে হবে।
কিন্তু প্রকাশ তো বলে দিল 15 মার্কিং করতে।
ইনগ্রেশনটা হয়ে গিয়ে
Thank you so much. We end the session over here and requesting all the dignitaries, doctors to please stay back and join us over here in this hall for the inauguration ceremony. We will be starting the inauguration ceremony of Eiicon 2023. Requesting all of you to please join us for the inauguration ceremony of Eiicon 2023. Well, time for inaugurating this grand conference, Eiicon 2023. I would like to invite on stage Dr. Soumitra Kumar, President of CSI West Bengal branch. Can we have a big round of applause, everybody? I would like to invite on stage Dr. Monotosh Paja. I would like to invite on stage Dr. Anjan Lal Dotto, inviting all respected doctors on stage for the inauguration ceremony. Like to invite on stage Dr. Monotosh Paja, sir. I would like to invite on stage Dr. Anjan Lal Dotto, sir. Kindly come up on the dais for inauguration. I would like to invite on stage Dr. Arup Das Biswas, sir. I would like to invite on stage Dr. Shuni Banerjee, Honorable Secretary of CSI West Bengal branch. Sir, kindly come on the stage. I will request all others to please continue your round of applause because we are here at the inaugural ceremony. I would like to invite on stage Dr. Arunangshu Ganguly, Course Coordinator of Eiicon 2023. Sir, kindly come on the dais, please, sir. I would like to invite on stage Dr. Prakash Hajra, Organizing Secretary of Eiicon 2023. Sir, if you kindly come on the dais. I would like to invite on stage Dr. B.P. Pandey, Scientific Chairperson of Eiicon 2023, sir. If you kindly come on the dais, sir. I would like to invite Dr. Prakash Hajra, sir, Organizing Secretary of Eiicon 2023. Probably. Okay, so now I would request Dr. Soumitra Kumar, sir, President of CSI Branch, West Bengal Branch, sir, to please start the inauguration. Thank you.
A very good morning and greetings from CSI West Bengal Branch. We are in our second conference of the year after a very successful first conference, CSI Prevent. And talking about CSI Prevent, I very sadly miss Dr. Raja Rai, the organizing secretary. We are extremely shocked by the great disaster that is befallen him and his family. May God give them the strength to bear with this. But as they say, the show must go on. So the conference will go on, and the academic extravaganza that has been arranged for all of us, I think it is going to be a great learning experience for all of us. So kudos to Dr. B.P. Pandey, Dr. Prakash Hajra, and the entire organizing team. We are looking forward to a great conference. So robotic PCI, laser PCI, a training village with a live bovine heart, robotrips, the combination of lithotripsy procedures with the balloons, live procedures, combination with orbital atherectomy, everything has been planned at the training village. There are going to be 20 live transmissions, as I can learn. And the case presentations are going to be rewarded with a ticket to and fro to TCT 2023. So all this is awaiting us. But above everything, I think everything will happen in the atmosphere of the great bonhomie that has been the soul and character of CSI West Bengal Branch. So after the COVID saga of last 2-3 years, I think it is here again, time for us to meet all our old friends and colleagues and have a great, enjoyable and learning experience today and tomorrow. So with that, I invite all the dignitaries present on the dais to please participate in the lamp lighting ceremony. Please take a step down to be there and have the lamp lighting. Thereafter, I will request each one of the dignitaries in the order that is announced by the MC to say a brief word of, welcome to all the audience members present. So please, let us have the lamp lighting. Sir, apni cholna.
Yes,
Apni.
We'll request all the dignitaries to please join for the lamp lighting ceremony of Eiicon 2023. Indeed, a beautiful moment. Can we have a big round of applause? So we marked the wonderful, memorable inauguration of EIICon 2023. Thank you so much to all the respected doctors, dignitaries. Requesting to please come back on the dais. Requesting to please come back on the dais, please. I would now
Shubhro, would you please join us here?
I would now like to request Dr. Arup Das Biswas, sir, Reception Committee Chairperson, sir, to please share a few words with us for the inaugural ceremony.
Not the printed one, but what is in the software, you'll find there have been many innovations in this program. As Soumitra was talking about, we have had in our plan from the West Bengal branch that we'll be holding 4 programs. We have started with cardiac prevent, we are doing this, we'll be going to cardiac imaging, and we are trying to do our best with each and every scientific program to give something new to you, not that old things getting repeated. And this time, Vijay and Prakash, they have given a hard labor to introduce certain new things, and you will be in these 2 days finding that. Personally, for me, I have been doing little for this conference. I was traveling abroad, but I've got my great respect to my junior brothers and think whatever feat they have done, you will enjoy that. With these words, I end my talk.
Thank you so much, sir. I would now like to invite Dr. Monotosh Paja, sir, to please share a few words with us.
So, respected President, Secretary of our West Bengal branch, CSI, I observe this program is fantastic. Only it's very difficult to finish in time, so much crowding in the program. And I believe all the speakers will restrict the talk within few minutes, within the restricted time. So I think there will be great success of the conference. So thank you very much. And I congratulate especially to particularly the B.B. Pandey and the chairman and Secretary Dr. Hajra and Mr. Ganguly and all members of the EC of CSI. Thank you very much indeed.
Thank you so much, sir. I would now like to invite Dr. Anjan Lal Dotto, sir, to please share a few words with us.
Friends, ladies and gentlemen, as a past president of the West Bengal branch of the CSI, I take it as an important issue for me to welcome you all and the tremendous hard work that the organizers have done to make this program dynamic, successful, and scientific, that we should especially thank all of these organizers. One important thing that we should remember that Cardiological Society of India was born in Kolkata, 1947. Cardiological Society of West Bengal branch was always in the forefront for the further development of Cardiological Society or its conferences. We are having the All India Conference of CSI this time in Kolkata, and I request all of you present here and those who are attached to the Cardiological Society of India as a West Bengal branch or as branch from other states to come forward, take active part and make this incoming Cardiological Society of India's conference a grand success. Thank you very much.
Thank you so much, sir. I would now like to request Dr. Shuni Banerjee, sir, to please share your valuable words with us.
I should take less than 1 minute just to say something different. Thanks, dignitaries in the dais and in the audience. This is the 12th year of Eiicon, that is the Eastern India Intervention Cardiology Conclave, and which has been a brainchild of Cardiological Society of India, West Bengal branch. So 12th year I came to know from our old office bearer, Mr. Roy. So, and also I can remember in the first conference, I was happy to be a part of as organizing secretary, and our great Shuvanand Rai was the scientific chairman. And at that time also we thought of some live in box cases, and probably this is going too fast, 12 years now. So all the great success. Thanks Prakash and Vijay for having these things. And we expect more people, more young blood to come, and please join and carry forward. Thank you.
Thank you so much, sir. I would now like to request Dr. Arunangshu Ganguly, sir, to please share a few words with us.
Well, intervention is the core of cardiology. Somehow or other, it was a perspective in the whole country that East lags behind. When I came back from Delhi to start here, in Delhi, I used to hear a lot about East lagging behind. I met here the connoisseurs, the beginners of intervention cardiology, all of them on the dais, Professor Manutosh Panja, Dr. Anjalal Lotto, off the dais, Dr. Shuvanand Roy. They were doing splendid job at that time. Then we realized that it's perhaps a handful of them are doing it, so it should go. The young generation has come up, and now you see interventions everywhere in the whole of East. This is very heartening on the way of this Eiicon journey in the last 12 years. I had been the organizing secretary in the 3rd Eiicon or 4th Eiicon. At that time also, the main thought process was to give everybody the perspective that we are doing as well as what is going on in the world. This time, Prakash and Vijay has done a superb job introducing many new things, giving chairs to almost all the junior operators who are operating. They should come up and carry the baton. One interesting thing this time, the virtual platform, you must all share with your friends. You can see the whole conference on the virtual platform in the YouTube, and that's a splendid add-on this time. Thanks, Prakash, and thanks, Vijay, for this wonderful effort. Thank you all.
Thank you so much, sir, for your valuable words. I would now like to invite Dr. Shubhro Banerjee, Vice President of CSI West Bengal, sir. Please.
Good morning, everyone. I would like to keep it very short. More than 700 registrations, virtual and real platforms for showing cases, live inbox, just you name it, national, international faculties, things can't be better. And kudos to Dr. Prakash Hajara and Dr. Vijay Pandey. Really, you have done a good job.
Thank you so much, sir. I would now like to invite Dr. B.P. Pandey, sir, to share his words, also place a vote of thanks.
So thank you. It was an immense task to organize a scientific program because of the, as Dr. Panja said, we have to accommodate many things. But my motto was, as Arunangshu said, we have to go local rather than going all the way. So out of 20 live cases, 18 are being transmitted from the Kolkata itself and all the local operators. And before going to the intervention, my task was to let you, all the delegates, particularly the younger cardiologists, know what are the algorithm which leads to the intervention. So you see a lot of program related to the algorithm ultimately will culminate into the intervention. So that was the main motto. Along with we have got several robotic PCIs, some virtual reality cases you will see, particularly from the surgical field also. We have the bovine hurt. So a lot of program which has been introduced this year. It could not have been possible with the mentor's role. Our president, treasurer, and course coordinator, Dr. Arunanshu Ganguly, of course, with all the blessings of my senior teachers on the dais and in the podium. So I'll stop it here and will request all of you to join for the next 1.5 days. Thank you.
Thank you so much, sir. Thank you so much. We end the inaugural ceremony over here and we'll continue with the session right after this. Thank you so much, all the respected doctors and all other dignitaries present over here. We move on to the next session. We'll be merging the next two sessions together. As chairpersons, I would like to invite Dr. Shivananda Datta, Dr. Alok Majumdar, Dr. Kanak Mitra, Dr. P.K. Jha, Dr. Chandra Kumar Das, also Dr. Amitava Bandhopadhyay, Dr. Gautam Banerjee, Dr. Kirti Kumar Bhavishi. As chairpersons, as we are clubbing both the sessions together. Moderator, I would like to invite Dr. Rituparno Barua. I would like to invite Dr. Shubhro Aditya, Dr. Bapaditya Kumar, Dr. Shubhro Banerjee, Dr. Anil Mishra, Dr. Arindam Pandey, Dr. Arijit Ghosh, Dr. Shumanto Chatterjee, Dr. Bapaditya Kumar, also Dr. Arindam Maitra, Dr. Abhishek Shah. We will start with a case-based know-how on ROTA, and I would like to invite Dr. Dilip Kumar, sir, for his presentation.
Yeah, I think the first speaker. Now, who's the first speaker? Yeah. Oh, it's Dr. Dilip Kumar is the first speaker and case-based know-how on ROTA. Could I request Dr. Anil Mishra to be on the dais, please?
Yeah, let me do full screen. So good morning, everyone. So my topic is ROTA ablation case-based discussions. So of late, we have been seeing calcium, recognizing calcium, kind of calcium, but there inside the coronary artery and dealing with that. And we are enhancing and, bettering our performance. So this was a case when I was doing an acute intraval MI STEMI, and nothing was going in after 1.5 millimeter balloon. And to our surprise, this patient had a very severely calcified lesion, and I had to take ROTA ablation in acute intraval MI. So whichever case you are doing, you can't avoid these kind of gadgets, and to be familiar with these gadgets, you have to see cases, do cases, and then perform cases. And finally, you can give outcome like this. So this patient was okay in 24 hours. We discharged the patient. So let's go around the algorithm of calcium, how we detect it. So we have got scoring algorithms now, OCT based and IVUS based. And what we see is the arc of the calcium, the length of the calcium, the thickness of the calcium, and the vessel size, which we see in IVUS. And we get a calcium score and we decide our strategies. But this is also very important, what kind of, the calcium distribution patterns are. So this is basically a very superficial calcium and concentric calcium. This is very well treated by root ablation. This calcium, the second one, is deep calcium, although concentric. So this rota bar is not going to touch this calcium. So no way you can perform rota in these cases. IVL is a method of choice. Similarly, when there is eccentric calcium, which is superficial, be it a calcific nodule, it's well treated with rota ablation, provided your wire is biased towards the calcium. So we have got a misconception that rota ablation creates havoc inside. We really scared that rota ablation, this rotating mechanism, is going to rupture the artery, disturb the artery, destroy the vessel, the intima and everything. But it is not true. You see here, the left side, there is a artery which has been given angioplasty with a balloon. And you can appreciate here the number of dissections in the artery. And right side, it was after a rota run. So rota gives you a clean artery. Rota ablates and cuts very precisely, and the artery which you have after a rota run is very clean, unlike your angioplasty balloon. So this fear is totally unfounded and totally out of proportion. We shouldn't be fearing rota ablation if you know the basics and how to perform it. It works just like an electric razor. You see, when we cut our, when we shave, it cuts our hair, but doesn't cut our, the skin. And that is how rota works. When it encounters the elastic tissue, it doesn't, cut it. When it encounters an inelastic tissue, it cuts through. And that is why it cuts the calcium, it cuts the fibrotic plaque, but seldom cuts the, intima. So let's get ourselves familiar with rota ablation system. So rota ablation, now we have got Rota Pro. This is the, the gold standard, not gold standard, the original Rota Link, which we have been using for last 7-8 years. So Rota, they both have a console and an advancer and a paddle. So the paddle is not there in Rota, Rota Pro. On the advancer, there is a knob, which you activate, then the rota ablation starts. And again, you push it, then a rota ablation stops. So everything is under your control in Rota Pro in your hands. But in Rota Link system, this paddle is there and console is there and an advancer. We'll go through in detail. And this burring motion, the increased speed, facilitates the advancement burr. So just like opening a champagne, your fingers doesn't get hurt. It's not easy. Just do it and it goes off. So the increase the speed, the burr usually advances. You don't have to push it through the tissues. And the plaque the particles which you get after, the rota burr, the rota runs, these are about less than 5 microns. So they don't clog the vessel usually. So you don't get a no flow situation. You can get a slow flow situation, very rarely no flow. And all these pass through the capillaries and they are taken care by the reticuloendothelial system, afterwards. So nothing is retained there in the microcirculation after some time. That is the basic. And this is a console. There is a dynaglide and a foot pedal, and there is an air tank is there, and there is a compressed air or nitrogen you can keep in the air tank. I will go through all this in detail because it's important to know the hardwares. In cardiology, intervention cardiology, 80% job is done if you know the hardwares, what French size, what is, what's the lumen there, and what kind of gadgets you are using. So this Rota Link console has got a tachometer where the rotational speed is displayed. There is an event timer. There are connections through which you connect with your saline and the advancer. Then there is a turbine pressure knob through which you can control the pressure. And there is a power switch and a power lamp. And this is the air tank. The pressure in the air tank should be something around 500 psi, not 500 to 700 psi. But in the console, it should be around 90 to 100 psi. It's not more than that. And that is controlled by the knobs which are there in the console system. And dynaglide you can activate by just pushing the side button, which is silver in color, smaller knob. You press it and then it lightens up and it shows that now it is dynaglide mode. Now you can switch the paddle and the dynaglide, it will move in a dynaglide fashion. Dynaglide means the rotational speeds is not something like 150, 170. It's just half of that, 70 to 90. So it doesn't injure the vessel. You can just take out the wire after activating the Dynaglide mode and switching the paddle. So this is how it works. And sometimes some of the operators you must have seen Dynaglide mode, they activate to advance the wire. Sometimes wire comes in. You have parked the wire in the distal LED or distal RCA. You've activated the foot switch. Now we are doing a rota, and now you see the wire has little come inside the mid LED. So if you want to park the vessel, some of the operators, they bring the switch on the Dynaglide mode, then activate the rota and pass the wire in. So that is not a great idea. Although very seasoned operators like Dr. Samim Sharma has shown many times, but the company discourages about doing these things. So it's Dynaglide mode is always to withdraw the wire, the exchange the wire. And then we have got an advancer. Advancer has got multiple knobs. So this is basically the advancer knob. In Rota Pro you press it and go forward. In Rota Link the switch pedal works and you go forward and backwards with this knob. And then there is a wire brake system. There is you have multiple connectors, and then there is a drive shaft through which the rota bar is attached here. One of the most important component which one should know is rota wire. So rota wire is unlike 0.014. What we generally has basically the normal thickness of the wire which we use. This is 0.009, and it tapers down to 0.0077, then 0.005 in the distal. Then again, last portion is 0.014. So that is why if you take your rota bar towards the spring coil, it is going to snap it off. So you have to leave the opaque part of the rota wire while you are doing a rota ablation. So there's nothing is more opaque. Little distal segment of 30 millimeter is opaque. So you don't have to go. Your rota bar should not be approaching this area. It should be proximal to that area. And then the rota drive extra support has got uniform 0.009 thickness till 5 centimeter, and beyond that it tapers down 0.005. So there is no transition from 0.009 to 0.0077 to 0.005. So this directly tapers to 0.05. This is the Rota Pro, and this gives us basically this halo triangle, yellow triangle, gives us an idea that 5,000 rotations have dropped, and more this solid triangle gives you an idea that 10,000 rotations have dropped. So this is a very visually very attractive kind of thing, which is right in front of you, and you can do the procedure seeing that. And the console is also very high tech they have made, and it's really good experience to use Rota Pro. So I will take you all through this. Can we have the volume? Can we have the volume of this video? You can see here there is a drip, and we will just check how much pressure it is generating. The gas pressure is there in the console or not. So there is a test called draw test which we do, and which we are going to do. First we see draw means drip. You see here there is a drip coming up. So there is a constant flush is going on, and this is not the Rota flush. We have given Diljam and heparin and nitrate, and now we will check the draw means drip, then advancement, and then rotation, and then wire. So these four things we need to check. And here, see here, this is Rota Link Plus. It's not a Rota Pro, and this is unlocked and this is locked. So from here, and once it is unlocked, locked, this moves like this. So once we activate, and the Rota will show up there. So there, wire is the brake is there tightened. It's important that your brake is there. And then I see here now it will be rotation will happen. And now I see here there's a good movement. So now you have to fix it 2 centimeter just towards the Rota bar, and then you have to go inside. So the draw test has to be performed beforehand. Before going in, everything is set up, and then you need to do a draw test. You see the drip yourself. that saline, which should be at least 200 millimeter Hg pressure should be there in the pressure bag, so that the drip is continuous. And then it should be advancing freely. There should be no resistance, and it's rotating. You can see the rotational speed there. Here you see here. So once we are testing it, how much speed we are having. So this is 132,000. So we have to increase the speed through this dial. Okay. And then now I can appreciate here it's 157. After this preparation, we go in. So without this, you are going in, rushing through the procedure. You are going to not going to do justice to the therapy. So here you see a very calcified LED, and we are going doing rota, and you can appreciate the lesion is not getting crossed here. Everything was getting stuck here, so it is not going in. So we don't have to rush it. We have to go the second run which we started, and then finally we made through. So this is the second run. You can appreciate the rota were passed, and then there was a followed by polishing run, and then finally we could do, and this was the the lesion, the final stenting. So this is how rota ablation is done. So what are important potential complications? How we can avoid that? Recommended maximum drop is 5,000. If you see more than 5,000, it can generate excess heat. It can cause a spasm. It can cause increased particle burden. System will stall at 15,000 drop. So be careful if the sound of the pitch of the sound gets altered, or you see directly that there is a drop in more than 5,000. You have to come back and stop, and always do a slow, smooth, short taking movement rather than forcing the rota down the lesion. Is going to get stuck. So everyone who has done more than 30 rota ablation, they have got 1 or 2 stuck bursts. So it is not uncommon, but you can avoid after 20-30. If you do next 50, the rota stuck chances will be less, because then we know the nuances. So we don't have to rush through the lesion. If it is not going in, just hitting the lesion, coming down, hitting the lesion and coming, retracting down. And this is how you will go and cross. Do not over tighten the Y adapter, avoid daughtering, never stop or start in the lesion or beyond the lesion. You have to stop the rota ablation once you are proximal to the lesion. Otherwise, there will be chance of a stuck bar. And never adjust RPMs during ablation. So you can't adjust. You see 180, you don't want to come down 140 while doing putting the foot switch on. So these are all small nuances and tips. You can get 3 feedbacks. One is tactile. I hope I have time, sir. Yeah. So we get 3 kind of feedbacks. One is tactile. So we can get an excessive load on bar or bar advance too rapidly. Then we can assume that there's some problem has happened or can happen. Visual, you can see there how the rota is moving, and auditory pitch changes. So Rota Pro, you can see everything in front of your eyes. In Rota Link, you have to see in the console. So you depend more on pitch sound than the visual things. And final polishing run is very important. You should stop when there is no RPM drop, no tactile resistance, good flow through the lesion site and beyond. So, and with this, I will go through some of the cases which we have done, which will be of interest. So this is a case, you see the calcified lesion. Can anyone comment which modality of calcium modification tool can work here? I don't think besides Rota, anything can fit here. Hugely calcified LED lesion right from the ostium to the mid LED. So you can't, you feel scared in negotiating this vessel, even with wire, rather than going with a cutting balloon, something like that. So nothing else but Rota works here. You see, after the initial run, which we caused through, there was a polishing run. And then finally, it was dilated with NC balloons. And this was stented, and we got through this result. So this was the final result. So, and this was not at all a case of bypass surgery. Can you see here the distal LED? There will be a huge endarterectomy, and then again there will be you can't guarantee the treatment, the outcome. Sometimes you can get a lesion like this. You do a Rota, again you do a cutting balloon, you deploy a stent, but even after that, after cutting balloon, Rota, your results are inadequate, and you have to go with IVL. So rotatripsy is needed, in many cases, and it depends on what kind of lesions we are treating with. This is my final case. Can appreciate here, lesion is calcified, but it's not very, diffuse or kind of not much of angulation, but there was only one angulation. And then finally, we got a rota burr proximal to lesion. So this is why it is important. We have to burr the proximal lesion also where there's a calcium, and then the rota burr was stuck. We recrossed the LED, and then we dilated the balloon, and then finally the rota burr was free, and we could do the procedure. So thank you so much for the patient hearing. I hope there will be a few questions. Thank you.
Thank you very much, Dilip. Excellently covered rotablation. Makes me a little nostalgic. The first rotablation I performed was almost 27 years ago, 1996, when even Boston has not acquired this one. This was by a small Californian company, HeartMate. So that was long time ago. Since then, Boston acquired after 3-4 years. They acquired it and launched again. And they've made 2 modifications. You have covered both the modifications and the techniques for new beginners. Is you really given every point you need to know about this. And very rightly said, when you are concentrating, you are not really going to see the triangle unless it's a very flashy thing. You're probably concentrating on the sounds, and that is very useful. So you have covered every point, and beginners will learn a lot from this, and it's come a long way. We know there are newer tools which have come in since then, but rotablation has its own place. A new competitor like orbital atherectomy is coming in, but that's a different beast. So one has to really be careful about it. Thank you very much.
Thank you.
Very nice.
One thing I probably missed, did you mention about releasing all the tensions from the system before starting? Because
yes, sir.
That's important for the beginners.
Very important, sir. So it's important to see that the wire which you have taken, either a floppy wire or a support wire, there should be not much of tension, and it should be in a straight line. There should not be much of angulation. And nowadays, a single operator rotablation is in practice, and rather than fashion. You can see a whole lot of YouTube videos where operators are doing single-handedly rotablation. So the exchange of wire is very important. They make a loop in the on the table. They don't keep an assistant there and do everything and exchange the wire also. So I think that is little dangerous, and I don't know how to endorse that practice or not. But finally, in the end, you have to see their brakes are finally applied before you go inside. There should be no residual tension, no kink is there. Once there is a kink, it can cause problem. So a very, very nice point highlighted by sir.
Yeah, a quick, question for you. Your comments actually. What do you do rotor in a patient who has a very poor LV function? And secondly, like you commented, like the deep calcification, if there's deep calcification, you would need IVL, that's true. But I think most of the deep calcifications, they do not need anything. You can just do it with a balloon.
Yes.
Because all calcifications doesn't need to be ablated, especially very.
Yes, sir. So deep calcium, although it will not pose problem directly, mostly in negotiating the stent, but it will give a problem in expansion. The total expansion of the stent will be hampered. So it is choice is ours. If you take a maybe 1:1 size balloon, NC balloon, and we see that it is opening up, then we may avoid rotablation or many IVL. But it is not opening up. It's not expansion is not guaranteed. Then we can do that, sir. Yeah. And when there is a kind of a very less ejection fraction, and we see that this is the sole artery which is making the patient survive, we avoid rotablation in those cases, because in 5-10% chances there is a slow flow, and that slow flow can be detrimental. Even if we want, we have to take the patient in MCS and Impella and then do it, sir.
Sir, is a wonderful talk.
Usually there are 2 basic guidelines. I mean, you cannot spend a lot of time deciding whether to go for the route or not. So 2 simple things are, first is if you are not being able to pass an even small diameter balloon, you give up. Second is maybe you have been able to pass a balloon, but if it's NC balloon, if you go up to 20 and still it's not opening up, then you have to go for route.
Yes.
So you can make this decision.
Yeah, we're talking about low ejection fraction.
So for the beginners, so your opinions on the coaxiality of the guide catheter, and how will you select your bar, the size of the bar, and the third is the use of the temporary pacemaker in which of the cases.
Yeah. So I can for anyone who is starting the rotablation, for him, I think default burr size should be 1.5. 1.25 burr looks smaller, so it looks less dangerous. But this is the most dangerous burr, I tell you. the chances of entrapment is mostly in 1.25 bars because it is designed like that. It's designed like a bullet. It is not that smooth, proximal tapering, and it stucks many times. So default 1.5 burr size should be there. And then if the artery is very big, you are not convinced and you want to, burr extra, then you can get 1.75. More than 2.25 burr, I don't recommend because we have not done it. You can do that. And coaxiality of the stent, so guide catheter is very important because also it is very important not to start burring inside the guiding catheter. And also not starting the rota when you are near the calcium because you have a very calcified lesion at mid LAD. Proximal LAD also you are getting some calcium. So start rotablating from proximal. Don't start from the left main ostium or inside from beyond the proximal LAD. Because there, if you have not done rotablation, chances of stuck burrs can be there. Like last case I showed you, I started burring after the proximal lesion. I thought there's a huge lumen is there. No problem. I have to just burr the mid LAD lesion, which is calcified. And there I got a stuck burr. So start burring right from proximal, from where the calcium starts before that. And then if your diffuse calcified segment is more than 60 millimeter, because the advancer can go only 60 millimeter. You see, this much is length. So 6 centimeter. Then how will you tackle? So LAD is 9 centimeter. And from proximal to distal, there is a disease. You want to go till distal LAD. Then from proximal to mid, you do normally. Then you take guide extension. And then go inside, then start burring. So you can then totally, rotabur the vessel.
Ratio between, what ratio do you prefer between the arterial wall and the bar? What is your preferred ratio?
Yeah, 2/3 they say, but I think I am okay with 1.5 bar. Most of the cases.
Below 7?
Yes.
Below 0.7?
Yes.
Below 0.7?
Yes.
Just another practical point for learners that the radial distal part is only 22 millimeters, unlike 30 millimeters, what we see in most common wires. So that is to be remembered.
Yes.
And I think we'd like to have some questions from the audiences.
Yes, sir.
Now, so far as I know, the rota is used for pulverizing the calcium. But you mentioned about fibrous tissue and fibrocalcium.
Yes, fibrocalcium.
Now, does it at all affect the fibrous tissue or the fibrous cap?
Yeah, so basically it acts on fibroelastic tissue, fibrocalcific tissues. So there is only fibrous tissue. It can, assume that is elastic tissues. Depending on the elasticity of the, the structure which is hitting. So if it is elastic, it will not cut through. But if it is inelastic, is only calcium or fibrocalcific area, it will cut through. So it depends on the elasticity of the, the tissue which it is encountering. The cut portion will be there.
If it's elastic tissue, you cannot do anything with, usually you cannot do anything with rota. Only hope is big top. Only idea is to go laser, which is it available around? No.
Laser is not available in steel.
No. So we can't do really much about it because rota, there is an element of extra risk as well, and it doesn't really help.
Only fibrotic lesion, it shouldn't be taken, sir. Fibrocalcific lesions.
So excellent presentation, sir. So my point is, because in our country, most of the labs we're not having this imaging and all. So what is your say? Means for rotablation, is imaging is a must, or means how to approach those cases?
I think cutting balloons are very handy. Now there are good cutting balloons are there. Wolverine has really come up very well. So you dilate the lesion with smaller balloons like Nick Nano or 1.25 small Tajuna balloons or very low profile balloons. You make a passage of NY cutting balloons like Wolverine, and once you cut with Wolverine, the Wolverine which we are really scared that we don't go more than 10-12, so you can go to 16-18, no problem, provided your size of the Wolverine balloon should not be 1:1. It should be 0.75, little less than the size of the vessel which you are looking at, and in 90% of the cases it gives you a more or less good extent expansion.
Thank you, sir.
I think we are actually running a little bit ahead of time, and our next speaker is not here yet. He's just reaching. No, he's is he? He said that he's there in the hospital. He's almost reaching, isn't it?
Yeah.
Oh, right. Okay. So do you want us to carry on the discussion for another 5 minutes? Okay. I think there was someone from the audience who had a question, please.
Sir, the cost of rotablation is lesser than IVL, number one. RotaPro and RotaLink costs are different. And it also depends on the hospital. How much hospital, they're procuring at and how much they are, giving to the patient, the price. So on an average, rotablation is around 1.5 lakhs and RotaPro is 2.25 lakhs. Yes.
It's about the same. It's similar. There may be difference of 5,000-10,000 here and there, but not a major difference. The good thing is in rotablation, there are certain parts which can be reused by disconnecting and reconnecting to, not officially, unofficially, of course. That brings down the cost a little bit.
This mic is.
Can you share your experience about rotablation in lesions which have a suspected thrombus or thrombus containing lesion?
So in the literature and in the teaching, rotablation is contraindicated in thrombus containing lesions. So one should not do it. The case which I showed, the first case was STEMI. So there nothing was going in, and then patient has a ST elevation, but it's not very tall ST elevation. So not only a thrombotic component, but a majority, mostly the patient had a very subtotal occlusion kind of thing, and on top of that, a small thrombus is there. But if you see a thrombus and you are dealing with a thrombotic situation, laser is a very good option. Laser evaporates the thrombus, and then thrombosuction is also not needed. And the proponent, the laser, one thing which the laser users are really fond of using in saphenous vein graft, STEMI cases, they utilize their laser most rather than calcified lesions and fibrotic lesions. So rotablation should be avoided in these cases. Laser is the treatment of choice, and I think.
So thank you, Dr. Kumar, for the really enriching talk. And we would move on to the next speaker, who would be actually online because he had got stuck over there. So it's Dr. Aftaf Khan, and he's going to talk on how to avoid complications during rota. You can hear more of what has been just discussed from him. So over to Dr. Khan.
Hello. Hello. Whiteboard share করছি। What is এখানে? No, but that's the main. Yeah, just 1 second. I'm just trying to see how to share my slides. Hello. Yeah, I'm just trying to see how to share my this thing. Hello.
We can hear you, but we can't see you. We can hear you, but we can't see you.
Aftaf, could you hear us? There's some echoing. I think we have to take care from this end or the other end. I don't know.
Hello.
Yes.
So can you hear us?
We can hear you, but we can't see you. Neither the slides nor yourselves.
There's some echoing. I think we have to take care from this end or the other end. I don't know.
Hello? Hello? Sir, we can hear you. Sir, can you turn your camera on?
Sir, can you hear us? We can hear you, but we can't see you. Neither the slides nor yourselves.
There's some echoing. I think we have to take care from this end or the other end.
Sir has just disconnected. He's connecting from. Hello? Hello? He's disconnected. He'll reconnect.
So we can hear you.
Sir, can you turn your camera on?
Maybe your video is turned off. Something.
Sir has just disconnected. He's connecting from. He's disconnected. He'll reconnect. So we can.
Maybe your video is turned off. So
Can you, sir, can you start your video?
Yeah, I'm sorry, I cannot see my keynote presentation here. Trying to see how to get it on the, how to upload it.
Sir, open your presentation first.
Yeah, it's there. It's open on my mobile.
Now, sir, you can share the screen. Share screen. Start share screen.
1 second. So it does not say anything about share screen. It just gives me the other options here. It says Photos, iCloud Drive, Dropbox, Microsoft, Google Drive box, Okay, now are you able to see it now? Hello? Are you able to see it now? Hello?
We can see the slides and your.
Yeah. So I think, can I start the presentation? Okay, sorry, apologies for all the presentation delay there. Okay, can I go to full screen? Can I go to the full screen there? Yeah, so my talk basically is to tell you about how to prevent complications during a rotablation. And this is going to be basically focusing on the complications that we normally see. So there are 4 or 5 complications that are very common in patients during a rotablation, and this includes decreased antegrade flow, perforation, burr entrapment, arrhythmias, and rota wire fractures. Am I audible there? Hello? Am I audible? And this is going to be basically focused on. Hello? Dr. Banerjee, am I audible there?
Can you log out from the other device?
Yes.
We are getting an echo. Can you
Okay,
log out from?
Yeah. Am I audible now? Hello? So basically, the complications include decreased antegrade flow, perforation, burr entrapment, arrhythmias, and rotawire fracture. Now, the rotablation complications usually arise because of a decreased antegrade flow. And when you're talking about these 3 main complications, dissection, embolization, and spasm, these are often caused by a small vessel. So if you're doing a rotablation in a small vessel, or if you have tortuosities and you're using a larger burr, you're more likely to end up with dissections. Similarly, if you're using a high burr speed, more than 180 to 2000, 20,000 per RPMs, then you're more likely to end up with more distal embolization and long runs. So unlike small runs and adequate time frames between the runs, if you continue with a longer run, then you're more likely to get distal embolization. And spasms are often related to pressure damping and not use of prophylactic vasodilators. So we make sure that we give a lot of nitrates during the procedure to make sure that the patient does not have distal spasm. And the solution for this is basically to give, if there is a distal spasm, is to give vasodilators. And if there's a stent, if there's a dissection, then the treatment is to stent the artery. So this is one example of a patient. This image is not playing. So basically, there are 2 dissections that we see here. One was during an RCA on the right panel, and one was during the left anterior descending. Unfortunately, the images are not playing. So the rotablation complications. complication is relating to the perforations that we commonly see during our ablations, and well, not commonly, but this could be one of the dreadful complications that one could have during a rotablation. And the causes are usually because of an ablation into or a rotablation to a small vessel. So one has to be very careful when one is rotablating a small vessel less than 2.5 millimeters, and that's one vessel that we would probably not want to rotablate. Using high burst speeds, using a rotablation in tortuous vessels, or keeping a rotawire tip too close to the lesion. Now, what one needs to realize is that the rotawire is a wire which is a 0.09 wire to start with, and the tip becomes a 0.14. So if you get your burr too close to the rotawire tip, you could in fact engage the distal floppy part of the wire, and that can produce a perforation because the wire may then get engaged and it can leave the vessel wall. Rotawire fractures are also known. If you have a fracture in a tortuous vessel and you're integrating at high speeds for long periods of time, you can cause a perforation on the wire. Again, this is a video that's unfortunately not playing, but this is one of the videos where you can see that there's an angulated lesion and the burr was kept stored for a long period of time to try and engage the lesion, and this eventually ended up causing a rotablation perforation. The treatment for perforation in all these patients is universal, and as we do for any perforation, one has to inflate a balloon to occlude the vessel proximally. Intravenous fluids and vasopressors are to be started to make sure that the patient can maintain a blood pressure. Pericardiocentesis in this hypotension, and one may try an autoperfusion also, and get your surgeon to be notified. In case there is a persistent extravasation, one has to think in case of a large vessel of a covered stent, or in a small vessel, one may try distal embolization with fat, coils, or other materials that one can use. And in case there is a continued extravasation despite these methods and despite a reversal of anticoagulant, surgery becomes the only choice for this group of patients. The other complication that is dreaded is burr entrapment. And I think the commonest reasons for this is either a forceful advancement. One has to realize that the rotablation burr, unlike an orbital African device that we have, this has diamonds only in the front and nothing on the back. And therefore, if one forces into the lesion and then does not come back rapidly, one can get trapped beyond the lesion, and that could be one of the reasons. Second thing is using a small 1.25 burr. Now, unlike a 1.5 burr, which is more rounded, a 1.25 burr is almost like a bullet. You can then jump across the lesion, and it may be difficult to get it back if one stalls the burr beyond the lesion. Again, doing a rotablation in patients with prior stents or in tortuous lesions are again causes where one could have a complication relating to a stuck burr. And the treatment for this, or the prevention for this, is to use gentle advancement. So it's always a slow movement ahead, a gentle pecking movement, and a fast withdrawal. So always go slow ahead and fast back. Use burr. Normally, my protocol is to use always a 1.5 burr or longer or beyond this. 1.25 is something that I use very, very rarely, and that will be only in patients who are very tortuous lesions, or if I cannot really get a 1.5 burr up, where there's severe calcification, where I do a graded upsizing of my burr, where I will start with a 1.25 and then go up to 1.5. And the 1.25 burr will be used for what we call as a halfway rotablation that we'll talk about later. And the third important thing is never stop distal or within the lesion site. Always go in and, as I said, come back to your neutral or starting position. Well, this is again what I was trying to describe. The 1.25 burr is something that's almost bullet shaped, whereas the 1.5 burr is something that's more liquid, and therefore it's easier for us to use with less chances of entrapment. But again, burr size is definitely one of the indicators, but again, one has to be careful to understand that the other steps are equally important. If you have a rotablator burr entrapment, what do you do? Well, the first thing is to not to panic. The patient does get often symptomatic, and one can try a lot of intravenous or intracoronary vasodilators, give a lot of nitro to make sure that the burr can, if there is a vessel spasm, the burr can get released by relief of the spasm. The second thing that we often do is to use the Dynaglide mode and then go to high speed and try and rotate the burr. Well, do not try and rotate a burr in a stuck position without the Dynaglide mode. So if you're doing a high speed rotation in a stuck burr, you are causing trouble. You're likely to end up with a perforation there. And this is something that has to be avoided. So if you want to try a rotational there, it has to be in a Dynaglide mode, and then you try and pull back the burr in a Dynaglide mode. So if you're not able to remove the burr, the next steps become to advance the small wire and a small balloon next to the burr, and therefore do a small balloon inflation there so that the wire can, the balloon can create a space for the rotablator burr to be withdrawn. And this, if this fails, and the commonest thing that we do now is to use a guide liner by cutting the burr. So what you do is they cut the distal shaft of the burr, remove the Teflon coating on top of the wire, on top of the burr, and then advance guide liner there. If you have an 8 French guide liner, you do not need to even remove the Teflon wire over the burr. But if you don't have a 8 French, then you need to cut off and remove the Teflon wire, and then give a gentle counter traction by getting the guide liner deep close to the burr. And if all these maneuvers fail, then the treatment is to, of course, send for an emergency cardiac surgery. So this is a slide that I borrowed. What you do is basically you cut the rotablator outside outside your sheath, outside your guide catheter. Then you remove the sheath cover or the Teflon coating on top of the rotablator shaft, and then you introduce a guide extension catheter. And as I said, it's preferable to have an 8 French. But if you don't have an 8 French, you can also use a 6 French or a 7 French also. And then what you do is that once you get the guide liner inside, all the way down, you get your guide liner directly down till the lesion where the burr is stuck, and then you give a gentle traction onto the guideline, onto your rotablator entrapped burr. And what would come is that the entire assembly can then come out. And this is again one example where the guide liner, and you can see that entrapped burr, which is connected to the at the tip of the guide liner. The other thing to be importantly realized is one more method that we can do is that, as I said, the distal wire is an 014, whereas the proximal wire is an 019. So if you pull back the wire can get caught in the distal end of the rotablator burr, and the wire itself can give you a traction force because the wire will not come into the rotablator burr since it is a bigger wire, and that can also give you a traction force to pull your trapped burr back into the catheter. The other ablation complications that could arise are arrhythmias, and this could be both the bradyarrhythmias, which is usually we would like to suggest that you put in a temporary pacemaker if you're doing a dominant right coronary artery, or if you have a dominant left anterior descending artery. But I think we have also started using the protocol of using aminophylline peri-procedural, and this has reduced the incidence of our use of temporary pacemakers during the procedure. But again, one has to be also careful to use the other techniques. Make sure that your burn speeds are between 140 to 160. And again, make sure that there is enough rest between your rotablation bursts. Your intention should not be to cross the lesion in the first run itself. One would suggest that you make small runs, and often the lesions are crossed many times in our cases by the 5th or the 7th run itself. So go slow and give the artery sufficient time to breathe, so that the distal microembolization gets a chance to wash off. Of course, if you have tachycardia, this is usually something that is dangerous, and this is often a ventricular tachycardia. And its often etiology is a no flow or a slow flow, and one has to treat that by means of chemotherapy or giving adequate vasodilators, or often if there's a dissection, one has to put a stent to get rid of these arrhythmias. The other complication is a rotator fracture. And again, this is again caused by trying to do an aperitomy close to the wire tip. So if you're going to the tip, again, as we said earlier, there's a transition zone from 0.09 to 0.14. Wire thinking is something that's also important, and if you're doing a rotablation very close to an angulated lesion and there's wire thinking, you can cause a fracture and perforation there. High angulations and prolonged lesion contact. So all these are important causes for rotablator wire fracture. And if there's a perforation, well, it's like the earlier thing, as I said, one has to be really rotablation fracture or perforation caused by rotablator is dramatic and disastrous, and one has to be really careful to avoid this and to tackle it. And if there's a wire fragment that is left behind, say at the tip of the LED, one could probably just leave it behind and not worry too much about it. So if it's in a distal vessel, well, you don't break your head about trying to retrieve that wire, you can leave it there itself. The other thing is the use of the wire bias. So again, make sure that your wire is has a favorable bias. So here you can see that there's an unfavorable bias, that the wire is almost hugging the inner sides of the vessel. And here, if you're doing a burr there, you can cause a tunneling and you can end up causing a perforation in these vessels. So therefore, one has to change the wire bias. And if I just push the wire inside, you can see here, by just pushing the wire inside or retracting the wire rather, rather than pushing it, you make it more towards the bias. By just retracting the wire, you can change the wire bias so that the wire is more in the center of the vessel rather than hugging the inner curves of the vessel. And this can help you to prevent any tunneling of the inner aspects of the vessel along the curves and the presentation of what we call as pseudo lesions. Just to end my talk, there's something that is known as the halfway rotablation, which is now favored by many of us when there is an angulated lesion with calcium. So the earlier protocol was that we try and go all the way with the rotablation burr over an angulated lesion, but this had problems. When you have a long lesion with angulation, the more rotablation you do, the more chances of distal microembolization and slow flow, and the chances of burr entrapment. And therefore, the protocol now is to do what we call as half rotablation, that's seen in panels D, E, F, where what you do is that you just do halfway. You don't go beyond the bend, just break the calcium in the proximal part of the lesion, and then use a balloon to tackle the distal part of the lesion. And this protocol works well. And there's a paper which has been published by Sasuka. And this has shown that the chances of burr entrapment is much lesser. Chances of complications relating to slow flow is much lesser once the halfway rotablation techniques are used. So to conclude, I think rotablation is a great tool for us to manage our calcific lesions. Well, now that we have a gamut of tools here, we have IVL and we have orbital. But decades earlier, this was the only tool for us, and it still has a role despite the use of the other techniques that we have. In a balloon uncrossable lesion, when there is no distal, when you cannot get the other devices inside, you would have to do a rotablation to get your passage down. And for osteoproximal lesions, aorto-osteal lesions, for example, that's the only tool that we have for us. We can use IVL, of course, but for a tight lesion, rotablation still remains the choice for an aorto-osteal lesion. Well, one has to be careful in certain things. Don't forget the basics. Go with the slow pecking movements. Never stop within the lesion. Gentle advancement and rapid distillation back to your neutral position.
Sorry to interrupt you. Just have a minute.
In one location when you're rotating at high speeds. Always make sure that you're doing pecking motions and avoid burring distal or stopping or stalling distal to the lesion. So with that, I think I'll stop my screen share. I'm sorry for all this disturbance and the delay in starting my presentation. I hope you could hear me.
Yeah, thank you. Thank you, After, for the great talk. We all appreciated it. Unfortunately, since the live case is going to start right now, we won't be having any question answer session for this. And if to have the last word, I'll ask my co-chairperson.
Can I have just one? Sorry, I missed Dr. Dilip Kumar's lecture. I was sitting in the other hall. Just it will be nice to give you a take-home message that from the angiographic view, how you take decision that this should be a dedicated rotablation or some arthrobiotic procedure, or it is a provisional. Because majority of us have to take decision from just the viewing the angiographic film without using IVAS or other gadgets.
Yes.
So this is, I think, one of the important decision making for majority of cardiologists doing in other parts of centers.
Yes.
Dr.
So
Dilip Kumar.
That's very wonderful.
Dilip Kumar.
And I'll just try to be very brief. I know we have short on time. So I think one is angiographic calcium. If you have an angiographic calcium that you can see even before you inject into the contrast into the coronaries, or if you have a tram track calcium, I think that falls into the category of severe calcification, where a calcium score is more than 5. So anything that is medium or moderate or severe would be the places where we would think of some form of balloon of calcium modification. Now, rotablation is, of course, one method, but I think we also would say that the other methods are also, of course, cutting balloons and the scoring balloons, and there are also the other modalities such as an orbital or an IVL. But I think anything that is seen angiographically, so angiographic visible calcium, even before your injected contrast is one. Calcium that is seen in a tram track fashion is second. And the third thing is that when you see calcium in vessels which are, say, eccentric, I think that's, again, something that makes me worried, because I'm worried that the calcium may not crack enough for me to expand the stent. So whether it's in the proximal, the more proximal vessels, the more worried I am. If it's a distal calcium, I'm not so worried. We can probably try our other stuff. But if it's in the left main, an ostial position of an circumflex or an ostial LED, I think those are lesions which I'm really concerned about. And if I see extrinsic calcium in those locations there, I would say that I would still want to image and be careful before I put in a stent in those locations.
Thank you.
Thank you.
Thank you so much. We end the session over here. We move on to the next session, but before that, we have few announcements. Kindly submit the lucky draw coupon 1 and 2. The bowl is just outside beside the tea coffee counter. The first lucky draw will be taking place after the lunch. Kindly be there to collect your gift if you are lucky enough. And the next one will be during the dinner. So kindly submit your coupon 1 and 2 before that. And today's dinner coupon you will be getting post 6 p.m. We'll be moving on to the next session, Live Case 1, KGMU Lucknow. Case 1, Dr. Rishi Sethi and Dr. Pravesh Vishwakumar will be joining us. And Dr. Pravesh Vishwakarma will be joining us. As chairperson of this particular session, I would like to invite Dr. Amol Banerjee, Dr. Amol Khan, Dr. Raja Roy, Dr. Ashfaq Ahmed, kindly. As panelists of this particular session, we'd like to invite Dr. Pankaj Shorkar, Dr. S. Kundu, Dr. Arnob Datta, Dr. Uttam Shaha, Dr. Miraji Mondol, Dr. Amit Bhawala. Requesting all of you to please grace the stage as chairperson and panelist. Thank you so much.
Good afternoon. Good afternoon, Rishi. I'm Dr. Amol Kumar Banerjee from Calcutta. Rishi, can you hear me? Yes, I can hear you, but whether you can hear me? Okay. Oh, okay. Okay, you are virtually welcome to Calcutta and also have our virtual good wishes to you, you and your team also. Now I request you please to start, give us the brief history of the case with relevant investigations.
I'm grateful to be on my own I am pretty new to this, and my two converts have been who have done some kind of case in terms that then we have people. So I end up with very keen of the technicians that Sharma and the Rita. So, of course, it's so nice to see all of you in Washington, and I think that you all have invited you to provide and nice to have that. So, I want to say that it's the next little bit of the news. So this is beautiful campus that, everything is not within it's very applied in Lucknow, and we take the guidance, we just use 10 seconds of the so demonstrate really well and what we do. Never slide into the case weeks. So I'm looking at specifications to the case and then we come right in action. There are audits, residents 2 years old, but it is not adequate, but US about 2007, we had an individual public auction and then to one of the public sector hospitals in Delhi where beside the was the percent that was 3.5 into 21 millimeter in the diameter and then. And after for many years, and now we are 1 2 years in the some and then section, and then we have this meeting with the last series that presented to us with unstable in that. It is to be all of the normal limits. And if you look at the demographic diagnosis of unstable data, we're really to see when it's solid send a energy of 2.521 in 2007. They have the demographic. So we send them around the 10 hours back, and we found that we there were 300 circumstances of the different and the physical disease in the large use market, and comes the next disease. And when we saw that in the problem, and we said that the diffuse and treatment, and also the different medium and function of the good and the excellent. And we also some relatives of the and we also have the viewers in the RCA. So we start with that level, then we have a function of surgery, and go to the next slide, please. So, but there are many reasons, and the question is about the science of people that's going to when it's time, we are restoring them, and we're doing conversation, and what kind of reading and depending upon the type of strategies, we define the wisdom and the possible strategies. So, in terms of wisdom and approval of draft and release and everything, like we can do that, I think, in every thought, persistent, just on that, final written. So, obviously, I don't find it so much as it's a good, but this is you also read sometimes, and if you look at no major sectors for after that. And that's the side where actually our current put our graph. So suppose if future patient develops a leak flow, if we put it as leak flow together, what will happen to this patient? Probably the leak will become non-graphical. So what we are thinking is that we will maybe put a balloon, we will dilate and do a depth, and then we'll see the results. If results are acceptable, we'll leave that first. You need to finally analyst.
Well, yes, that could be a strategy, but I still think the distal vessel is still graftable, even after the stenting. But yeah, drug-eluting balloon is a new thing. People are practicing more and more. And as I said, use a simple balloon, dilate it well. If you get a good results, put in a drug-eluting balloon. If you don't get good results, put in a stents.
Sure. So, so we have visible one values.
Yeah, we can see it.
Somewhere around 900 degrees of calcium, you can see, and about you can see from 8 o'clock to 2 o'clock there is a fiber flag. Another there was a fiber flag. This is the fiber calcium flag. It is narrowing. That's the end of the flag. We are going to do normal acting. Normal segment. Very normal. So we have it as very small, you can see R.5 and 0.5 million cluster. That's what that's coming. And you can see a small micro increase. Again, you can see the rocking motion of particles. Yeah. So that is now starting. Now, this is the problem of either that we are considering is the instant means of it, we can see that size space there. The earliest time demanded was 3.5 million. So if you look at the Eiicon, so everything that is possible, and so it will help us understand what is the possible mechanism behind this at the story. So if this kind of place is available in 2007, so probably looking 60 years of past, so we can guess that it must be some kind of real circulosis. So it's not look around the calcified part, around the calcified part. Stop there, right? It's just a calcium. There is some distance. Go distance, go distance. This for example, was yeah, you can see here. You can see the transfer and the inside calcified glass inside. So it is a calcified neurosurface here. But luckily the calcium marker is very small. Yeah, please run again. You can see it's tended going small inside, there is some rejection, probably because of the iron catheter went there.
So So what's your strategy now? Any change in strategy?
So this there is one that I was finding, and we were trying to give less level to by using either bio or settling or other using when you get certain identify the good side of I feel that we are already to understand this and then my from backwards. If I was and that's one just and I think
Any alternative strategy? Would you consider rotablation, looking at the calcium all around in both the lesions, fibrous tissue?
And the physical article also there will be two blisters. There is almost 120 minutes application listening. But I think we will comfortably use time going to the higher going to the direction. And first, when it becomes non-direct, that probably will be much more happy movement and other rather than a recommendation that it would be good at that direction instead of being also. That much time, you know, really considering rotation, and it's an idea.
So let's see, have you done something for the distal lesion or? Okay, right. Yeah. Right, right. So you go on with your case, so we'll switch to the other lab and we'll come back to you. Switch to another lab. Yeah, we can see you, sir. Yeah, doctor, you are live. Good afternoon, Dr. Pandey here, along with me, Professor Amal Banerjee and Dr. Anil Mishra.
For the Eiicon conference, and we are presenting state and we thank you for providing the opportunity. So we have the emergency team and Dr. Vedanti is in our team and we are representing.
Yeah, and now we can see your PowerPoint presentation. Yeah.
diabetic hypertension is here, demonstrated testing, and the was but before so all when initially was slow, then level up to 4%. Next is before the PT taking but is there right? So kind of really communicating IPA, dominant IPA.
Yeah, if you freeze the frame, there we could see it better because there's only a single run. Yes, we could see just near the bifurcation with the diagonal branch.
Now RCA answer both. Patient did not want CAV at all. So because of that denial, then we have to identify. So let us see for PCR.
So what is the plan for LED diagonal, provisional or two-stent strategy? Yeah, I think you can proceed with the provisional strategy and
This is the one. Now, diagonal fair size, but LED size would be, like 2.5, something, those are really confused. If there is no chance between group. So what are your views on this now?
yeah, as I said, we can proceed as a provisional strategy. And we'll see because there is a one diagonal ostial and followed by another 50 to 60% lesion just before bifurcation.
Is there a concern about the first septal, which is a fairly large branch with significant ostial narrowing?
No, it's okay.
Not visible here.
Yeah, it's almost occluded actually. No, I think if you are going provisional, no pre-dilatation. Yes, Dr. Nath.
With such a large diagonal, Would it be better to go ahead with a two-stent strategy rather than a provisional strategy? And diagonal ostium has a significant disease. I think a upfront two-stent strategy will be a better strategy, in my opinion.
Yeah, as I said, diagonal is less than 5 millimeter at the ostium. And then there is a gap of normal segment, then you get a lesion. So I think we should remain provisional. Right. Yeah. 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 So you have any plan to image after pre-dilatation? Right. So this is 2.5 balloon. Or a lot of your prescriptions. So which year you passed on this one? I passed in 95 from this.
Well, I'm also a fan of two-stent strategy, particularly DK crush, but there have been a lot of criticisms and opinions that whether these two-stent strategies, Chen and all have reported very good results, but it's from the same group. Every time you see DK crush 3, DK crush 5, it's the same group. So whether that group is giving good results, will we be able to replicate similar results in rest of the world? So that we don't know. We don't have answers to. So we really have to wait to see whether these so-called attraction towards two-stent strategy with excellent results in definite trial and others will actually work out in real world or not, or just we go for age-old provisional stenting strategy, which has been shown to be very effective in majority of the trials.
So I'm going at the plan of dilating diagonal 2/15 and try to DB.
Okay.
And then go ahead with stenting for a year.
All right.
Okay, my opinion only the size intervention, which is too small to accommodate or everything. Okay.
Is this a drug-eluting balloon directly?
They're preparing.
Okay, fair enough.
Because drug-eluting balloon, then I have to do that.
So Dr. Anil, if you do DEB to the side branch, is it always upfront or you do after stenting the main vessel?
What I'm finding that the size of the vessel is small. So two-stage strategy is not attracting me because accommodating two stages in the vessel looks a bit too much. That is one. So what I'm doing is that I just diagonal because the ostium was very narrowed down. So there is possibility there is no dissection. Okay.
Yeah.
So now I'm planning toward DEB right upfront because then I don't want to cross again. So that is the
Okay.
Just a question.
yeah.
If we are doing DEB to diagonal with the recent publications and studies, why not DEB to both the vessels, LED as well as the diagonal?
We can even try that. We can even try. If there is no dissection, we can even try that. So
Yeah,
we
but
think if area proximal is too much at stake. So yeah, we can keep.
but
We
doing
are given macro, we are taking a picture. Go ahead.
doing a DB upfront, then you when you put a LED stand, suppose the diagonal gets pitched, then you'll have to recross. So would that lead to more incidence of dissections?
Yeah, but the only thing is that, after putting the stand, if suppose it looks okay, I don't want to recross that as far as possible. That's it. Both will have its advantages, disadvantages. But for putting a TV again, I will have to go through the struts and then again I should have to pilot and then again I will have to do the TV. So I was trying to avoid that. If it's because I have highlighted well, if it remains pattern at the end of the LED stand, then I was thinking of getting away from two strands. What do you think? We can do OCD, but OCD I can. We can not. You want to see the OCD of LED after that?
I think you fix up the diagonal first if your plan is to do a DEB.
Yeah, okay. You. The 20 20. 20 or 25? What's your opinion?
It depends your landing zone. Landing zone looks
20.
it will fall into the pluck actually. Use slightly bigger one, yeah. 25 should be okay.
You can even come to very.
So when you are doing DB, your proximal part of the DB has to be in the LED.
Because if we go in this size, the size of vessel.
And Dr. Anil, you have pre-dilated with 2O diagonal 2O and your DB is at 2.5. Right.
I think that becomes 2.5.
Yeah. It will.
It is a smooth leader right now to dissect that.
Yeah.
Just I want to comment.
Yeah.
So these vessels, I don't know, it's my opinion. It considered to be a smaller size. Definitely it is less than 2.5. And if we consider the radio opaque portion of the this wire that is in the diagonal, it is 30 millimeter. So you make it double, so it will become 60 millimeter. So the criteria is that a significant diagonal or a branch, if it is more than 72 millimeter, is considered to be a bigger vessels. Supplying more than 10 bigger vessels, considered to be more than 10% of the myocardium. I think we might leave these vessels also and focusing the main vessel.
Yeah,
that's just an opinion, I think.
Yeah, by definition criteria, it falls into bifurcation with a good adequate size diagonal. There's no doubt. If you image, you'll find it 2.5.
Yeah, but it is now, I think all the vessels are kind of individually distinct. Maybe, I don't know, like that. Now, So I thought it's, just as far as possible, doing and DEB, so that in the statement,
So you put a DAB for 2 minutes full?
1 minute.
1 minute, okay.
Four. Because they are operating area. Where there are some SPT changes because of operating area also. Ah. Okay.
Well, with the current strategy, what we are using, my worry is always that if you land up with stenting of the diagonal after a provisional stenting, then you have a drug-eluting balloon also, you have a stent as well. You have a double dose of medication in the side branch and plus double expense. I mean, it's only for that reason, and also traditionally as they teach, I would want to do balloons after I put the LED stents.
Yeah, that's why.
I said DAB after the main branch here. But the result looks okay. Apart from the ostium, other thing looks pretty okay.
Yeah. So we'll directly state and then do OCD first.
Yeah. Yeah.
Like refresh. Should we directly state and then do OCD?
I think show us the OCT, and after that we'll switch over to other lab and come back to you for the final result.
Okay. Yeah, I think fully. Okay.
So which system you have for OCT here?
Yeah. Ready? Ready? Sorry.
Yeah, which system you have a OCT machine? Okay.
So, we have 1-to-1 dilution.
Okay.
Saline and contrast. Other level is not.
We'll just see the OCT, then we'll switch. We are another is from Lucknow.
We take 2 minutes. Ready? 6.
Yeah, Dr. Rishi, you are live.
Yeah. So, so as 12, you can have the LED slides, minus please. Ready? Come to first part in the start of PCI. So as you remember that we had two regions in Bristol and the proximal area, we had seen that the levers were calcified. So we had gone back east, come to starting off. So we, after writing everything, we had done drivers and drivers to show classification. The grounded classification was with this lead actually almost 180 movies that we had decided to do it like the so so we were cutting a 2.5 millimeter diameter cutting balloon for the twisted artery to get a calcium and then subsequently we also plus please plus and then we also dilated the proximal segment with a 275 millimeter diameter cutting balloon for its self-reached process at multiple points. I would like to tell you that the austere of the everything I was watching almost 100 almost 200 degrees of 240 degrees classification. So our plan was to include the size and come right up to the austere. So we use the small balloon to dilute the entire house and the austere. Plus, the project we look something like come forward, come forward, come forward. So if you can watch here, I don't know if you can see this we just saw small perforation which happened because of the cutting balloon of the distal LED dilation. And we thought that we can optimize the experiment. We thought that this perforation might be a contained perforation. And there was good regard fusion with the echo on the table. So a stable patient, we decided that it might be a contained perforation. So we just went ahead and dilated with the went ahead and strengthened muscles. And after strengthening the 2.524 millimeter strength, we are using post dilation 2.5 millimeter balloon for prolonged inflation. So we are using to prolong the inflation of this balloon for almost 2 minutes each of that is. So, will follow this. Yeah, very follow this. So nothing else this system. We are doing the long version of 2 minutes each on the side, so as to contain the small information that which at this point in time was not causing any compromise of the part of the fusion. So it is, probably a contained perforation or a large pouch of almost the same thing. So we are trying to clear that. In case the patient develops the regarding refusal of hemodynamic compromise, or if the perforation increases, then we are prepared to put in the cover stent in this artery. So we are trying to avoid a cover stent in this artery. That's our strategy.
Oh, okay, Dr. Rishi, but I think we'll switch to the other lab and we'll listen from you probably tomorrow what happened. Please bring us the detailed. Yeah. Yeah, thank you for nice presentation. Please switch to the Sushruta lab. Yeah. So Dr. Anil, we are with you now. So distal vessel is what, 2.75? Okay. Yeah. And how is the diagonal ostium on the OCT? Yeah, this is the diagonal. Yeah. So you'll go with the 2.5 stent and do a proximal optimization. Yeah. So we have 7 more minutes to go, Anil. So 2.5, 38? Yeah. Right.
So this is a European and 60 micron thickness by releasing quite small content inside.
Is it with the polymer? Is it a polymer or polymer free? Okay.
So this is the
So show us the fluoro, please. Yeah. So put the fluoro on the main screen, please.
You're still seeing ACT only?
Yeah, right. Fine.
So
Distal
far, so
looks
good.
okay. Yeah. Landing zone is okay. So what is the deployment pressure? 10, 11? Okay. Result looks perfect, even without optimization. Because we are having only 2 minutes time, we like to get one final good shot, and you can do your proximal optimization offline. You have got a wonderful result. Yeah. So no further procedure in the diagonal because it's a flowing vessel. So we'll be going offline, Dr. Anil. Thank you for the wonderful presentation. We'll thank your team from West Bengal CSI Forum. Thank you so much. So we call up the session along with my co-chairs and panelists. Thank you. Next session.
Thank you so much. Big round of applause. We end the session over here. Moving on to the next session. Imaging and physiology of calcified lesions in CAD. As chairpersons, I would like to invite on the dais Dr. Pankaj Manoria, Dr. Rajiv Bhagaratta, Dr. Kashinath Ghosh Hajra, and Dr. B.B. Bharti, requesting all of you to please come on the dais to grace the chair. Thank you so much. Also, as moderator of this particular session, would like to invite Dr. Debojyoti Sarkar, Dr. Dibyendu Khanra, Dr. Debhargo Dua, Dr. Gopal Chandra Ghosh, and Dr. Joy Sanyal. The first speaker of this particular session IVUS update, Dr. Devdatta Bhattacharya. Thank you.
From Jaipur. Which place are you from? From
Good afternoon, everybody. And whenever there is any calcification in the coronaries, we are very much scared of it for the proper deployment of the stent, because assessment of the lesion in the calcification, that is very, very important before you proceed for the PCI. And why is it so much important? Because that is always fraught with all the complications, perforation, under deployment, and even after the successful procedure. And even after the successful deployment of this stent, post-procedure, there is more chance of restenosis and all these things. So that's why the preparation of the lesion is very, very important, and that can be done only after proper evaluation and assessment of the calcified lesion. May I call upon speaker Dr. Raja Nag, the OCT update. Dr. Nag, please. Dr. Devdatta Bhattacharya will present the IVUS update on the imaging of calcified lesions in coronary artery disease. Dr. Bhattacharya, please.
Thank you. Just waiting for my slides. Is it? Okay. Oof. Hey, Baba. আমি এখানে দেখতে পাচ্ছি না রে স্লাইড গুলো ও এই যে পেজ ঠিক আছে okay thank you respected chairpersons. So my topic is on IVUS guided calcific lesion assessment, and then I think Raja will talk on OCT and Sunip will talk on physiology. Is Dr. Banerjee here? Sunip achen pasher ঘরে okay. So this is data from a very old paper, and this is Mintz, Gary Mintz et al. This is circulation 1995. And at that time, IVUS was not as developed as what it is nowadays. But however, what he set out to find out was in lesions in 1,155 target lesions, it was a study examining whether calcification was there or not. And it was a study between angiography and IVUS. And in these lesions, we know that calcium is present in, it's very ubiquitous. It is present in most of the coronary lesions. We have a calcium score that tells us about presence or absence of coronary artery disease. So it may not be significant in terms of intervention, but it is present. So this was a study, and they looked at target lesions except in saphenous vein grafts and Lima arteries. So these are native coronary arteries, 1155 target lesions, and they looked at the lesions both by IVUS and angiography. And what they showed was that IVUS, in 73% of the lesions, there was calcium. And when you examine by IVUS, but however, if you examine by angiography, it detected it only in 38%. So IVUS is a much more sensitive imaging modality when you are looking at calcium. And sometimes you won't be able to see the calcium on angiography, and IVUS will show you. In terms of how many quadrants are affected, whether it is severe, whether it is moderate, all these data, IVUS is more sensitive than angiography. It also tells you whether it is superficial, whether it is deep, whether it is a combined superficial and deep. It tells you about the length of the calcium. It tells you about, and increasingly we have learned new things. It tells you about calcific nodules. Calcific nodules was not known at the time of this paper by Mintz et al., but nowadays we know how to look at these things and how to strategize in terms of PCI. And this is a much later paper by Wang and Matsumara, and this was published in JACC Imaging 2017, and this was a study evaluating target lesion calcification assessment via angiography versus IVUS versus OCT. And this was across 440 patients with stable angina. And the IVUS versus angiography detection differences were consistent with findings as previously reported by Mintz et al. So this was 1995 data, which was validated again in 2017. And this data showed that IVUS detected calcium in 82.7% of the lesions with a mean of with 127 mean angle of calcium versus angiography, which detected it only in 40.2% of the lesions, and OCT, which detected it in 76.8% of the lesions. So these two papers, they are for just our understanding how powerful imaging tool IVUS is in terms of detection of calcium. And if you are doing angioplasty and if you are suspecting that this lesion, there is a calcific lesion, IVUS is an excellent tool, and I will show you why. So angiographically visible, non-visible calcium at IVUS maximum calcium angle greater than 180 degrees. And the summary of this is that lesion with calcific arc of greater than 180 degree measured by IVUS, the main difference between those visible versus non-visible on angiography is calcium thickness. And this is a calcific lesion imaging assessment, thickness and reverberations on IVUS. We now have OCT, which we know has a better resolution than IVUS, and it has certain advantages over IVUS. And I'm going to show you the comparative comparison between OCT and IVUS here. The main advantage of OCT is when you are assessing thick calcium. And in IVUS, what you find with thick calcium is you cannot see anything beyond it. But in OCT, you will be able to see something. In thin calcium, again, regardless of thick or thin calcium, you are not able to see the structures beyond. But here you can see it very nicely. Thin calcium in both these pictures, you can see beyond it. But in this picture, you can see that you can't see a lot. But nowadays, if you put this on dynamic imaging or you do a pullback, what you look for in cases of thin calcium are reverberations. So if you have, so you can see one reverberation here, one reverberation here. And if you have reverberations, this means that this is thin calcium. This is not thick calcium. If you can't see anything at all, then it is more likely to be thick calcium. So this is a way of looking at it, because we look at three things. We look at the arc, we look at the thickness, and we look at the length in deciding and grading the severity of a calcific lesion, about whether it will give to conventional balloon dilatation preparation, or whether it needs more calcium modification by either rotablation or IVL and cutting balloons and stuff like that. So again, this is again a picture, and I think it is very instructive here. So you look at thick calcium, you can't really see anything. If you have a thick, these are corresponding images, IVUS and OCT. On the other hand, if you have thin calcium, you can see these reverberations. So so you can look at this and you can think, oh my God, will my stent expand or not? This is a big arc of calcium all around, but if you are seeing reverberations here, you think that probably it will. And the easy way to find out is actually inflate your balloon and see that whether the balloon inflates or not before jumping into some kind of serious calcium modification. This, on the other hand, is less likely to be modified by balloon dilatation. What will happen is, if you inflate your balloon, it will expand in this direction. You will get a stent expansion in this case, but it will be sort of an eccentric expansion. So target lesion detection, calcium detection, angiography versus IVUS versus OCT. I think we have already said this, but I will read out the summary. Evaluating in a contemporary imaging study, this is again Wang and Matsumura. Target lesion calcification assessment via angiography versus IVUS versus OCT across 440 patients. With stable angina, 30.2% of IVUS detected calcium. Calcium was either not visible by OCT or was underestimated by OCT, mostly due to superficial OCT plaque attenuation. So this is an important thing. There are some images in OCT, and we have faced this, where you think, what is this image? What am I looking at? And because you won't be able to see the classical images that I showed you, like this or like this, concentric calcium, calcium that has two borders there. With a lighter intensity in between the two borders, you won't be able to see it, and IVUS will always see it. IVUS sees it better. So this is the advantage with IVUS. IVUS will always tell you that calcium is there. And now we have a OCT based calcium scoring system, and this is by Fujino et al. Published in the Euro Intervention Journal 2018. And you look at, as I was saying, you look at the angle, the thickness, and the length of the calcium. Angle by angle, we mean the arc of the calcium. So if it is less than 180 degrees, it is not that significant because the vessel has scope to expand in one direction. If it is greater than 180 degrees, you give 2 points. You look at the thickness. If this is less than 0.5 millimeter, you can measure the thickness very well on OCT, which you can't do on IVUS. Okay, so they can afford this. And if it is greater than 1.5, it is 1 point, and length less than 5, 0 points, greater than 5. So you can have concentric calcium, but the length is also, it plays a part, a significant part in your assessment, and you're giving points to it. The most important, however, is the angle. So if it is 270 degrees or 360 degrees, this is very, very significant. And so we have a total score of 0 to 4 points. And as the score goes higher, the lesser is your likelihood of stent expansion if you haven't cracked the calcium. So if you come to IVUS, you can, as I have told you, there is this obvious problem with IVUS is that it always cannot give you the thickness of the calcium. You can easily calculate the arc of the calcium. You can say whether it is thin calcium or thick calcium by looking at reverberations. You can see, you can diagnose this appearance here, whether it's a calcific nodule or not, and you can easily size the stent diameter. And then you do a long view layout, and you can measure the length of the calcium. So you can measure the length, you can measure the arch, you can have an idea whether it is thin or thick calcium. You can detect calcified nodule here, though not as well as OCT, but these are the things that you can do. And based on that, you have this IVUS guided calcium lesion scoring to predict stent expansion. And this is by Eiicon Minerva, published in Circulation 2021. And so we begin with, is there angiographic calcium? Yes. Is the IVUS maximum calcium arc greater than 270 degrees? Yes. Is the calcium score calculation 0 to 4 greater than 2? Then it is significant. Consider greater than or equal to 2. Then it's significant and you consider atherectomy. So for the first two, yes, you have angiographic calcium. IVUS greater than 270 degrees. For these, you have 1 point. Okay. And if it is greater than 2, then you go for this calcium expansion by atherectomy. So the effect of atherectomy on stent expansion, you can see that if it is a balloon only procedure, as the calcium score increases, FOBA does not work that well. So there is a crossover point between 1 and 2 there. And you can see that atherectomy works much better in regards to stent expansion. And the expansion is given on this side, 70, 80, 90, 100. So this is an example of a patient with a calcific lesion. And you can see that the two types of rotabar has been used, 1.25, then 1.5 non-compliant balloon, and then a rotabar with a 2, and you can see the difference. So after the rotabar, you can see that some amount of calcium has been scraped off, because now you can see the reverberations, but the lumen is not large enough. So there a 2 millimeter bar has been used, and then this is the final result, and you can see that the stent has been well expanded. So I will finish with a case here, and this is a case that was shown live this time. How many minutes do I left? Okay, I have 1 minute. So this was done in Bhubaneswar by Dr. P.K. Shahu, and I was his interpreter. And I will show you the case briefly. So what he was doing was old inferior wall MI, RWMA in the RCA territory, and he had done the RCA. And then after that, there was very bad disease in the LAD, and I will show you. So this was the RCA result. And then you can see the LAD. The LAD is very badly diseased. You can see angiographic calcium. There is osteoproximal disease in the LAD. And you can also see that the left main is diseased. And then there is a bifurcation stenosis at LAD D1. So this is the lesion that was being treated, and we started off by doing IVUS, and I will show you the IVUS. That's not this one. So this is the IVUS, and you will see that this is the IVUS pullback. Sorry. And I will just. So there is my commentary there. I have muted the commentary. And what I am saying here is that we can see this arc of calcium here as we are going up. And as we go up further, you can actually see, if you look at this region here, you can see the length of the calcium here. And this is the critical region that needs to be treated. And we are looking at that region. We are looking at the arc of the calcium. We are coming into the left main. And what my interpretation in this case was that this could probably be cracked without doing, this could probably be cracked without doing IVL or rotablation. And so what we did was, so this is the initial part of the case. So what Dr. Sahu did was he did a LAD D1 bifurcation by a crush technique, mini crush technique, and then this is the IVUS after that, and you can again see that we are measuring the distal landing zone. So we are now going to stent the LAD. And here, if you look at this long view layout here again, you can still see this calcific zone here. So for those of you who are in the chair, this is the calcium region that we can see, and we have not yet modified this. So we are going to modify this, and we looked at that region and we saw reverberation. So I said, just go ahead with a balloon dilatation there. And I'm going to show you what they did. So
how many slides you have?
Just I've finished. This is just a run.
Sorry.
I'll take 2 minutes. So this is, again, we are looking at that osteoproximal LAD, and so you can see they have implanted the stent there, and as we had predicted, the stent is well expanded there. And the patient was very sick, going into failure at that time, and we were asked by the moderators in the case to finish it quickly. I think Dr. Samuel Matthew was there. He said, just finish it quickly. The patient was not tolerating this dilatation in that osteoproximal LAD very well. But here, I think if we had to do rota and a lot of other dilatation here, the patient probably would not have tolerated that as well as this simpler procedure. So IVUS helped us in assessing this lesion. We did some post dilatation, and I think I will show you the final result. So this is the IVUS, and this is just from the proximal LAD into the left main. And what I'm doing is I'm scrolling up and down and showing the various parts of the stent that was expanded. You can see it. You can see that this osteoproximal part of the left main stent is quite well expanded. And I think we are at the end here. So, and I think that is the end. So that is there you can see Dr. Sahu being congratulated by everyone. So this is what we can do with IVUS. We can look at a lesion, we can tell you the length, we can tell you the arc of the calcium, we can look at the reverberations and predict whether it is going to crack or not. We can look at calcium nodules and tell you that this needs a different type of modification. And all these have a bearing on the success of the case. And I think IVUS, it is a very, very powerful tool. We have newer modalities of IVUS. The catheters are more, you can negotiate the catheters across these lesions better. And if you have a calcific lesion, IVUS should be very high up on your list in terms of intravascular imaging. Thank you very much.
Thank you, Dr. Bhattacharya. Thank you. Thanks for such a lucid talk. Just a small comment. Okay, after this. Okay, we'll have the comments and the questions after that. Okay. So we move on to the next part of the session, which will be conducted by Dr. Raja Nag, and who shall be talking about another modality of imaging, which is OCT update. And let's see how it is useful to differentiate uses of the two modalities, that is IVUS and update, IVUS and OCT. Welcome, Dr. Raja.
Thank you, sir. Good afternoon, everyone. So to continue with the imaging in PCI, so my previous speaker has already shown very beautiful images of IVUS and how we can predict calcium. But now I have been asked to talk about OCT update. And I can tell you that what I'm going to show you is not only update, it is breakthrough technology in OCT, which is going to happen. I was in Europe ECI recently, where I happened to see this presentation, and all the slides courtesy are from EuroPCR. So the learning objectives would be to look at the limitations of present day OCT or other imaging. And I will be presenting to you the third generation high frequency OCT. So this is a saying, human heart is full of mysteries, but solving some of them can mean the difference between life and death. So what are the current day limitations of OCT? One is speed. One is the length of the scan, which is limited. If we have a long LED, then we have to take 2 runs instead of 1. Then we are worried about the volume of contrast which we give in patients who have nephropathy or renal dysfunction, and the time consumed. So let us see what can be done about all these problems. So this is an angiogram of a diffuse long segment LED disease. And what would we do in this case? Should we pre-dilate or should we go directly with imaging? So we can see there is a very tight lesion in the mid segment before the large septal, where it doesn't look like any imaging catheter would pass through. So this is where high frequency OCT helps. And let us look at some of the trials of imaging in which we have already seen that the benefits of PCI, complex PCI, are much better, and the outcomes are much better if we have long and diffuse disease. So these are some of the excuses we have at present with present day imaging, why we don't incorporate imaging in most of our cases, and mostly so in complex cases. It takes more time, difficulty in crossing lesions with tight lesions or small vessels, and the additional contrast load. So the intravascular OCT is very important in pre-PCI planning and imaging. And pre-interventional imaging is more impactful on decision making. And as you can see from your right-hand side of the graph, that 80% of the operators who were given imaging after an angiographic decision changed their decision 80% of the time. So catheter size limits crossing in severe stenosis with the present day OCT technology, also the IVAS. And the limited pullback length and scan range can miss key information with limited pullback speed and also as the contrast volume. So this is high frequency OCT. As you can see, even the catheter size is much smaller than the present day OCT. And with a simple hand injection of 10 ml contrast, we can scan a length as long as 100 millimeter within 1 second. So this is where the breakthrough technology comes in, where we can get clear visible images with 10 ml contrast and scan up to 100 millimeters. So I will show you some of the images which were shown in the recent EuroPCR. So this is a still image, and this is a Gentuity OCT catheter system. And in your middle of your screen, you can see the
Sir, proximal LED stent is looking very good. Do you still think that we need to treat the D1? Is ostium looking fairly okay? Yeah, that. Okay, okay, sir.
I think provisional stenting will be enough for this patient.
So what are the balloon sizes? Almost time is almost over, sir. So are you planning for Ivers of both LAD and D1?
I think flow is quite good, actually. You can leave it there.
D1 proximal is looking hazy. We need to stent probably, sir.
It's quite a large flap, so I think.
Large flap.
Dr. Sharma, we are running out of time. One suggestion, why don't you put the diagonal wire in the main vessel? The diagonal wire in the main vessel. The risk of perforation is very high.
So what wire is this? This in SARC?
I think keep this wire in play in the branch because we have a dissection proximally.
Sir, we are running out of time. It's already 20 minutes late.
Dr. Sharma, I think we conclude this session and tomorrow we can see what you've done and we let the next session. It was good. No, but it was a good learning for all of us. Thank you. Thank you very much.
Thank you. Thank you, sir.
Thank you so much. We end the session over here. We move on to the next session. That is a lunch on session. Panel discussion on STEMI. Are we doing enough in STEMI care? As chairperson of this particular session, I would like to invite Dr. Monotosh Paja, sir. I would like to invite Dr. Amol Banerjee, Dr. S.C. Mondol, Dr. P.K. Deb. As moderator of this particular session, I would like to invite Dr. Shuni Banerjee, Dr. Shomo Patro, and Dr. Rajanag.
It will be discussion only. Or some speaker is there. Hello. Now, what is the objective? Just we'll discuss. No other person is there. Anybody coming?
Just together, everybody joins it. So the speakers are having managed to speak in the second. But basically the panel discussion, the chairperson of the model. So rest of them who are in the second, their session is still going on.
Then what to do now?
So we can just wait for some from 3 o'clock, we can have this two sessions. Because it's, they are both of the same. Assume, we can speak with other speakers.
Nobody here.
Few speakers are on that road. Session is going on. You are having lunch. So I just had a word with even so people with two sessions from 3 o'clock.
The session. You have to clap the session at 3 o'clock because speaker for the TEMI there at 3 o'clock.
Chairpersons, they're not here of this particular panel discussion.
Nobody here.
No. Few doctors are in that session, in that room, and I guess we were having lunch there also.
Then announce it. Announce it. Soumitra? Yeah. The discussion is that whether are you doing enough in STEMing?
Good afternoon. Now this STEMI is a very important problem, and it is a problem which has to be taken by the government. And in Tamil Nadu, they have taken this in the governmental form, and in the governmental hospitals, they have 24/7 STEMI-care program. I don't know whether such program exists in all parts of India. And once the patient lands up with acute coronary syndrome and STEMI, the patient is taken by the ambulance 108, and on the ambulance itself, expert advice is available, and the patient is directly taken to the intensive coronary care unit in the tertiary care centers under the care of the cardiology department. And depending upon the availability of the cardiologist, the patient is immediately wheeled into the cardiac cath lab. This is what it happens in Tamil Nadu. There is a great insistence that the door to needle time and balloon time has to be brought under 6 hours of care. Now, whether this is acceptable in all parts of the country, whether this can run in all parts of the country is a big problem, because there has to be a correlation between the information from the patient side and carrying of the patient by 108 ambulance to the secondary or tertiary care center where the immediate intervention is possible. So the insistence is that if the patient is closer to the tertiary care center, he is taken to the big hospitals. Whereas if the patient is in suburbs or in far off places, they are taken to a primary care center, where initially the thromboinvasive strategy is taken up. The patient is thrombolized and then shifted to the tertiary care center. What is your opinion of this pattern, sir? Whether it is available in West Bengal or
No, unfortunately not, although the government medical colleges are coming up in various corners of the state. Almost every district has a medical college now, but the cardiology departments are not there. But that is the second step. But as you said, a well-coordinated system has to be instituted at the behest of the government. That you are very right, and we are in fact fortunate to have you here, so that you mentioned the Tamil Nadu concept of STEMI care, which has to percolate to other parts of the country. I'll go one step backwards and say that the program should start from increasing patient awareness, so that the moment they have chest pain, that should be communicated to the one toll-free number or whatever number that you are given, so that the ambulance arrives on time, because the patient care has to start from there. Unless the patient is made aware that time is muscle, any time that you waste drinking antacids or doing other things, putting sublingual nitrates, is just a waste of time. So if your pain is lasting longer than 20 minutes or at least 30 minutes, then you should immediately get in touch with the closest medical help that you have. If this comes at the government level, you should be given a number where you have to dial for the ambulance to arrive. Then you mentioned about the paramedic help. If we can develop the system to that level, maybe out of hospital thrombolysis can even be promoted. But I think we are still away, quite some distance away from that kind of a goal. But even if the patient can reach the nearest hospital with the intensive care unit, where at least the first treatment, that is thrombolytic care, can be given, then maybe patient can be either treated in the same hospital if it has a cath lab as part of pharmacoinvasive therapy, or of course, if the cath lab is 24 hours into 7 running, we can have the facility of primary PCI. But the most important thing, patient reporting, being transported to the nearest state-of-the-art medical care, the best care
Chhattisgarh, even in Odisha, the situation is not the same. Even if the patient is being sent after 24 hours of thrombolytic or rather fibrinolytic therapy, whatever might be the fibrinolytic agent you are using, but you should send the patient for angiography is whenever it is possible and feasible. That should be the lesson on the primary care physicians.
So all the mechanical complaint, if it is given at the right moment, at least block level or the district subdivision level, so all the mechanical complications and arrhythmic complications will drastically reduce. Whether MR or this VSD, all the mechanical cardiac rupture, all the things will significantly reduce. All MACE, the international study, everybody already prove it.
Any other comments from the floor or? Yes, please. Might not work. Yes.
A very high volume center in Kolkata where, certainly we do a bit of primary angioplasty, but if you're talking of hurdles, the first thing, let's put one thing in perspective. In Kolkata, well, if you want to compare between pharmaco-invasive and your primary angioplasty, of course, we have to think of primary angioplasty per se. Let's not discuss about pharmaco-invasive as a care of STEMI when we are sitting in a major city like this. Now, whether it is possible to do a primary in a place like, say, a remote part of the state or not, that's a different question. But there are a lot of hassles, starting from the patient awareness, one. Number two, what I would like to put forward today is physicians' intentions, one. So that is something which during my initial days of practice, what we used to see, or honestly, probably I had also done it several times, that thrombolysis for the night and angioplasty for the morning. This is something which has to be understood by the physicians, by the cardiologists, and I had insisted my center that we should ascribe one cardiologist for the night who should take up all primary PCI per se, but this never happened. There are a lot of hassles which comes on. First is money, then is your whatever Shastro Shati or scheme and whatever, and then they start looking for the physician, and that kills no less than 90 minutes or whatever. So first is awareness, and number two is physicians' intentions, that we should really volunteer to go ahead in spite of whatever hassles is there. So this is my point actually. But pharmaco-invasive, well, in the remote part of the state, pharmaco-invasive is probably a bailout option if you can't transfer the patient to a center. Thank you.
Dr. Datto,
you have rightly pointed out that the first option should be primary angioplasty.
Of course.
When everything is being satisfied and all the logistics are being available. But you know, that is usually in city like Calcutta or some other, say might be possible in Burdwan or some other cities also where Kerala facility is available. But if we look at the India as a whole, then comes the question or the issue of pharmaco-invasive therapy. So there should not be any confusion among the cardiologists, primary care physicians, secondary care physicians. The treatment of choice of STEMI is primary angioplasty. But when that is not being satisfied, that is not feasible, then we should go for pharmaco-invasive therapy with good scientific knowledge and intention.
Yes, intention is the main issue.
Yes.
And going ahead with a pharmaco, say a thrombolysis, 4, 5, 6 hours down the line is actually no good. When we are talking of physicians' intentions, we have to keep that in mind also, that it's 4 hours, 5 hours down the line. Let's not just pump in tenecteplase for sake of whatever.
Dr. Dotto,
Yes, sir.
all practical experience, because of Sastosati, all the people has a heart attack, they're coming up to 3 to 4 days later. And all the interventional cardiologists doing the angio and doing the angioplasty. What is the rationality? You see, I believe it is right to do this angio.
Sir,
Definitely.
I would.
And if there is a critical lesion,
Yes, sir.
and the infarct zone, as well as the non-culprit lesion, that should be also.
That is,
accordingly.
I just summed up in 2 words, physician's intention, sir. So we know how we work. We know how we work, and at times we have to do. Suppose you get a occluded LAD 3 days down the line, and you are talking of viability and all, nobody is going to take it. You open up, put a stent, people are happy to see a flowing vessel. We know what we have done. But if you are talking of the best care in STEMI, I think the first thing should be awareness. Number 2 is physician's intentions. By physician's intentions, I mean a person in the periphery who can transfer the patient within 2 hours to a cath lab facility should not go ahead with a thrombolysis. He should try heart and soul to transfer the patient to a facility. That is my point only, because if states like Tamil Nadu can do it, if we have intentions, we have good intentions, we can also do it.
Another important thing, as even in the patient reaching to 24 hours or the 12 hours, whatever may be, if the chest pain, definitely you have to do the angioplasty. But question of that, even in primary angioplasty, whether you do intervene the all arteries or stage procedure. Just study the 7 days before the PCR already vascular trial, biovascular study. They demonstrated to as many vessels, immediate culprit vessels dilated, as well as the non-culprit to be in the same setting because of cost efficacy in the country. Second thing, you should not wait for the next stage procedure, because if you wait for the stage procedure, then a chance of unplanned revascularization coming up, and MACE and death also will be later on. They discourage the stage procedure. It is better to do immediate procedure as the primary culprit as well as the non-culprit lesion. If preferably the FFR is done, or without FFR.
I think that is what
complete revascularization. That is biovascular.
As long as the
But in
patient
BioVas trial, basically, they have seen that 30 days, in fact, that incidence of infarction is slightly less in BioVas trial. But BioVas trial, they have taken only 2 vessels, not more than 2 vessels. If they have seen that it will take more time, or patient is renal compromise, they don't do it. So the same thing, that if you do the stage procedure within 45 days, as we've seen complete trial and BioVas trial, long-term, in fact, result is almost same. BioVas shows that is non-inferior to stage procedure in long-term result, but only 30-day result. There is a few more myocardial infarction in complete trial than in stage procedure, than in the all the vessels you can do in the same time in BioVas trial.
Thank you. I think we are running into the next session. So Dr. Amuthan, your final comments. I mean, since there is a state-sponsored program, what is the percentage of people receiving pharmacoinvasive primary PCI, and at the end of the day, no reperfusion? What is the actual figures? I mean, do you have any?
I don't have any actual figures, but this system is working very well. Whenever the patient gets into problem of chest pain, he simply dials 108. The ambulance comes, it takes over and takes to the nearest hospital. Whether it is a district hospital or a metropolitan hospital, they take to the government hospital. One valid point which you have suggested is that whenever a primary care physician sees the patient and refers to the secondary or tertiary care center, he should not go ahead with the thrombolytic therapy if the patient is within a distance of 1 hour. So that is a very important valid point. So whenever there is a possibility for primary angioplasty within 3 hours, the patient should be shifted to the tertiary hospital where the cath lab is available and where these facilities are available. At that point of time, the primary care physician, if he gives a thrombolytic therapy, we will have to unnecessarily wait for another 6 to 8 hours to go in for the secondary angioplasty. So this is a very, very valid point which we have to carry, and that is the take-home message. I thank West Bengal branch of Cardiological Society of India for having invited me for this August conference, and I thank especially our Amal Kumar Banerjee and Dr. Soumitra Kumar for this. Thank you very much.
Thank you, sir. So please conclude. And Professor Mondol, you are in charge of the largest teaching hospital, at least cardiology teaching hospital. And so you can suggest to the government to come up with some dial number like 108, which can be instituted in our state also. So with that suggestion, I think we can sum up the session here and hand over to the MC for the next session.
Thank you so much. We conclude the session over here. Move forward to the next session, session STEMI. I would like to invite the chairpersons on the dais, Dr. Bishokesh Mojumdar, Dr. B.R. Nath, Dr. P.S. Banerjee, Dr. Ashok Kaur, Dr. Kishan Agarwal. Requesting all of you to please come on the dais to grace the session chair. Also, as moderator of this particular session, I would like to invite Dr. Pashobendra Choudhury, Dr. Avik Karak, Dr. Moinak Mukherjee, Dr. Meeta Bar, Dr. Shonali Shorkar. Requesting the moderators to please grace the chair. The first speaker, culprit only versus complete update, Dr. Shilanjan Roy.
Good afternoon to all the august audience, respected chairpersons, moderators. My first talk on this STEMI update, culprit only versus complete revascularization. Culprit only versus complete revascularization strategies to treat multivessel disease in STEMI. Now, this topic or this area in interventional cardiology has been an area of controversy since long. We know that approximately 50% of the patients who are presenting with STEMI, they have at least one other vessel having a significant, at least more than 50% stenosis in a non-culprit artery. And presence of obstructive lesions in a non-culprit artery has been historically shown in the scientific literature to be associated with a worse short and long-term outcomes. Now, whether these non-culprit lesions along with the infarct-related artery needs revascularization has been controversial. Old guideline recommendations, they advise against non-culprit vessel PCI in the absence of any spontaneous myocardial ischemia or intermediate or high-risk features and invasive assessment. Now, the question is that compared with the culprit-only percutaneous PCI, is a strategy of complete revascularization with multivessel PCI can be associated with a decreased cardiovascular mortality in STEMI, and whether the association of fractional flow reserve or angiography-guided complete revascularization approaches are used. Now, as you know, the present guideline recommendations, the ESC 2017 guideline, after a series of studies, namely the starting from the PRAMI study, the Dynamic 3 Primality, and the culprit trial, they have upgraded the recommendation of complete revascularization in PRAMI patient from class 2B to class 2A recommendations, and they are based on mainly on these 4 trials. We'll briefly go on these 4 clinical trials. Now, which has shaped this guideline recommendation, it mainly is driven by these 4 trials: the PRAMI trial, the complete versus the lesion-only primary PCI, or the culprit trial, the Dynamic 3 Primality, which is an FFR guided trial, and the compare acute trial. All these studies has been published in and around between 2013 to 2017. Now, in these studies, if we dissect the studies closely, we'll see that the PCI of the non-infarct artery was done either during the index procedure itself while opening the IRA in PRAMI and in compare acute study. It was staged during the same hospital admission in Dynamic 3 Primality, and anytime before discharge, which can be on the day of index procedure or before discharge anytime in culprit trial. Now, indications for PCI non-IRA was angiography guided lesions with more than 50% stenosis in PRAMI, more than 70% stenosis in culprit. So in these two trials, it was primarily angiography directed and FFR directed revascularization in dynamic 3 primality and compared acute. It was seen that these 4 randomized clinical trials. First is the PRAMI trial, which was done between 2008 and 2013 in 5 centers in the UK. Infarct-related PCI versus the other group was randomly assigned either conservative management or the non-infarct-related PCI. It was seen that the patients with STEMI and multivessel CAD undergoing infarct artery PCI, preventive PCI in the non-infarct artery was with a major stenosis, it significantly reduced the risk of adverse cardiovascular events as compared to PCI, which was only limited to the infarct-related artery. The culprit trial was a trial with similar design, where in one arm, the patients were stratified based on infarct location and symptom onset, and the primary composite was all-cause death, recurrent myocardial ischemia, or repeat MI, non-fatal MI, heart failure, ischemia-driven revascularization within the next 1 year. And it was seen that in the primary composite endpoint, it occurred in 10% in the complete revascularization group versus 21% in the infarct-related artery only revascularization group. So the complete revascularization group fared significantly well, and it was statistically superior seen in the complete revascularization, and the trend towards benefit was seen very early even after the complete revascularization. The curve diverged and achieved a point of statistical significance even only within 30 days after the procedure. So it was quite a superior trial, though neither of the primary endpoints was statistically superior, but all showed a trend towards superiority, which culminated totally into a statistical superiority. So the conclusion was that in culprit trial with a multivessel disease, complete revascularization possibly lowered the rate of composite primary endpoint at 12 months compared with treating only the IRA. Another similarly designed trial was a dynamic 3 primality, but the differentiating factor in dynamic 3 was that these revascularization in the non-infarct artery was guided by the FFR values, and the follow-up was longer for up to almost 2.5 years. Events comprising of the primary endpoint was recorded in 22% of the patient who has PCI of only the infarct-related artery versus only 13% who had complete revascularization. So this study also established the superiority of total revascularization or complete revascularization post-MI. Dynamic 3 primality, a CMR sub-study analysis showed, however, that complete FFR-guided revascularization who were enrolled into this complete revascularization, though the primary endpoints was reduced, but CMR-guided final infarct size LV function or remodeling was not significantly improved compared with culprit-only PCI. So there was a slight, contentious issue. Now, interpretation in the light of dynamic 3 primality was that these effects were primarily driven by fewer repeat revascularization and not hard endpoints like cardiovascular death, because all-cause mortality and non-fatal infarction did not differ between the groups, that is infarct-related artery and complete PCI. Another big study was done by Hamza et al. That primarily studied the diabetic patients with MI and which replicated almost the similar results, that diabetic patients who underwent a complete revascularization in the same sitting or during the index hospitalization possibly fared better in terms of primary endpoints of death, MI, repeat revascularization. Compared acute trial was a similar trial that was published in 2017. It was also an FFR guided trial. FFR was performed in both the groups, and the uniqueness of the trial was that even after performing FFR, both the patients and the cardiologists were unaware of the findings of the FFR, and they were randomly assigned between the trial group and the control group. Primary endpoint was similar, all-cause death, non-fatal MI, and revascularization. And results were seen. The primary outcome occurred in 23 patients in the complete revascularization and 121 patients, which were statistically equivalent to 8 versus 21 events per 100 patients. So the group which received complete revascularization FFR guided fared significantly better than the patient who underwent only infarct-related artery PCI. So the conclusion was similar as it was drawn from the PRAMI trial and the dynamic 3 primality. Prague was one of the trials similarly designed. However, it diverged from the PRAMI culprit. That Prague trial it was published in the similar trial time, it failed to show any significant benefit in the patients who underwent complete revascularization. Some points has been, proposed by the investigator himself regarding the design of the trial, which might be leading to this trial being a negative trial. And the landmark trial, which was published in 2019 NEJM, was a complete trial. Everyone was waiting for the trial because it was a large trial, adequately designed and powered to study the hard endpoints of mortality benefit in this subgroup. And it conclusively proved this complete trial. And in complete trial, important to note was that the staged PCI was done either during hospitalization or within 45 days after hospital discharge. So a time was provided after the patient was being discharged. Exclusion criteria was an intention before randomization to revascularize a non-culprit lesion, a planned surgical revascularization in previous CABG. They were excluded from the study. Other patients, they were incorporated. Primary endpoint was CV death and new myocardial infarction. Secondary endpoints were almost similar among the other studies. And you can see that cardiovascular death, it was the first trial to show that the CV death was significantly improved, the first, or myocardial infarction in this complete trial. So complete revascularization was associated with a reduction in the cardiovascular death and MI, and it was the first trial to show conclusively that it improves the CV mortality also without any significant increase in major bleeding or contrast-induced nephropathy. So these in short is a summary of all the trials that studied these infarct-related artery, revascularization versus the complete total revascularization in the MI patients, and more or less these studies has pointed towards a beneficial effect, be in terms of reduction in the target vessel revascularization, ischemia-driven revascularization, and even mortality benefit in the complete trial over the last 1 decade or so. This is a meta-analysis of all these trials. Almost similar study has been similar results. FFR versus angiography-guided non-culprit lesion PCI, because we have seen that FFR was used in compare acute and dynamic primality, whereas culprit and PRAMI was driven by angiography-guided revascularization. However, the meta-analysis showed that there was no significant difference when revascularization was done either by angiography-guided visual estimation or by FFR. There was no evidence of any heterogeneity. Same was done, same was seen in terms of same sitting or index procedure revascularization or a staged approach. That is whether the non-infarct artery was opened in the same sitting, depending on the operator's experience and expertise, or whether it was staged procedure. The result was similar. So the clinical caveats, one important thing to keep in mind is that in prospective study, we know that in natural history of atherosclerosis, nearly 50% of the events, future cardiovascular events, it occurred in the non-culprit bystander lesion. So in no way they can be considered as a, benign lesion. And interestingly, most of the culprit lesions who are responsible for the future events, they are usually angiographically mild at baseline, or the vulnerable plaques can be mild. An important subset, those were not included in these trials, were the subsets of cardiogenic shock, which was tried, because these do not apply to patients in cardiogenic shock, which was tried or tested in culprit shock trial, culprit lesion versus PCI versus the multivessel PCI and cardiogenic shock, which showed, however, entirely the opposite result, that showed increased mortality of the patients who underwent multivessel PCI compared with culprit vessel only PCI in acute MI with cardiogenic shock in both short-term as well as in long-term basis. So in patients with acute MI, whether STEMI or non-STEMI, in culprit shock, both even non-STEMI patients or NST-MI patients were also included with cardiogenic shock, and significant reduction in the primary composite of all-cause death and severe renal failure requiring renal replacement therapy was observed in culprit lesion-only strategy rather than with complete revascularization during an index event, with an very significant 8.2% absolute reduction in mortality within next 30 days. So in a nutshell, we can understand that MI with shock is possibly an entirely different ballgame, and various other factors like operator's expertise, dye usage, patient's hemodynamic status, renal function comes into play. So depending upon all these trials in 2017 ESC guidelines, they upgraded this complete revascularization indication from class 3, that is harm, to straight away class 2A, that is may be beneficial or likely to be beneficial in MI patients, mainly based on these 4 trials, that is PRAMI, Dynamic 3, Culprit, and Compare Acute, which has been further substantiated and consolidated based on the, this complete trial. Thank you very much.
Thank you, Sudhaditya. Now the question.
The non-culprit vessel angioplasty in the same sitting benefits only those who are having cardiogenic shock. If the patient is stable, the non-culprit vessel angioplasty should be staged. Either should be done before discharge. That's what most of the studies have shown. Before discharge, in the same hospitalization period, or afterwards. So this does not mean that complete revascularization should be done in all patients of AMI during the same sitting of primary angioplasty. But if there is cardiogenic shock, there should be all the vessels should be revascularized as far as practicable.
What is your opinion in practical day-to-day practice? Whenever a patient with the primary angioplasty patient has come, in that situation, you have to bail out from that situation fast. Next, you have to think of the other vessels. So if the patient has come in the right time, within 2 hours or 3 hours, then it is the choice of culprit vessel. But if they have come up to 12 hours or 13 hours, so I don't think the only culprit vessel can prevent the further mortality benefit, because you have to do all the vessel in that situation. If the primary angioplasty with the main artery, that means if it is the anterior MI involvement, in that case, when there is a main vessel involvement, LMC involvement, so single vessel will be more beneficial than the multiple vessels.
Any comment for the floor?
Thank you for the nice talk. The real world scenario we follow, we see, as operator, we see whether doing all the vessels we can do it successfully and the patient can go home safely. And if culprit only we do and the same indication, afterwards we can do the other vessels, we take that course. And also whatever according to the finance of the patient, so another point, suppose in some BSY or some whatever government or aid we are giving. So according to that, if we can do all the vessels at the same time, taking 3 or 4 stents, taking 5, 6 balloon, whatever possible, then there are some restrictions. So the real world scenario is really different. We do the culprit vessels. If we choose that it can be done in the same sitting, the other vessel smoothly, then we go for that. Thank you. This is my comment.
So if there is no other comment, we proceed to the next speaker. Role of hemodynamic support, Dr. Somnath Mukhopadhyay. Okay.
Good afternoon, respected colleagues, and thank you for this opportunity to present this topic, the role of hemodynamic support in STEMI, when and how. Not every STEMI patient comes us with who require hemodynamic support. So the indication for hemodynamic monitoring in STEMI, these are the indications like management of complicated acute MI, where to differentiate between hypovolemia versus cardiogenic shock, ventricular septal rupture versus acute MR, severe LV failure, RV failure, refractory ventricular tachycardia, difficulty in differentiating severe pulmonary disease from left ventricular failure with available non-invasive data, assessment of cardiac tamponade, and assessment of therapy also. So, as per the previous talk, cardiogenic shock in STEMI is a different ballgame. Now, the recommendations for management of cardiogenic shock in STEMI are like that. The class 1 recommendations are immediate PCI in cardiogenic shock if coronary anatomy is feasible, and if not suitable, then it is CABG. Invasive blood pressure monitoring with an arterial line is recommended. Immediate Doppler echo to assess ventricular and valvular function, loading condition, and to detect mechanical complications. And it is indicated that mechanical complications are treated as early as possible after discussion by the heart team. Oxygen mechanical respiratory support is indicated according to the blood gas. And fibrinolysis, whenever possible, whenever primary PCI is not available. Complete revascularization, again, already told, complete revascularization during the index procedure should be considered. The two-way indication, again, IABP, it should be considered in patient with hemodynamic instability, cardiogenic shock due to mechanical complication. Hemodynamic assessment with pulmonary artery catheter may be considered for confirming diagnosis for guiding therapy. Ultrafiltration may be considered in refractory congestion. Inotropes, vasopressors are needed for hemodynamic stabilization. Short-term mechanical support may be considered in patient with refractory shock, and routine use of IABP is not indicated, class 3. So this slide summarizes this talk. No shock, primary reperfusion. Impending shock, primary reperfusion along with hemodynamic monitoring. Shock, LV unloading, then primary reperfusion. So the philosophy, there is a time to rethink. We are very keen about dot to balloon time less than 90 minutes. But dot to balloon time less than 90 minutes is not associated with improved in-hospital mortality, especially in anterior wall MI and cardiogenic shock. Despite timely reperfusion, 10% mortality in index hospitalization and 76% of those who survive progress to congestive heart failure in next 5 years. Myocardial reperfusion actually is a double-edged sword. According to the Dr. Braunwald also, ischemia reperfusion injury can lead to cardiomyocyte death. In CRISP AMI trial, there is within 1 week of successful reperfusion, 40% LV injured quantified by CMR. So the myocardial perfusion is driven by several factors like coronary perfusion pressure versus ventricular filling pressure, myocardial oxygen supply versus demand. Reduction of myocardial injury is our utmost need. Only reperfusion could not meet the goal. Hence, the concept came dot to unloading, but the trial occurred, that was a failed trial. But since that, the important things are circulatory support to increase mean arterial pressure so that we have increased urine output, decreased serum lactate, ventricular support to reduce LV pressure and volume so that we have reduced pulmonary capillary wedge pressure, coronary perfusion to increase the transmyocardial perfusion to resolve STT changes or CKMB level. Now, that may be an approach for this situation. First, assess the patient and classify the shock. Stable blood pressure and perfusion status, stable respiratory status, go for revascularization of culprit lesion. If not, moribund patient, limited goals of care, palliative care. Then stabilize the patient. If low blood pressure, malperfusion, then consider vasopressor or inotrope. If hypoxemia, acidosis, mechanical ventilation. Diagnose the cause of shock and define hemodynamics by left heart catheter, right heart catheter, echo. If mechanical complication, surgery. Consider early mechanical circulatory support, the factors favoring persistent hemodynamic, electric, or respiratory instability despite initial measures, high-risk coronary anatomy, severe ventricular dysfunction, and caution against early MCS, low level of operator experience, vascular anatomy prohibitive, delay to primary reperfusion therapy. Then revascularize culprit lesion and stabilize the patient in ICU. Now, regarding pharmacological management, prompt management of hypotension and hypoperfusions are needed. Volume status should be replenished. RVMI is actually a different ballgame where right heart catheterization is important. Regarding inotrope, noradrenaline is preferred over dopamine in different studies. Dobutamine can be given in low cardiac index, high PCWP, borderline low BP without severe hypotension. And in case of non-hypotensive patients, dobutamine plus vasodilator are the choice. Now, regarding the other mechanical circulatory devices, we have continuous flow pumps or pulsatile pump. Pulsatile pump is our IABP. Axial flow, continuous flow pumps are Impella CP and percutaneous heart pump. Intracorporeal things are these. And tandem heart VA ECMO are centrifugal flow extracorporeal system. Regarding IABP, the regulatory mechanism depends on scale of diastolic pressure augmentation, scale of reduction in systolic pressure, degree of blood volume displacement, timing of balloon inflation and deflation. The advantages are ease of insertion, relative low cost, global familiarity. And in STEMI, routine uses are not recommended, but uses are in hemodynamically unstable circulatory support required to perform CAG and PTCA, cardiogenic shock unresponsive to medical treatment, refractory ischemia unresponsive to treatment or waiting for definitive revascularization, and benefit may exist in mechanical complications. In TAMI trial, there is less reocclusion, more mortality, but there may be a selection bias. In PAMI 2 trial, no difference in death, reinfarction, IRA reocclusion, stroke, new heart failure, ventricular arrhythmia. In IABP shock 2 trial also, no all-cause mortality benefit was there or long-term mortality benefit even after 6-year follow-up of that cohort. But IABP shock 2 trial gave us a very good risk stratification score comprising of 6 variables like age, blood glucose, serum creatinine, lactate, TIMI blood flow after stenting, history of stroke. Now regarding Impella in STEMI, it is a catheter-mounted axial flow device deployed into LV across aortic valve, transfers kinetic energy from a circulating impeller to the blood in LV, resulting continuous flow across AV. ISAR shock failed to show difference in mortality, bleeding or distal limb ischemia was there. Euroshock registry 30-day mortality was high, but it likely reflects last resort character of Impella 2.5 in poor hemodynamics and greater imminent risk of death. And IMPRESS trial, no outcome differences are there or mortality difference are there in 50% in both arms when compared with IABP, but there is excess major bleeding events. In tandem heart situation, this is a system where extracorporeal centrifugal flow pump that bypasses oxygenated blood from LA to descending aorta via 21 French transeptal cannula in LA and arterial outflow cannula into femoral artery. And it has been seen that in ascending aorta, increase afterload restricts LV unloading, but in descending aorta, increase afterload is alleviated by retrograde perfusion of mesenteric and renal arteries as well as dead vessels of aortic arch, which decreases LV stroke work, but no mortality benefit was seen in different small trials. In VA ECMO, in STEMI, it removes deoxygenated venous blood, circulates it through oxygenator and extracorporeal centrifugal flow pump, and returns oxygenated blood to arterial circulation. Inflow cannula is RA or across SVC-IVC, or outflow cannula is in femoral artery or subclavian artery. It can reduce RV and LV volume, increases MAP, may be associated with increased LV pressure. And there may be concomitant use of vent may be required, like inotrops, concomitant IABP or LV Impella or LA cannula. Now, the limitation of VA ECMO in STEMI is like possibility of LV distension, potential high risk for bleeding and risk of vascular injury. But Euroshock trial, there is non-significant reduction in 30-day mortality and even 1-year mortality with standard therapy plus ECMO than standard therapy only. The trial was underpowered actually, but there is definite improvement. And to compare the different types of MCS nowadays available, IABP has minimal ability to affect ventricular performances, and it depends on intrinsic ventricular performances to provide maximum benefit. ECMO, tremendous total body circulatory support, but does not affect ventricular performance drastically. Impella, good blood pressure support, directly unload LV. So Impella may be an answer in future, but recently a meta-analysis reported the result of 4 ICTs, including only 148 patients comparing percutaneous MCS versus IABP. MCS use did not show any difference in 30-day mortality. Now came PROTECT 2 trial. It has clearly shown benefit over IABP. Impella has clear benefit in 30-day major adverse event reduction, 90-day major adverse event reduction when compared to IABP. After that, USPELA or ASPELA registry comprising of 154 patients, they actually told about early initiation of hemodynamic support prior to PCI with Impella 2.5 is associated with more complete revascularization, what we are discussing in previous talk, that more complete revascularization can be done with this and improved survival in the setting of refractory cardiogenic shock complicating an MI. This is the outcome, and this is the different comparison between the different MCSs. Now, the last part of this discussion is RVMI, complicating with cardiogenic shock. Pulmonary artery pulsatility index is the hemodynamic indicator of choice for RV failure in inferior wall MI as well as post-LVAD. Shock trial showed RV dominant cardiogenic shock had similar mortality as LV dominant shock. significant higher in-hospital mortality when RV is involved. The options of these RVMI situations are like surgical RVAD, ECMO, atrial septostomy, Impella RP, tandem heart protect duo cannula, and recover right trial showed Impella RP was safe, easy to deploy, and reliably resulted immediate hemodynamic benefit in life-threatening RV failure. So these are the situations where RV failure and LV failure are, this is a spectrum, the MCS use spectrum. The take-home messages are like that. Early decision-making regarding need of MCS is important. Not to hesitate in putting pulmonary artery catheter when required. Good care of access site is required. Individualize during selection of MCS according to experience of use, follow-up knowledge, hemodynamic data, revascularization plan, and cost effectiveness. Proper weaning of MCS, the timing and techniques are very important. Thank you for your patient hearing.
No, your mistake. I can't go back. That's your mistake. So there is a special lucky draw. Now this is the first lucky draw. We'll have 3 more. Like today is up before dinner, tomorrow before lunch, tomorrow before dinner. So first prize is sandwich maker, and second prize is the steam. I mean for the ladies. The first prize you have the Midas touch by none other than Professor Amol Banerjee. The number is 210. 210. Check your number. 3 number fail kore gecho. And we have another Midas touch by Professor Panja to number 083. Huh? Yeah, fine. Okay, chalo. Nobody's here? So go for the second round then. Now, what to do? তাড়াতাড়ি 1 মিনিট 5 মিনিট তুমি হাতে নিয়ে বসে থাকি তোমারটা ওঠেনি দাও এটা দাও বলটা তাড়াতাড়ি বলটা 2 মিনিট নো প্রবলেমস তোমারটা দাও স্যার এক ব্লু খিচো ব্লু উঠাও ব্লু আপনার নাম্বার নেই ব্লু Yeah, blue. No, quick. Show me to the blue. Evening. Next number is 121 by Professor Soumitra Kumar. First prize. Second prize 219. No luck? 219. Quickly. One chance of. Wow. Yeah. Sir, fighter, air fight. Come. I forgot. Oh my God. Sir. So we have one more chance. What was Dr. Panchan Sauke? So one more chance, Dr. Amuthan. He's blue. Blue, sir. Any blue. 047. 047. 047. Check your number. No. Good. We are wasting time, so this will be the last chance. If somebody gets it, fine. Otherwise, it goes to the organizing secretary. Blue, sir. So, Dr. Anil Misro has picked up by his golden finger, number 117. Check your number. If you get it, fine. Otherwise, it goes to organizing secretary or the evening. Oh, you got it. Come here, please, sir. 117. Okay, carry on. Just a minute. Come forward, sir. Please, sir. Price to Didi, sir. Later. Sir.
Congratulations. Thank you.
Yes, you cannot bring it. Thank you.
Carry on. Sorry for the interruption.
Somnath, you have
Yes, sir.
elaborately described, but I am asking you real life, what you are doing. Whether you are using IBP, in different situation you are doing this, but in our different hospital, the facility is very limited.
Yes, sir.
No.
Yes, sir. Absolutely.
So in real, yes, what you do in that situation, whenever a patient with cardiogenic shock has come to you with a anterior MI.
Sir, first, I have already mentioned that to individualize the selection of MCS according to the experience of use. So my experience is limited to IABP only. So for all practical purpose, it is up to IABP. But recent data are telling that maybe Impella 2.5 maybe has beneficial effect. But since that, pharmacological followed by IABP.
Now we'll
Thank
go
you,
to
sir.
the next speaker. Thank you. How to prevent slow flow and no flow by energy.
So good evening, everyone. Well, I do not have any video in this particular talk. The reason is very obvious, because my topic is prevention of slow flow and not treatment. So I can never prove that what I have done has actually prevented slow flow. So it's going to be more of a didactic talk, and this is something you come across. It's not something which makes you feel happy when you are doing the plasty yourself. That's a slow flow or no reflow. So this is a no reflow is characterized by angiographic evidence of slow or no antegrade epicardial flow, resulting in inadequate myocardial perfusion in the absence of any evidence of mechanical vessel obstruction. And this may occur in the setting of acute coronary syndrome, as in primary PCI, or in a stable patient who is undergoing an interventional procedure. Maybe PCI, complex PCI, maybe rota, and it's due to a functional and structural alteration of the microcirculation, the coronary microcirculation. However, in in a proportion of cases, it may regress spontaneously. And if you ask me about the incidence, it's about 5 to 60%. It has been described, a huge, vast range. And the reason is like depending on the patient population that's been studied. I mean, if you only study patients who had an atherectomy done, maybe high, as opposed to like maybe in a stable patient where you have just use a balloon perhaps. So incidence is higher in primary PCI for STEMI, and encephalous venous graft PCI, and rotational atherectomy in highly calcified lesions. Now, it's very interesting to look at the pathophysiologic mechanisms. Broadly, there are three. That's ischemic reperfusion injury. It could be microvascular obstruction resulting from distal atherothrombotic embolization, or even from intravascular plugging, which may happen from leukocytes or platelet microthrombi. And thirdly, it could be microvascular spasm. Most of the time, it's not a single phenomena. It's all these three together. And which mechanism will be predominant, that depends on the setting in which it has occurred. Now, I've just made an attempt to elaborate like what happens actually in slow flow. Now, initially, of course, there is a ischemic injury, and this initial severe ischemia causes damage not only to the cardiomyocyte, but also to the endothelium. And endothelial damage from ischemia results in endothelial necrosis, cell necrosis, resulting in destruction of tight junctions and loss of vascular integrity. So there is extravascular edema, and this results to vascular compression and a reduction in the microvascular lumen. Also, at the same time, ischemia causes endothelial dysfunction. So release of nitric oxide is reduced, and this impairs the endothelium-dependent vasodilatation.
Now, ischemia to cardiomyocytes results in cell necrosis and cardiomyocyte swelling. This again may compress the intramural vessels. Now, ischemia is followed by reperfusion, and this reperfusion injury is, it actually worsens what has been already been done by the ischemic injury. So reperfusion is associated with production of oxygen-free radicals, which further cause endothelial disruption as well as inflammation. It causes migration of neutrophil and platelets forming microthrombi, which obstructs the lumen of the microvasculature. Also, reperfusion is associated with autonomic dysfunction, and there is intense alpha adrenergic receptor mediated constriction of the coronary vessels, which results in microvascular spasm. And the third is, of course, the distal atherothrombotic embolization, which happens more in a stable PCI setting. So where we do a PCI of a complex plaque, and there is distal embolization of the microthrombi and plaque components, which causes occlusion of microvasculature, resulting in microinfarcts, which again promotes release of pro-inflammatory and vasoactive substances. And this further causes damage and microvascular and vascular spasm. Now, no flow, reflow is not good for you. It's bad. It increases it worsens the outcomes. So the mechanism perhaps is if blood flow cannot enter or leave an area of necrotic myocardium, then the cells such as macrophages, which are actually necessary for removal of debris, they cannot function. And the humoral factors necessary for proper healing cannot access the tissue. So it would result in poor healing of the infarct. So in short term, that can cause increase in acute heart failure, incidence of acute heart failure, malignant arrhythmias, cardiogenic shock, and death. Also in the long term, it would result in adverse left ventricular remodeling, resulting in congestive heart failure, rehospitalization, and MACE, including death. Now, the diagnosis is usually done from coronary angiography. At times when there is slow flow instead of no reflow, you can take note of the TIMI flow, the frame count, or the myocardial blush. If, say, you have thrombolized the patient and you find the patient's having, the ECG, there's no ECG resolution or resolution less than 50% within, say, after 60 to 90 minutes, then you can say, well, it's indicative of no reflow. And also there are other ways to do like gadolinium contrast enhanced cardiac MRI, contrast echo, or nuclear imaging. Now, it's important to know the predictors of no reflow, because if you want to prevent no reflow, then you need to know the predictors and how you can improve them. Now, there are the predictors of no reflow can be divided into two groups. There could be patient-specific features or procedure-related features. Patient-specific features are age over 65, female, hypertension, smoking, dyslipidemia, diabetes, renal failure, rheumatoid arthritis or other inflammatory process, atrial fibrillation. All this would increase the risk. On the other hand, procedure-related factors we know, increase in thrombotic load, delayed presentation, high pressure inflations, use of debulking devices, that would increase the chances of no reflow. Now, coming to the prevention of no reflow, I will divide them into three categories: generally accepted, controversial, and experimental. Now, what are these generally accepted? Now, we know that shortened door to balloon time would reduce the incidence of no reflow. And that is because more prolonged ischemia is associated with more microcirculatory damage and therefore development of no reflow phenomena. And also we know like direct stenting in acute MI would cause less embolization of the debris, and that would also result in reduced no reflow. And if you avoid high pressure post dilatation with balloon in patients who are at high risk of no reflow, then it's very obvious like there would be less embolization and less reflow, chances of reflow. And if you're using rota, say, then you always try to use shorter burr runs and lower speeds and avoid decelerations. If you really, especially in high risk patients who are at high risk of no reflow. And in case of saphenous venous grafting PCI, again, which is associated with high incidence of no reflow, it's best to use an embolic protection device. And there's been some evidence to say that pre-treatment with intracoronary vasodilators could be useful in such a situation. Now, also we know, like there's some other things, factors, like if you have cardiovascular risk factors, and if these are very optimally controlled when the patient is going to have a PCI, then it reduces chances of no reflow. And statin pre-treatment has some evidence, and it showed that although it did improve the coronary flow after primary PCI, it actually didn't reduce the MACE. Now, there's some controversial issues. For example, what about intracoronary vasodilators to prevent slow flow, not infringement? Now, the Amistad 1 and 2 has showed that the clinical outcomes in patients undergoing primary PCI were not significantly improved with adenosine, although the infarct size is reduced. And reflow STEMI showed that neither the infarct size nor the microvascular obstruction was reduced by intravenous nitroprusside or adenosine. Sorry, not intravenous, I would say intracoronary. Now, it's a very interesting topic is that I would like to put in 2B3 inhibitors. Okay. So the On-Time 2 study, which was done quite some time ago, is a study which showed that the pre-hospital initiation of bolus tirofiban could result in ST segment resolution and improvement in clinical outcome after primary PCI. But note that such trials were done before actually the potent P2Y12 inhibitors like ticagrelor and prasugrel was available. But the contemporary trials have not demonstrated such a useful effect. However, patients undergoing primary PCI may benefit from it, especially if there is an established no reflow, large thrombus burden, or for bailout cases. Now, regarding thrombus aspiration, a meta-analysis has failed to show the long-term benefit. On the other hand, manipulating the occluded area with balloons and stents often results in distal embolization of the thrombus, which may contribute to development of no reflow. So routine aspiration should be avoided and should be limited to the presence of angiography visible thrombus only. And lastly, the experimental ones, and these are the ones like intracoronary fibrinolysis, ischemic preconditioning or conditioning, therapeutic hypothermia, and hyperoxemic reperfusion. I wouldn't discuss these because these have not been shown really to help. Thank you very much.
Thank you, Dr. Banerjee, for an elaborate discussion. But no reflow basically remains an angiographic finding. ECG, echocardiography, and gadolinium-enhanced myocardial imaging, MRI, all those are theoretical. I mean, nobody goes for those. And mostly it is a post-procedure finding after PCI or sometimes after rotablation. And exact mechanism is still unknown. So prevention remains very difficult. And once you face it, you had it. A very difficult situation, particularly when a patient is in acute MI, cardiogenic shock, you are undertaking for intervention on hemodynamic support, and most of the agents are vasodilators, causes further lowering of blood pressure. So managing also is very difficult. So with these remarks, I open the question, I open this topic for discussion and questions, if any, from the floor.
Thank you for a nice presentation. I just had a comment. Practically, I think the most important thing that we need to emphasize that start the dual antiplatelet loading as soon as possible the moment you diagnose, because that's probably is the most important thing that we can do. Because we often know that the clopidogrel takes longer time to act. So before reaching the cath lab, in the community, if someone diagnosed his patient is having an ACS, so as soon as possible, the particular doctor should try to initiate the dual antiplatelet with a loading dose. That's probably one of the key practical aspect that we should emphasize, which can prevent no reflow later in the cath lab. So that's one comment I would say.
So as we know that nicorandil can be used, intracoronary nicorandil can be used in the treatment, but do you believe pre-treatment with nicorandil infusion can be helpful? Because there are some scattered data
Yeah, true. And that is what often we have done actually. We have given nicorandil because we have seen clinically also giving nicorandil before intravenous nicorandil actually helps. But, I didn't get any robust data to support this. So, this may be my experience, maybe your experience, but I do not think we have any robust data. And intravenous nicorandil is mostly used in Japan. It's seldom used in, in the Western countries. So I do not know of any Japanese literature which shows its beneficial.
Thank you.
See, other things, as you have said, what we follow is avoid predilation in a thrombus containing lesion, if possible. Avoid high pressure post dilation after stenting, if there was a thrombus, and continuous flushing during rotablation. These are the preventive steps we can take while doing procedure to prevent the complication and no reflow. But antiplatelet anyway, we start dual antiplatelet as early as possible in all cases.
Thank you. Because now we are running short. Whether Dr. Shomik Chaudhary is there? Live case now will start from the Narayana Super Specialty, Howrah.
Thank you so much. We end this session over here and move forward to the next session, live case 4, 5, and 6, Narayana Super Specialty, Howrah. Operator of this particular live case will be Dr. David Rosario, Dr. B.P. Pandey, Dr. Munna Das, Dr. Amitabh Chattopadhyay, Dr. Sanjeevan Ghosh, Dr. Joita. As chairperson of this particular session, I would like to invite on the dais Dr. P.C. Mondol, Dr. S.B. Roy, Dr. Shukumar Ghosh, Dr. Sujit Pal, Dr. Shushila Mitra, Dr. Shoumajit Shaha. As panelists, would like to invite Dr. Shubhro Banerjee, Dr. V.S. Sharma, Dr. Pradeep Bhomik, Dr. Pradeep Sarkar. Thank you so much.
Yes, sir. We are. You are.
Thanks for giving us the opportunity to show you the live cases. This is from medical cardiology. This is osteomedical. This start the forward one.
Yes, sir. Yes, sir.
And you are found to have a lot of clinical next. So these are the private courses and the following application and there is permanent paper. So giving a large opportunity to the next. Because the transfer is the first moving course in the so that you can see there is a large opportunity to the there. And the next year, the personal part activity, there is a see which probably is down to so in that case, there are different things. So we have to for 8 device user. Next, so I think for 8 device user, considering the floppy rings, we are planning to put a data set in from the feature of one state. This is the new technology. In order to considering ASP devices, in particular, there are change of having a specific location, which give us and there is no really device. First, there are device accident identity permanent or later you Make a echo brief. Yeah. So you can see initially one productivity capacity. Here you can see there is a large documentation you see. You can appreciate the visual figure in this property. Next, here measuring 18 to 22 millimeter in this particular. There is a noise digitization. Here we follow the method. Here again, see here again approximately 12 millimeter mark. So here we see this is the last one product to view. Here also you can see the posterior inferior range is problem and there is deficient directorial range. So here in this particular view, we have the view. The pulmonary venous range appears to be normal. So for posterior view, the maximum diameter we got that is 26 millimeters. And this is the moving picture. Here you can appreciate the unseen already top. So here we use the large exhibition with floppy interior and posterior range. So I did the consideration also. Here you can see this is 0 degree. When you put that here you can see about micro range south and east. So because the posterior range. It's not very long. So from the palm into the palm you can measure approximately 24 to 26 millimeters. Now this is the view of characteristic product. Where you can see there is no discoid range and the posterior interior has application floppy and clean. So from the palm to palm, we are getting a measurement approximately 22 millimeters. So these are the views when we take the video to audio, this is the particular view, where again you can appreciate the interior range very problem. So these are the images. I was taking the pulmonary range, these are the left side pulmonary range, which is normally ranging into the left atrium. And these are the right side pulmonary vein, and you can see it is very normal. So it's always better to take the pulmonary venous image before putting a device. Sometimes there can be associated pulmonary venous abnormality where the patient can be emphasized. So the pulmonary vein is normal. So that is the thing. We got a moderate to large size with floppy interior and posterior range. The palm to palm we got a measurement approximately 24 to 26 millimeters. So we are planning to put a 28 millimeter light cerebral space of view. Okay, so standard thinking we got a venous aspect. So we got a 28 millimeters. The 28 millimeter device we have a 12 or 14 days. Okay, so now we can do a video. So as you can see, we pass the multiple factors. We define the various pulmonary veins. So we are defining the activity where now we are pulmonary vein and we are the sheet. This is the channel for all the 8 devices. Next. So, we plan with the selected device. You can see the device is being advanced from the sheet. Next. So, the device is being put to the sheet. This is a very new device, and this is the second time we are using this device. Okay, so this is the second time we are using it. The advantage of using this particular device, particularly in the inter-regulatory problem. It makes very easy to access before the deployment. So as the patient is not into the deployment. You can see the laser inside the is not there. The two is the top of the resolution pattern. So they are making the different so we have defined so once we try to deploy the device from the thing, and we can see that as the device is not that big, the data are delivered inside the system. Now we are trying to capture the value of the system, and we can see that particularly with that. And then we are defined already. And after one delivered, yeah, so we have detected the already. We are doing the everything on the date one, 90, and now we are across the date one, and this is the design of the already. Then we take the position of the device, meaning where we can see the operating time everything are 90 device, and there is a description to the actual view of the device position is perfect. And now we are going to see the transformation to the so as you can see, the device is perfect here. The alignment is very good. Microbiology is clean. This is the cartography graph. There is no movement for the visualization. The device is adequate in particular aligned with the system. And this is the beauty of this particular device because there is the visualization is very soft. So there is not much pull on the cable. So the device is already aligned with the system. But it's already aligned with the system. So this is the device of parameter quality. And you can see the device is nicely cutting the yoga. And this is the positioning, yeah. And you can see the positioning to be the device. So go to the particular here the ABC means screen. You can see the ABC in your device. You can see the ABC also. To the device. So in my system, you have to process and you can use the device. And then you can processing. So go ahead and use it.
ऑन करो माइक डाउन
Yeah, sir, I can hear you. Yeah, please. No,
An interactive session. Another chairpersons is present there or not? Actually, for which type of deficit and stump should you observe for and which design is or company is suitable for which type of patients? Have you any idea?
yeah, so basically the two companies we are using, one is Amplify and one is Lightweight, but not this particular device. We are using the standard edition of the product, where we want to consider the usage of 40 millimeters and the Lightweight is 40 millimeters. So that is the standard for these dedicated involved and devices. But it is like properly and it's a very efficient electrical working of the because there are so we are coming for a efficient device, so we need to 35 feet there as a backup. This particular device, we have only two. This is the second year we are doing. The maximum size availability is up to 32 millimeters. So definitely this particular device is not meant for a very large area. But yes, there are advantages. This particular device is very good for e-rings. The standard LED devices in the heat table, after deployment, there is up to 45 degree rotation. Sometimes because of that particular rotation, it was made with stop. But if the properly you are using the therapy, this component is there is your rotation. So we don't expect the much rotation. So for properly, I think this particular device and we use. So can we go ahead with the release?
Yeah.
Yeah. So release the device in that release.
Is there any question from the audience? Yeah, you go ahead.
Yeah.
And if there is any question, we can discuss in between.
So I'm releasing national view just to see whether there is any location after this or not. So yeah, focus the hand. Yeah, so the device is reading. There is zero degree rotation. Are you right? I request Dr. Amita to show the delivery system one. Can you move on the hand? The very new device. We are only using this particular device. And if you order the second session in India, we use this operator. Normally, we are using a device which is having a screw. But this particular device, there is a milestone system. What you are seeing now, there is a loop, and the real device is entangled within the loop. And for relay, for the device system, there are two buttons. One is raise and one is blue. Yeah, so the raise and blue button. So basically, you have to pull the raise button first. You have to press the important raise button, and you have to pull the blue one. So there is a two button system. So even if you accidentally press one button, the device will not get ready. If you can press two buttons simultaneously, only after that, it will be ready.
So could you tell us, like, what's the USP of this device? I mean, why are you using this device more than the more traditional one?
Particularly for the floppy rings, after device release, there will be some floppy rotation, and if you do that rotation as a human not in strong, there can be problem.
Okay.
So yeah. So you can see the device is largely placed across the industrial sector. And you can appreciate, before any also the device was looking just like this. And this is the advantage of this particular device. Because there is a specificity rotation and the very soft and there is not much movement. So you can see the device is largely having a view. And particular view also, the device is the ABCD. Within the device, device is flying above. And you can access the brass one, the microphone to screen, not much.
Is there any disadvantage to this device? Why would you just avoid using it?
First of all, what is the big disadvantage? We have room 246 for the individual device, but the company has figured only 32 millimeters. Particularly the road 16 multiple times I will see here 40. So such a large unit cannot be closed by this particular device. Second disadvantage, One is the sometimes the device is not properly placed across the container, you have to capture one link for both the and you have to be lost. But as the cable is not very fun, so the capture is very difficult, but somehow today the first pattern is therefore not across the system. We have to capture the RF inside the chip. But the capture is totally slightly difficult than the conventional one because the interface is very involved. So these are the disadvantages. Advantage definitely the data metal mass is much less, communication is less, and there is no force filling required or allocation. These are the advantages. I would recommend this particular device for the second work across the property.
Is there any other question from the, yeah, please, go ahead. Could you use the microphone?
One query, while sizing the device, if your rims are floppy, the metal ring or the outer ring, in sizing you do any increase in the size of the device you take?
Sir, there are like there is no specific recommendation, but from our experience, what I would say, suppose the rings are very good, you have a central defect, all the rings are adequate, there is no deficiency in the rings, and the rings are firm. Then you can oversize only 2. Suppose you are getting a defect of 20, you put a 22 fingers. That would be sufficient. Suppose you have a deficient rings in particular one axis, or if you have a deficient rings, like rings are very floppy deficient, either you oversize it by 4, at least by 4. Suppose you are getting a defect of 20, you at least put a 24 millimeter device. But suppose another thing you can do, you can measure the arm ring to the arm ring. That is you can exclude the floppy part and you measure the arm sector to the arm sector and measure that, and you can put that amount of device. Today actually we got a 26 to 27 millimeter arm to arm. That's why we put a 28 millimeter. But here in this particular defect was near about 20 to 22 millimeter. The defect was not that big. Because of the flopiness of the rings, we have oversized. Another important thing, if you are putting device in small children, nowadays the recommendation of putting AC devices after 2 years of age, in the preschool age. So 1 2-year-old child will be maximum around 9 to 10 kg. In that particular child, you cannot put a 30-40 millimeter device. What routine we follow, we have to go up to 100 to 220%. So 1 10 kg child can get the device up to 20 to 22 millimeters. In this particular condition, you don't have much room to.
What is the risk?
Yes, sir.
In when outer rim is floppy or very short, what is the risk of invading into the outer root by your device?
Then there is a minimum chance of floating erosion. This is different in the test, but in our experience, actually, we have never faced it. And in majority of the condition, we get respiratory deficient. I don't know from India, I have never seen any case report of like erosion after being AC device, but definitely for the Western countries we have case report, but probably it's very rare. And probably it's unpredictable also, we will develop the aortic erosion. But one thing, if the device is nicely hugging the aorta, the chance of aortic erosion is less. But suppose there is a very small electrolytic ring and the discs are poking on the aorta, so probably chance of aortic erosion is slightly on the. But we have never experienced that thing. So I would like to say thanks to the organizer.
Sorry,
Yes, sir.
we have one more question for you, Dr. Bikash Mujumdar.
The device. And did you ever experience that movement, that is displacement of the device?
Sir, can you please repeat the question?
So when we finally release the device, we all experience there's a jerky movement and device moves a little bit, isn't it? Yeah.
The conventional AC with a light cable, they have experienced up to 45 to 50-degree rotation.
Yes.
If your rings are deficient or if your rings are really floppy, due to that rotation, this device can get dislodged. And probably the operator cannot do anything in that. So that is not in the operator's hand.
Right.
This particular device system, they have produced a 360-degree rotation, and they have claimed that, and today also we have seen that there is no post-release rotation of the device, because the device is already sit along the axis of the plane of the intellectual septum. That's why there is no rotation, and if you can place the device perfectly before release, probably the device is going to sit there in its own position, and there is not much rotation, and this is only the advantage of this particular device. And because today we have a very floppy ring, we have selected this particular setup.
So another question I have means, as we all know that we upsize the device by 4 millimeter. And another thing, the left disc, which is of bigger size.
Yeah.
And do you take into account the size of the LA, that whether that bigger size left rim will be able to accommodate that LA or not? That's the question.
There are papers where they used to measure the total intellectual septal length and the LA dimension. But nowadays that is not recommended, because suppose you are putting a 40 millimeter device, that is the highest AT approved device, 40 millimeter, the LA is will be 54 millimeter. That can be easily accommodated in an adult heart. And the nitinol mesh is very soft. So chance of perforation of the LA is very, very late and is probably not reported. Yes, during the procedure with the sheet, with the delivery cable, you can perforate the LA root. But post deployment, LA root perforation is not reported. So nowadays it's not recommended to take the LA size in account or the intellectual septal length in account. So if you have a 30 or 40 millimeter defect, you have to put a 40 millimeter device.
And that is true for the children as well.
Yes, sir.
That is true for the children as well.
No, sir. In children, actually, there is not much recommendation, but what we follow, we never cross 220. We try not. We always try to not cross 220%. For one 10 kg child can get a 22 millimeter device. Sometimes we have given we have gone up to 240% also, but definitely not 250 to 60 or 300%. And one of our fellow is preparing a study also. She's doing a study on this small children with a large device. I don't know what is the result come, but there is no published data how much we can do. Another important parameter is there, that is device weight is to height ratio. Instead of the body weight, they have taken account the height of the child, because the concept is if the child is high, like big, tall child, the LA size will be big. So instead of taking the body weight as in account, we can go for the height of the child. And there are specific guidelines, not guidelines, there are papers where they have suggested up to 2, if the device height is to waist is to height ratio up to 0.22 can be easily accepted.
Yeah, I think the question which Dr. Mujumdar had, like in case of the Amplatzer device, if could you do something? What precautions do you take so that during release there is no sudden movement leading to dislodgement? I know this new product is better that way, but for the Amplatzer, is there any step you can take to prevent that?
So one of the modifications we have used in few cases. Suppose the leaves are leaking properly. What we can do, there is a snare technique of release. Before releasing the device, you can hold the pin of the device with a snare. So then you release the cable. Suppose you have seen there is a much rotation and the device was short. At least you will have the snare in your hand to take out the device. You are already holding the device with a snare. This particular technique you can use, we have used in the occasion. But sometimes it's not very like predictable also which device is going to get dislodged and not. So it's always recommended to keep your surgical team as a backup if you are really doing a high risk device.
So if there is no other question, should we move on to the next question? Okay. Thank you very much.
Thank you.
It was really a pleasure.
Hello, hello. Sir, there is one more case. Hello.
Sorry, who's going to present the next case?
Sir, live case. There is one more live case.
That's three live cases, right?
Yeah, yeah, yes, sir.
So can we move on to the second live case?
Yeah. Labeled at tomorrow.
Yeah, we can hear you. Just be a little bit louder.
So, we are going to show you this, and before that, I introduce Dr. Swami Sara, a university of district, where the district and children and the commission, it's a family currency, and it's a review, and other studies. So the part presentation of this case, I hope you can see the PowerPoint here. So, can you listen also?
Yes.
Right, so Anish is 55 May, who presented on 22nd of May with acute onset of chest pain. And he had diabetes for last several years. So the inclusion goes to the next slide, please. We had the ST elevation, you can go back to the inclusion. PowerPoint, yeah, go back to the inclusion. You just go back. Yeah, ECG showed the ST elevation in lead 1, AVL and lead 2.
Can you focus it more? We cannot see.
Yeah, just in the ECG.
We couldn't see the ECG, and also I could see some IVUS images, but we haven't seen the angiography either.
I hope you can see. I have never seen this. Elevation in lead 1, AVL and ECG. This is typical known as the South Africa flag sign, and this is a very rare. In fact, you know I'm saying for the first time. If you superimpose this ECG on a South African flag, your one AVL G2 will fall on the green name of the South African flag. And this will be phenomenon of diagonal energy involvement. As you know, one AVL is signified either of energy diagonal relation. Now I am showing you the physical on the lateral wall of LBS before the kinetics. And we came up on 22nd of May as the primary initially will show you the angle. And first, today the first talk. So, right side was the right survey RP was perfectly normal.
Is the right sided leads are normal? V3, V4 are?
And as I told you, I heard about it, how that we can plan. It is better more than a really bad one, go to the next one. And every bad one was like this, yeah. So, what we are doing, we are all. You can see the character is on video. So we opened up a subject on that time and we get the LED lighting for subsequent intervention, and today we are here. I'll show you what we have done today. In the meantime, we can discuss. Go to the next one. So today I wired the both LED and diagonal, and these are items made with the items. Can you project items there? And you can make it a video. Yeah. So here you can see from the digital in the optimal right, I will plan to do that. Digital is around 2.5. And you can see the R of calcium ranging from 70 dB to almost 150 dB in the red part. And we found about moving faster. So it was reduced and maximum So after the so in 1.5 bar, there was a difficulty at the 5 bar for diagonal. So it is almost 6 passes when from so after the 6 months, we will so that now we can't see the diagram. After the diagram is lost. So this is after median and rectangle, we could not get diagram. Go to the next picture and we want the diagram. So this was the standard time beyond blue wire. We could easily record. And after recording, we did a balloon calculation with 2.2 millimeter and then 2.35 millimeter balloon, and we got the flow back. So this will be what, yeah. So this is after the balloon calculation of the diameter. So now the plan is to do further optimization and flat modification. So we'll do that as we go to the next few steps after diagram to the eligibility diameter. Forward. So this is the balloon dilatation of the distal end and the proximal part. This is with the 2.5 millimeter balloon NCD. And go to the next. So this is the result after the squeeze at some point in time. So we can try to use as a cutting balloon actually, while doing balloon dilatation with 2.5 distal end and approximately 2.75 into 15. So the plan is whether to go for a provisional or two steps. Since you can see from there the proximal one side of the diagonal is showing the sector. So there is no question that we have to do the bailout step, and we did it. So we use the line of the technique which we are discussing in the morning. Go to the next one. So the diagonal center. So after the balloon dilatation of the proximal part of 2.75, we did a strengthening of diagonal. First we did the distal LED strengthening. This was a 2.5 into 38 millimeters energy step. And then we put the diagonal strengthening to the next one. So this is the diagonal 2.25 into 22, and with the blocking balloon 2.75. We did it with the minimal precision, but it was slightly more than minimum. So then we thrust, go to the next one. We thrust the diagonal stem. And so the next one. Yeah, this is the thrusting of the diagonal stem. Go to the next one after taking out the wire from the diagonal. And then we deploy the 2.75 into 24 millimeter stem overlapping the distal LED stem as per the here. The next one after the next, yeah. So this is the stem deployment. Now here you can see the first stem diagram. You can see the three layers at the bifurcation of LED and diagonal. Then we did the part. So the part we did it to 12. Part at 16 ATM, and after proximal optimization, we cross the diagonal. Next one, so the crossing of the diagonal. And then we did the allocation to the 1.5 into 8, 1.25 into 8, 1.0. Then I tracked the energy group beyond this, and with the use of trap, now you can see that 1.25 billion just flipped it. It was not going without block. So this is the anchoring technique. Go to the next one, and I am currently at this stage that I have just done a cut dilatation. So the last picture, and now we need to do a fitting after a further dilatation with a 2 or 2.5 millimeter. So the last picture where we are at this moment. Okay, so we have to take the last picture.
So you're going to do the kissing, right?
Yeah, I will first give a 2 millimeter below. And see whether it goes easy. No. Take a picture. There is some flooding flow in the diagram. The body is bad. Again, 2.2 millimeters from body. Any question, any discussion you can have. There are.
Going to do kissing.
Yeah, I think they will do, yeah, that there is another case. By that time, I'll be able to show you the final result.
Yeah, meanwhile, one point. Sunip here, Sunip. Yeah, great show. I think the most difficult portion in this bifurcation lesion is you lost the band while doing it and you rescued, great rescue. But your challenge remains because the angle is very bad between the LED diagonal. So I think you need to do some more port or proximal dilatation, and that then you'll get a very good result. Thank you.
Okay, we also finish with the items and end of it.
Dr. Pandey, I am Dr. Panya here. Actually,
Yes.
still speaking, there is some
that is why impinge is there. As there is no chest pain, as there is no issue changes, as flow that is more than 70%. So I think nothing to interfere in the flow. It will be automatically some spasm is that will be relieved.
Yes, we'll see what the IOS put, and if needed, we will do a report. So you can switch to the pediatric lab, they will have another interesting case of RBO technique. Over the lab.
So what's the plan now, Pandey? Are we moving to the next case and come back to this case later again?
Yes, yes.
Switch to. Hello.
It was a client at the platform. The client from Malaysia.
Hello. Switch to lab 2.
Staying in places at the same point. Why do you go? It's like in fact, you go answer that.
Okay, so we are moving to the third case here. So who's doing the case?
Yeah, hello, am I audible?
Yes, Shivananda. Yeah.
Actually, sir, we did the case just 2 hours before taking this particular ACD class. It's already in update. So you will see the recording. I am here live. So if there is any questions or queries, we can answer. This is from pediatric cardiology team, headed by Dr. Amitabh Chaturvedi, myself, Dr. Shunjiman, and we have Dr. Joita and Dr. Nikita. So we'll show the case. Good afternoon, everyone. This is the second live case from NSH Chhara from pediatric cardiology team. This is a case of RBOT stenting. Next slide. First, the patient particulars. This is a 5-year-old boy weighing 60 kg. The child underwent total correction for tetralogy of Fallot, and the RBOT augmentation was done by a transannular pads, and it was done in 2018. Presently, the child is asymptomatic. Next. On follow-up echo, as you can see, the parasternal short axis view, there is severe RBOT obstruction at the infrandibulum, and there is pre-pulmonary artery regurgitation. because transcendental patch augmentation of the RVOT was done. And in the subcostal view also, you can see there is infundibular muscle bundle producing severe RVOT obstruction. In the Doppler image, you can see the RVOT gradient is approximately 120 millimeter of mercury. And there was moderate RV symptomatic dysfunction. Next. Diagnostic cardiac catheterization was done 1 month back, which showed LV systolic pressure of 110 millimeter of mercury and RV systolic pressure was 100 millimeter of mercury. So RV pressure is almost near systemic. RV TDP was 12 and the pulmonary artery pressure was 18 millimeter of mercury systolic. So there is approximately 80 to 90 millimeter of mercury gradient across the RVOT. Next. So these are the angios. The first angiogram catheter is inside the RV. And the first angiogram is done in lateral view. As you can see, there is a severe narrowing in the infundibular and the distal end of the tap is roughly dilated. The next view is taken in RAO 30 view. These are the two views which we regularly take to profile the RVOT. One is lateral view and the second one is RAO 30 view. In the second view also, again you can see there is severe infundibular narrowing near the fourth sternal gland. In the next angiogram, what you can see through a femoral venous access, one catheter is inside the RV, and through another femoral venous access, we have taken a where because the RVOT. Now we are inserting a balloon. This is a 12 millimeter balloon, tri-sac balloon, and you can see as we are injecting inside the RV, there is no forward flow across the RVOT, and the whole blood is coming back to the RV through ER. So with a 12 into 30 millimeter tri-sac balloon, we could completely obliterate the RVOT. And you can appreciate there is a very good waste. So the narrowest portion of the RVOT we measured in this angiogram approximately 8 to 9 millimeters. And the next angiogram is taken in neo 70 degree to profile the coronaries. For through a femoral venous section, we have integrated 30 millimeter tri-sac balloon. And one fetal catheter is there inside the aortic root, and we are giving a aortic root angiogram. And you can see there is nice filling of both the coronary arteries, both the RCA and the LMCA, and there is no compromise in the left system after inflating a balloon in the RVOT. So this is very important for RVOT stenting. Sometimes after inflating the stent or balloon inside the RVOT, there can be compromise of particularly left coronary artery system. So we have seen, we have already said there is no ST elevation, there is no change in hemodynamics, and visual also the compression of there is no compression in the coronary arteries. Okay, next. So to summarize, this is a 9-year-old boy, weighing 16 kg, status intracardiac for tetralogy of Fallot, having severe infundibular pulmonary stenosis with systemic RV pressure and RV systolic and diastolic dysfunction. We are planning to do a RVOT stenting using a Sapphire XL stent, and the final diameter of the stent may be 14 or 16 millimeter of mercury, and we are planning to use an endamic balloon to inflate the stent. Welcome you all. So we are planning to do a RVOT stenting today. I'm Dr. Sanjeev Ghosh. In this particular procedure, the operators are Dr. Joita, Dr. Ishika, Dr. Fahil, and we have nurse Dr. Nurse Meeta, our assistant team, Dr. Shintenu, and we have catheter brothers. I need to deploy another Excel stent, which will require 11 French sheet. So we are planning to deploy the same for 12 French femoral balance sheet. So basically we have entered this is a Sapphire Excel stent. Yeah. So basically first, okay, we have entered the RV initially, and we have taken a simultaneous RV pressure along with the right femoral venous pressure. In the femoral arterial pressure, in the hemodynamic monitor, you can see the right femoral arterial pressure systolic of approximately 103 millimeter of mercury, and the RV systolic pressure is approximately 9 millimeter of mercury. So there is a systemic RV pressure. Then again we are injecting the dye in the RV first. The first angiogram is taken in RO30 view, where you can see there is a significant RBOT narrowing, and the landmark is near the fourth tunnel on the above. That area is really narrow, so we have to place the stent there. The next angiogram is the lateral view. Again, you can see near the first tunnel where there is a significant narrowing in the RBOT, and the display of that the transcendental path is roughly directed. So we have to place the stent there. Next. Okay, so we have entered the LPA. We have crossed the RBOT, entered the LPA. Now we have parked the catheter in the LPA. Make the hemodynamic monitor line. Okay, so what you can see, the distal LPA pressure is equaling approximately 50 millimeter of mercury. So we have a 85 millimeter of mercury gradient across the RBOT. So we are planning to place a Zofia XL stent across the RBOT. The beauty of this stent is the final diameter can be expanded up to 25 millimeters. So in future also, if there is any intervention like a pulmonary valve, this placement is required, we can easily place the pulmonary valve within this particular stent. So what we are planning to do is we can expand the RBOT up to 14 millimeter initially. Then we can check the flow gradient. If there is no flow gradient across the RBOT, we can accept that. And if there is any residual RBOT obstruction, after putting the 14 millimeter, we can expand up to 16 or 18 millimeter. So first, we will expand the stent up to 14 millimeter. So as you can see, the hydrogen catheter is inside the deep LPA. Now we are advancing the Ambassador ultra steep wire through it, and we are trying to park the ultra steep wire as deep as possible. As you can see, we got a very good position. So this is the final position of the Ambassador ultra steep wire. And now we are planning to take a 12 French gradient sheet through it, and we are planning to park it across the RBOT. And we are planning to cross the narrowest portion through this sheet. Now, as you can see, we are preparing the sheet. It's quite a large sheet. So we have to DI it very gently and carefully. So the same thing we did. Now the sheet is prepared. We will push the sheet to this ultra steep wire. As you can see, we are slowly advancing the 12 French gradient sheet over the ultra steep wire. So this is very important. Now we are advancing the sheet. We are trying to cross the narrow portion of the RBOT. Yeah, because of this ultra steep wire, this step becomes very easy. Otherwise, this is very difficult step. It's very difficult to cross the narrow portion of the RBOT. Yeah. So as you can see, we are almost there in the RBOT. Now we are inside the main pulmonary artery. I think that is very good. So as you can see, the sheet is inside the main pulmonary artery segment, and in the pressure monitor you can see the aortic pressure 85 by 47, mean of 60, and you can see the peer pressure symptoms of 13 or 14 millimeter of mercury. One important finding is the peer diastolic is very low because there is no pulmonary valve. They have done a transcendental patch repair, so the pulmonary valve is not there. That's why the diastolic peer pressure is very less. But this particular pressure confirms that we have crossed the stenotic area. Now we are distal to the stenotic area. We'll give a check angiogram just to see whether we are inside the area or not. Okay. Total detail immediately. Okay, so we have DI'd the sheet completely. Now Dr. Jyotika is immediately DCM. Yeah, so we are nicely inside the main pulmonary artery segment. So we are planning to take a Zofia XL stent. So we have selected a stent length approximately 29 millimeters. We don't want to put a very large stent because this is almost a pinpoint and very focal stenosis. So 29 mm stent, that is the minimum stent length available for the wire XL stent. I think that would be sufficient. And we are planning to mount this particular stent over a 40 into 40 millimeter Andromed balloon. So as you can see, we have taken a Zephyr XL stent. The length of the stent is 29 millimeter. And the diameter, this can be expanded up to 25 millimeter. And one important thing, the amount of foreshortening as per the company is very minimum. The amount of foreshortening is probably less than 10%. So even if we expand this up to 25 millimeter, the stent is not going to get foreshortened that much. So you can see we are planning to mount this particular stent over an Andromed balloon. The diameter of the balloon is 40 millimeter and the length is 40 millimeter. We are slowly injecting some dye inside it. There is any problem with the balloon, but it's good. Now we can take out the dye. Now the balloon is prepared. Here, now we will mount the stent over this particular balloon. Same thing we are doing now. This is the wire XL stent with the length of 29 millimeter. And we are mounting it over 14 into 40 millimeter and balloon. We are planning to mount the stent just exactly at the center. You can see the markers of the balloon. Yeah, these are the two markers. As pointed by the we are placing the stent exactly at the center. So we have checked that the stent is exactly at the center of the balloon. Now we are crinking. This is a hand crinking. Next. So we are slowly advancing the balloon mounted stent through the sheath. As you can see, the tip of the stick is inside the NPA. We have taken the balloon across it. Next. Now we will bring the stent, the whole assembly slightly down. As you know, our landmark is near the third and fourth sternum wire. So we are placing the stent across there. And we are gradually unsheathing the stent. So the sheet is totally unsheathed. Now you can see this is the take angiogram. The stent looks okay, but it's probably slightly inside the RV more. In the lateral view, we are checking the placement. Show the angio. So as you can see here, it looks perfect. The 50% of the stent is inside the RV and 50% is projecting inside the main pulmonary artery. So the narrow portion is just at the center of the stent. So slightly more, we are checking the angiogram just to place the stent perfectly. Okay, so next. In this angiogram, okay, the next one. Previous one. Okay, here this placement looks perfect. The narrow portion is just at the center of the stent. Next. So I think we are ready to replace the stent now. The same thing we are doing. We are inflating the balloon with an indicator. The nominal pressure is 4. The RDP is 8 millimeter. So initially we planned to go up to 6 millimeter, but there is a partition of waste. So we went up to 8 millimeter, where we saw there is complete disappearance of the waste. Next. So the placement of the stent looks perfect. We have to take out the balloon now. Yeah, the same thing we are doing slowly. So that is the thing. We have taken out the balloon inside the sheet. So these are things that like below. So now the sheet is inside the RV, and we can have some injection just to check the position of the stent. with the flow slightly big. So we check and you can in audio 30 view. This was perfect. The state is exactly at the RVOP, the average portion. We can have the hemodynamic monitor. Are you reading the euro? And you okay, go to the lateral view. We can check the lateral view and injection once. Here you can see there is small waist and that is exactly at the center. Looks perfect. Okay, so then we have the hemodynamics. Put the pressure line in the RV state. So as you can see, while entering the stage, we had some hypotension because we have completely uploaded the RVOT, but that was momentary. And we thoroughly checked, there was no CT changes, there was no evidence of any coronary compromise. And this coronary artery profiling actually we did the last time we used to call in the PPT. So we can have the hemodynamics now. As you can see, in the aortic pressure 92/49 with a mean of 65 millimeter of mercury. And we have the RV pressure also. Okay. Yeah, as you can see. Perfect. We start with the RV pressure was near 50. Now RV pressure is less than half literally. The RV system you can see it's only 37 millimeter of mercury. So there is definitely very good drop in the RV pressure. RV pressure has now become less than almost like 30% of the systemic pressure. So we are planning to take a pullback gradient across the stent. We'll enter the PA with the catheter and we'll take a pullback gradient. So as you can see, we have crossed the stent with a multi-purpose catheter. We'll take a pullback. So can we have the pressure line on the picture catheter here? Like this. Right. So now we have the PA pressure. The hemodynamic monitor big. Can you make the hemodynamic monitor big? Okay, so you can see that this is a PA pressure, systolic PA pressure of approximately 32 millimeter of mercury, and diastolic PA pressure definitely it will be very low because of pre-pulmonary regurgitation. Mean PA pressure approximately 10 millimeter of mercury. Can we have that pullback? So we are pulling back the catheter across the stent. Yeah, so yeah. So can we put the pressure line in the sheet? That is done. So this pressure was 33 millimeter of mercury. Now we have the RV pressure now. Yeah, we have already checked the RV pressure was also 40. So there is not much in pressure gradient across the stent. I think the RV pressure now is 31. So exactly the same. There is not much pullback gradient across the stent. We got a very perfect result. So probably we won't go for a revalidation today. Maybe if the child requires any future pulmonary implantation, at that time we can dilate the stent. And this stent, as I already mentioned, can be dilated up to 25 millimeter, and we can easily place a like a melodic valve or a microphone inside it. So today we will accept this result. Well, I would like to congratulate the team. They did a very good job today. The placement of the stent is exactly perfect. It was not a very easy case, but it was done perfectly. So you can ask if there is any query or any question, you can ask us. Thank you.
Hello, thank you for doing such a nice case of RVT obstruction post-operative patient. So if anybody have any question from the floor, please.
Yeah.
Sir, one query that steep amplifier OR you have taken as stabilizer OR, that will go in the across the pulmonary valve, pulmonary artery, and it was looking much down and turned. So how far you have taken that that amplage wire?
Sir, actually, to pass any big shape, your distance where position should be very good. Otherwise, the wire will just flip off. So what and for any RUT or any grant for them, always they have to go inside the AC because the invitation will give you a very good advantage. So in the APV it was something very deep, but probably it was in the basal area of the left lung. So definitely it didn't clear the diaphragm, and it was another ultra steep wire, which is the diameter is 0.35. So it will go through any standard catheter, but yeah, if you can perfectly place this, taking the big sheet will become very easy. So suppose if you are doing a cavity or a EPBL, even sleeper wire like a lander will be required. But this alternative is very good for a once for an FT or a RUT intervention.
Is there any risk of tearing the lung parenchyma through the vessel?
No,
Okay, that's thank you.
in part is small.
Actually, you have, there is a curious question in the long term, whether PR pulmonary resuscitation becomes a concern or not.
Sir, actually, this particular case, I would answer. The pulmonary regurgitation is already there. When they did the
So you have increased it more
No,
by
sir,
this mechanical process.
because, sir, if the pulmonary
When it is a by process, it is increased.
make 100 more times. The pulmonary regurgitation was weak, like a severe pulmonary regurgitation, and we have placed the skin across the muscle band, and the bulb was not there at all. So the amount of the pulmonary regurgitation will remain the same, but if there is a free pulmonary artery regurgitation, just like any pathology of lung who is undergoing transcatheter fat repair, there will be free pulmonary artery regurgitation, and there is chance of RV dilatation or dysfunction. We have standard measurements. Beyond which we have to filter that can be placed either constitutionally or by surgery. This particular case was discussed in our meeting. Sometimes we refer this style for surgical intervention. We could have done that also. But what will happen? Already one surgery is done. This would have been a reduced surgery. Again, in future, this particular time may need another surgery for surgical pulmonary valve. So how many times we can open the radical position? With the fire excel stain, as I already mentioned, the final diameter of this particular stain can be expanded up to 25 millimeters without much force. We have already 20 millimeter valve stains in our shell. Majority of my valves are actually 20 millimeters. The US diameter from 19 to 20 millimeters. Suppose you can expand this particular stain up to 21, and you can easily put a 24 millimeter stained valve. So that will it will prepare the room to put a stained pulmonary valve in future. So probably this particular cell will require another intervention in the form of transcutaneous pulmonary intervention, which can be easily done to this particular cell.
Okay, thank you. Nicely done. And whether can we go back to the second case remaining part, or will we?
Go to that, then is
You like to show?
good afternoon, everyone. I would like to say thanks to the organizer for giving us the opportunity to show you the live cases from Narayana Super Specialty Hospital, Howrah. This is the first case. This is a case of grant.
No, in the previous case, that's
Hello.
hello, okay. We are listening. The remaining part of the, whether the kissing part of these remained, that's why we are going to show it or not.
So after the dilation with the 1.25, we did dilated this chart with the 2 millimeter. So this, we went up to the 14 atmosphere, and then we already 2.75 and 14 atmosphere. Individually, and then we did everything at 8 atmosphere final dilation. And followed by a report. So this is the report with 3.75 millimeter. And it can be angular. So this will be. So this is an alternative here that is going to be good result. So any other question so that we can conclude this session because we have the presentation. There I am coming joining.
Okay, thank you. If anybody has any question from the floor, otherwise we are going to close the session. If anybody has any question. So thank you very much for doing the 3 cases and nicely and perfectly done. So we are just declaring the closing of the sessions. Thank you.
Thank you so much. We end the session over here and move on to the next session, tips and tricks session. As chairperson, I would like to invite on the dais Dr. M.P. Tripathi, Dr. Panjanan Sahu, Dr. Shopon Paul, Dr. Shopon De. Kindly requesting all of you to please grace the stage as a chairperson. As moderators of this particular session, I would like to give my warm invite to Dr. Tanmoy Jyoti Shahu, Dr. Tanmoy Kumar Matia, Dr. Tarok Shamanto, Dr. Utpal Bhaumik. Requesting all of you to please grace the stage as the moderators. The first speaker of this particular session, Lad Osteal Lessons, speaker Dr. Bikash Mojumdar. Thank you.
So, good evening. I welcome for this session, tips and tricks session. So the first presentation will be LED ostial lesion by Dr. Vikas Majumdar. Dr. Majumdar, please.
Good afternoon, chairpersons. Good afternoon, colleagues. Today I am going to discuss about the tips and tricks of LED ostial stenosis. Let's start with a case. He's a 52-year-old gentleman who had a history of anterior wall myocardial infarction 4 weeks ago, for which he had primary angioplasty to the mid LAD. He had residual osteoproximal LAD disease and the diagonal disease. Is non-diabetic and non-hypertensive. And this is the angiography. You can see, now I've treated the diagonal with the drug-eluting balloon, which I haven't shown you here. So this is the angiography. You can see that patient has a patent stent, which was done a few weeks ago. And he has got some disease in the osteoproximal LAD. So at this point of time, I would like to interact with the audience. And could you please, give your opinion? How many of you would like to continue medical management without doing any procedure in this particular case? Yeah. For time's sake, I haven't given you the entire angiography, just this 2 view. This is probably the best views. I don't know why it's not playing. Right, so this is the osteoproximal LAD. The first option, that don't do anything, just keep on medical management. That's the better option, okay. Right. Second option, I'll stent the osteoproximal LAD without crossover to the left main stem. Just so majority don't agree. Okay. Stent the osteoproximal LAD with crossover to the left main stem. Yes, so you want to cross over. And fourth, I would like to have for more information by doing an IVUS. So there is a group, definitely they want to do an IVUS because want to have more information about this lesion, because increasingly now we are agreeing that angiography is probably not enough to deal with all these kind of lesions. Anyway, so if you go back about the literature of the osteal LAD disease, it is actually not confined to the LAD. It's a continuation of the distal left main to the LAD, and 90% of this osteal LAD disease actually also have left main stem disease. And these are the distribution of the plaques. If you do IVUS in those patients, that you can see that osteal LAD is actually not osteal LAD. There are left main stem involvement as well, which we often don't see in an angiogram. So before considering stenting to the osteal left LAD, we need to consider certain points. Do we want to just keep our stent absolutely nailed at the ostium of the LAD? Can we do that? That's first thing. Second thing, how safe it is to leave few struts in the left main stem after doing just precise osteal LAD stenting? And actually, do we need to cross over into the left main stem? And many a time, as we don't see any disease in the angiography in the left main stem, being an interventional cardiologist, we often are quite afraid to put a stent in the left main stem if it looks healthy in an angiogram. So that's our innate kind of inhibition of coming to a left main when we can't see a disease in the left main. And there is another issue, is how to deal with the vast difference in the vessel diameter. So left main is 5 millimeter, your LAD is 3 millimeter or 2.75 millimeter, whatever, how to deal with this discrepancy of the size if you are crossing over and doing the left main at the same time. And what is the angle of bifurcation, whether it is a narrow angle or it's a wide angle, and what is the distribution of plaque? Is there any osteal circumflex plaque? Is there any distal left main plaque? These kind of things we need to consider. And at last, is angiography enough for the decision-making in this kind of lesion? And at the end, if we cross over to the left main, do we actually need to do the kissing of the circumflex ostium in order to prevent a future circumflex osteal stenosis? These are the few questions that we need to think about before going for an angioplasty to the osteal left main. Now, this is a pictorial representation of what we see in an angiography and what is actually the real anatomy. So if you see an angiography, it looks pretty the same. It's, just a lesion there. But does it really mean that? So there may be plaque inside, which you may not even see. There are a lot of plaque which may be extending after the left main, which we may not see. So that we have to consider, but we see the same angiogram all the time, and we underestimate the plaque burden and plaque distribution if we are not doing IVUS in these kind of patients. And it is often extremely difficult to precisely stent at the ostium unless and until there is a very big left main compared to the LAD diameter. And unless and until there is a very little plaque in the distal part of the left main, it is very difficult to precisely stent at the ostium. Now, if we are thinking that we are going to stent precisely at the ostium, then we need to find out, is it safe? And can we actually predict? We can do that by doing an IVUS. I'll come to that later. But what are the studies saying about osteal stenting only and versus vis-a-vis if we cross over and come to the left main stem? Now, it's a small study comparing that only osteal stenting vis-a-vis the crossover stenting. And you can see if you do the crossover stenting, you don't have an IVUS, for an example. Not everyone has an IVUS. So if you do a crossover stenting, come up to the left main, your result is much better as far as the AMI is concerned, as far as the stroke concerned, and the target vessel revascularization is concerned, restenosis is concerned. If you actually do the crossover into the left main, your result is better compared to if you just putting the stent at the ostium and keeping few struts on the left main. Now, as we know, many interventionists in a normal looking angiographic left main, we don't want to come into the left main. Can we predict that if we can put the stent just at the ostium, then you have to do an IVUS. And in the IVUS, if you see near the carina, there is a sharp edge. It's called an eyebrow sign. And if you see that, and in spite of seeing that, if you just place the stent here at the ostium, you are actually going to get a circumflex ostial stenosis in few months or years' time. Though your acute result will be absolutely fine. But if you're seeing this, and in spite of seeing this, you are actually putting the stent just at the ostium of the LAD, you are actually inviting a circumflex ostial stenosis in due course. But if there is no eyebrow sign, probably you can get away by just placing the stent at the ostium of the LAD. And this is the pictorial description. So this is your eyebrow sign. And if you put the stent just at the ostium and you invite a circumflex ostial stenosis. And if you don't have an eyebrow sign, you just precisely put the stent at the ostium of the LAD without coming to the left main, you generally get away without producing any circumflex ostial stenosis. So these are the few things that we actually need to do that. In this particular case, I actually performed an IVUS, and I wanted to see that what is the area at the osteoproximal LAD, and also wanted to find out what is the size of the left main. Now, this is from the distal stent, which was put a few weeks ago after an infarct, and you can see proximals to the stent edge, there is significant disease in the osteoproximal part of the LAD. I'll show you the measurements as well. You can see the plaque. This is pretty much tight here. And then you see it is coming near the bifurcation, the circumflex ostium, and then coming to the left main. And you can see in the 9 o'clock position to 12 o'clock position, there is a plaque in the left main as well. So in this particular patient, there is osteoproximal LAD as well as left main disease. So I decided to measure that. And when I measured the ostium of the LAD, the measurement came 3.79 MLA. So this is significant, less than 4. So I decided to stent it. And if you look at the left main, there is 55% plaque burden in the left main as well. So I decided to cross over and stent from proximal LAD to the left main, because the left main was diseased as well. So the rest of the thing was pretty much simple. I just pre-dilated that with a balloon, and then this is the post pre-dilatation, and then I stented with a 4x18 Ultimaster Tansei stent. And this is, again, when we choose the stent and we size the stent, the one thing we have to remember, because left main is often very big compared to the distal part of the LAD where we are actually landing the stent. So how do we size? So if you do an IVUS, so the distal part where you actually want to land, you measure the intima to intima diameter and the media to media diameter. For example, if your intima to intima diameter is 3 and media to media diameter is 4, you choose a 3.5 stent if the distal. And then, for example, your left main is 5 or 5.5, you have to choose a certain type of stent where actually you can post-dilate 3.5 stent to 5.5. And this particular stent, the Ultimaster Tansei, which we can be 3.5 stent can be post-dilated up to 5.5, at least 2 millimeter above. So in this case, I choose a 4 millimeter stent overlapping the previous stent, and I inflated that. And at the end, I did a pot with 4.58 millimeter NC balloon, and then that was the final result. So this is the pot, and you see the final result, angiographic result, and that's where I finished. And I did an IVUS again, post-procedure IVUS, and you can see the post-procedure LAD ostium was 8.16 millimeter square, and whereas the left main was pretty much big, 12.71, what I have achieved after doing that. And I didn't do any further kissing in the circumflex ostium in this particular case. So in conclusion, ostial LAD lesion is often associated with distal left mainstem disease, and nearly about 90% of the ostial LAD is associated with left mainstem disease as well. IVUS is helpful to decide about the plug distribution, the vessel size determination, and crossover stenting has better outcome compared to the precise ostial stenting attitude, though in those patients where and those interventionists who are practicing without an IVUS, I would recommend if you see an ostial LAD lesion, it is better to stent crossover and stent. And I'm not saying that every time you have to come up to the ostium of the left mainstem, but you at least have to come do a proper pot in the left mainstem. So at least 8 millimeters, so that you can have an 8 millimeter balloon to do a pot inside the left mainstem. And while we are choosing the size of the stent, then we have to be careful that what size we are choosing, because there may be often a discrepancy of the left main and the LAD. So we have to choose the stent accordingly, and to know about the stents, which stent you can go up to which size. So that's all about the tips and tricks of doing ostial LAD lesion. And regarding the circumflex kissing, there is no consensus. Generally it is said that if it is a big circumflex, flow is fine, and the patient's age is a little bit advanced, don't do anything about it. Just leave it like that. But if the younger patient, big territory is supplied, and you think there may be some pinching in the circumflex ostium, you can go back and do a kissing of the circumflex ostium as well. There is no consensus that all the circumflex ostium has to be dilated and kissed in the left main if you do a crossover stenting, but it's your personal decision whether you want to do a kissing of the circumflex ostium as well if you are crossing over. Thank you very much. If you have any question, I will take that.
Hello, nice deliberation. You have discussed all the important points, including imaging, precise placement of the stent, and about if during implantation, before implantation, while positioning, the position is very important. If the stent starts moving too much, what do you do? What is the...
Now, one thing, you can put a wire in the, the thing is the guide position. First thing, if the stent is moved too much, the guide position has to be, you have to place the guide properly, number one. The second technique is the wire you are pushing in the LAD, you can pull the wire back a little bit. Third thing, you can put another wire into the circumflex. And fourth thing, if you're coming to the ostium and you are not sure, you can put a wire inside the aorta that will give you a guide about where the proximal part of the stent you have to land. So these are the few things that you can do.
Thank you, sir, for the presentation. Sir, many of us are not so much fortunate to have IVUS in our lab very regularly. So in our clinical practice, we have often seen that in a primary setting, when we just landed at the ostium, definitely and invariably these patients come back to us for with an ostial stenosis after 1 year. So it's my question to you, without IVUS guide, is it always advisable to come to the left main in all the cases for ostial LAD lesion, even in primary setting?
Now, in the primary setting, the first thing is to restore your TB3 flow, right? So that's what you do. But as I showed in this particular thing, that if you don't have an IVUS, it's better to come up to the left main, because there is nothing called ostial LAD disease alone. So it's the left main is diseased. And if you're just trying to precisely stent the ostium, then actually you are disrupting the plaque, which is having in the left distal left main, but you are not realizing that. So probably you are having more chances of having an instant stent thrombosis, or sometimes can jeopardize the flow in the circumflex as well. So I have seen many cases where in 2 or 3 starts that what we used to do, put into the left main, and within few months, you will see the circumflex ostium is absolutely pinched. I lost one patient after having an acute stent thrombosis, after just putting a stent in the ostium. Patient went home on the day to he died at home. Straight away, I could realize what happened. He had an acute stent thrombosis.
You are saying about osteal LAD or osteal surgery?
Osteal LAD.
Osteal LAD.
So what he's saying that if it's an osteal LAD and the primary situation, we'll just leave the stent at the osteal LAD and come out. I think the safer to come to the left main and then leave that patient, because many a time this osteal LAD stent is actually, you can have a stent thrombosis,
Sir,
which I had.
Two questions are there is also two questions are there. One is, without IVAS, how ethical is this to come to a left main and to size the left main only on angiographic view?
Now, only on angiographic view, it's difficult. It's definitely difficult. But as I say that initially, now that's all the left main we should be doing with IVAS. Answer to that question is initial part of your career. Of course, definitely you should be doing all the left main with an IVAS. And once you do 100 cases of left main, then you understand that what is what. And then you can do without an IVAS. But when we are learning, the IVAS will give you a better understanding of the left main. But does it mean that all the left main has to be IVAS guided? Answer to that question is no. So if you look at the total IVAS penetration throughout the world, it's about 20 to 30% of the cases. In the left main, probably a little bit more.
Right.
But initial cases, when you have the understanding, it is better to use an IVAS.
And sir, in
Thank
this
you, Dr.
strategy,
Majumdar.
and sir, in this strategy, pot is necessary. All the case. Pot
Yes,
is necessary.
what is absolutely necessary. Reason being, you are taking a 3.5 stent, for example, according to distal vessel, your left main is 4.5 or 5. So you need to have a pot. So you have to have a stentless within the left main where your pot balloon size is.
Yeah, because it is perfectly correct. In our long time, people are doing the practice for 40 years of interventional cardiology. Initially, particularly precisely the osteal, particularly push the osteum 1 or 2 millimeter inside the lemons. But eventually, we have followed also, the international also approved that is shifting the plaque to circumflex may cause the at least 50% cases of the stenosis of the circumflex. This may happen.
Yes.
After the last 10 years of what I am doing, that is advocated by the European Bifurcation Club as a whole, even normal LMC, it is the Gorang always advocated.
Gorang always
so
advocated.
in terms of
Yeah,
publication,
yeah.
it's better to be placed to the at least to the not always to the ostium.
Yeah.
If it is short lemons, definitely ostium. Otherwise, even mid part of the up to ostium, we can take out this slide. Of course, in this case, lemma 3.5, you can take it from the LMCA to mid part of the LMCA to proximal LAD.
Yeah.
3.5 is sufficient. If you take the Altimaster on so many strains is available, it is good decision. So eventually, on the probe, you should do the practice. So crossover up to lemons should be practiced routinely in our practice.
Thank you, Dr.
Can I have one
Majumdar.
question, sir?
Actually,
Yes.
2 days.
Yeah. Sir, can I have one question here? Sir, my point is like, is it like if the left main, this is, suppose it's a LCX, it's a dominant LCX, then it's the same thing, like if there is osteal disease, then that means that left main also having disease. Or in those cases, if you do crossover, means left main to LCX, and then suppose you have shown this case, if there is pinching in the LAD, then what is your means like?
Now, if you are doing crossover from left main to circumflex, it's
Yes,
mandatory to do a kissing for the LAD.
Okay.
Right? So you don't leave that LAD ostium without being kissed. Okay?
Thank you.
So that's mandatory.
About this controversy, whether in a LAD osteal stenosis, whether to take the stent into the LMCA. I was reading a meta-analysis 2 days back, some 14 studies meta-analysis in, of course, it is from Canada. They are told there is no significant difference in the mortality or the follow-up in the, whether you are putting stent just at the ostium or you are doing a crossover stent from LMCA to LAD.
I'm not talking always, no, to get a proper mortality difference, it's a big thing. Many of the studies don't get the proper mortality benefit or mortality difference. But one thing that further stenosis of the circumflex ostium is real problem. And we all understand that.
And when we have
and if you just
imaging, you should do imaging and go according
so,
certainly. Thank
you have said everything which is pertinent. The unpleasant thing what we have not discussed is we need to understand not all the stent will go from 3 to 5 millimeters.
Yeah.
Which may be available in your desk. And second, before doing this, you make sure that you have a short balloon and a larger balloon in the cell. And that's the major reason. If it is not there, we do a incomplete procedure. And this is a practical problem. Primary setting, tertiary setting, super specialty setting, whatever it is.
Thank you very much.
Cutting this in the left main shaft, in the stent in the left main shaft and rounding up to the ostium. What is your take? Supposedly, 50% of the LM is diseased.
Yes.
50% of the LM length is diseased.
Yeah.
Would you like
If,
just covering the plaque or come?
now, if you are sure that your ostium is not diseased,
It is diseased.
so whatever the disease part in the left main, I will cover that part.
Okay, you will not
And
come up to the
I'll
ostium.
up to cover that part and make sure that I have a balloon to pot that area.
Yeah, that's true.
50% LMCA is also significant. What you are telling is.
I'm talking of the
50%
length.
part of the
I'm
length
talking of the
LHA.
length.
He's not talking of the.
I'm talking of the length of the disease. Because I think there is a kind of suggestion that if you have a disease more than 50% of the left main length, I think it's customary to cover right up to the ostium if you have more than 50%.
Now we have IVASs, you know, so
Yeah.
you can see that how much the extent of the disease is there or not.
Okay.
Yeah. Thank you, Dr. Majumdar, for the precise discussion of the topic. We go to the next presentation. LCX ostial lesion by Dr. Priyam Mukherjee. LAD ostial disease and LCX ostial disease both are nearby. And let us see the discussion.
Good afternoon, respected chairperson and moderator and learned audience. So I'll discuss the tips and tricks of treating the circumflex ostium. Now, this is the Medina classification. There is a 001 and the Lefebvre classification, that is a for type 4B, which only isolated left circumflex ostium is being involved. But as my previous speaker told, that is an extremely rare phenomena, less than 5%. And practically very less, I think. So having isolated circumflex ostial disease. Now, circumflex ostium is basically I think I should say, is an Achilles heel in doing the left main bifurcation. You do a LAD ostial lesion, the restenosis occurring in circumflex ostium after a few months. If you do a crossover against circumflex ostium, you are getting stenosis. If a two-stent strategy, the most commonly involved restenosis is the circumflex ostium. So circumflex ostium is basically the Achilles heel or very bad subset in doing the left main bifurcation. So I will actually start with my first case. This is a father of a doctor, and you can appreciate. So there is type LAD ostial lesion. And I did a predilation and precisely tried to place the stent in the LAD ostium. But unfortunately, there is some few millimeters. The stent was in the LAD left main. The initial acute result was very good. The patient was asymptomatic. But what happened after 18 months? So there's a slight stenosis in the circumflex ostium. Not only that, the lesion also involved the left main, distal left main also. So this is the issue. This is the problem of doing ostial lesions. Either you do a LAD, vice versa, circumflex. So if you cannot actually, if you don't have the precise position of the stent, so this can happen. So if you do a similar stenting in the circumflex and having the large LAD compromise, so it can happen. So what can happen that way? So this is why this ostial stent placement is very difficult. Precise ostial placement of the stent is very difficult and sometimes it is impossible due to the angulation. So main vessel protrusion, of the stent is quite common, and plaque shifting, Dr. Paja was telling, and also the cranial shifting. They are the important two mechanism of the late acute or late bad results in the circumflex or the LAD ostium or vice versa. And hanging start in the left main vessel also lead to altered fluid hemodynamics, which leads to the later side branch stenosis. So these are the very important issues, and precise placement of the stent is discouraged. Now, what are the subset of what we should consider before actually treating the isolated circumflex ostium disease? Now, the threshold of doing a circumflex ostium should be very high. So this is the first basic rule. It's not a LAD ostium, it's circumflex, and you are doing a circumflex ostium, either a crossover or a precise. You are doing a precise nailing the stent placement, and in the later you will compromise a healthy LAD. So no interventional cardiologist wants that. So this is very important. So threshold should be very high, and there should be objective documentation of significant ischemia. It's not like LAD ostial. Okay, 50%, 60% you can do, but you should have a significant objective ischemic evidence, I think, and a large amount of myocardium should be at risk. You have to show that objectively. Now, clinical scenario in the chronic stable angina and ACS. Yes, ACS you do it, but in a chronic stable angina you try to manage it medically. So this is another important issue. Given the risk of main vessel compromise associated with the Medina 001 bifurcation lesions, it is important that the PCI approach is reserved for patients in whom it is truly indicated. So this is a very important point. So what are the clinical scenario? Isolated circumflex osteostenosis. Number one, is it really a de novo case with a significant isolated LCS osteal disease? You can got this isolated ostium after LAD osteal stenting. You can get after the LMT LAD crossover stenting, and later the circumflex having stenosis. Stent is okay, LMT LAD, and two stent strategy bifurcation. The LMT LAD stent is okay, but circumflex ostium stent having significant stenosis after a few months. So these are 4 clinical scenarios we can get. Now these are very important. So you can actually try to put flush osteal stenting. Now, some degree of osteal miss or main branch protrusion. So I have already discussed. So it depends on the angle. So unless it is almost 90-degree angle, you cannot actually get a perfect position. Either it will be in the left main or you will miss the ostium. So that is the important issue. And number 2 is the spiky carina. In the previous speaker, they have in detailed discussion of the spiky carina. So in a spiky carina, you don't try to put a stent in the ostium. You just cross over the stent. Otherwise, there is significant or malignant carinal shift and the patient having symptom travel. So this is the main issue. You can see the second position. So this is a large ostium, more than around 90 degrees. In such cases, you can try, though it is very difficult. So this is one of my cases. So she has a ACS symptom, and LAD and the circumflex ostium were diseased. So you can appreciate the circumflex ostium having significant disease from the very proximal ostium. And after fixing the LAD, I plan to do a circumflex flushing stenting. There is just keeping the stent in the LAD circumflex ostium. So after pre-dilatation, I put a stent precisely in the circumflex ostium. There was not significant movement of the stent, so I was fortunate in that setting. So I can able to place the stent perfectly in the ostium. So this was the result, and after post-dilatation, so this was the result, and without significant protrusion or any main branch or LAD osteal compromise. So this was the case. Now I got the opportunity to do a check angio 6 months later when the patient actually came with a CHB and syncope. So 6 months. So I did a check angio during the permanent pacemaker implantation, and I found that the circumflex ostium stent and the LAD stent is perfectly patent. So this was you can tell it's a short-term follow-up, but it's a 6-month follow-up of this flushing of this flush stenting. Now another technique is the inverted provisional stenting, as my previous speaker told. Is that directly go for the left main to LAD stenting. So here you can also go inverted provisional stenting. That is, you can go from the left main to circumflex and making the LAD as a side branch. And I think this should be the default approach and more predictable approach. So it is more predictable. So this is another case. You can see There is a mild left main plaque and with the LAD is healthy and circumflex proximal part starting from the ostium having significant disease. So after pre-dilatation of the proper pre-dilation of the ostium, you put a stent from the left main to your LAD, left main to circumflex, and after pot and post dilatation and rewiring, this was the ultimate result, and the patient is doing good in the follow-up. So this is by default. I think if you have to do a circumflex ostial stenting with a narrow angle, so this is basically you can do the case like that. So inverted crossbar stenting. Now there's a third scenario which can happen. So if you have done a left main bifurcation by the two-stent strategy. So this is a LAD is a Medina 111 classified bifurcation, distal bifurcation lesion, and we did a two-stent strategy, and after putting the stents and crushing, putting the main vessel stent, and final pot kissing, you have achieved a good result. This is the final result you have achieved. Now there is hardly any problem in the final result, and also I was also showing a good result. But what happens after 8 months? The circumflex and the left main to LAD stent is almost normal. Again, the problem in the circumflex ostium. So circumflex ostium having the significant disease, and this is having a stent also placed at the present moment. So putting another stent in the circumflex will should not be a solution here. So in these cases, drug-coated balloon is a choice basically in these cases. So you pre-dilate either a scoring balloon or cutting balloon thoroughly, and then put a drug-eluting balloon and do a final kissing and just came out. So this is another strategy of doing a circumflex ostial disease. So this is IVUS and showing acceptable result. So this is my I have a final case. So this is another stenting. So you can appreciate the mid part of the LAD is tight lesion, but the lesion has been started from the very proximal part of the LAD ostium. So the stent was placed tried to place in the ostium. So you can see the position of the stent. This is the final position of the stent, and you can see the acute result is very good, no doubt. But if you see carefully, there are a few starts they are put in the circumflex ostium or left main. So this is the problem you cannot provide. You cannot avoid this. You cannot avoid this. How much you are very precise. There is some movement. You cannot actually. You are not God or you are not a robot. You just fixing the place just at the ostium. So it's very difficult to put the place correctly at the ostium. So what happened again after 2 years? The patient having patent the LAD stent. There is no problem in the LAD stent, but again the burden goes on the circumflex. So that is why I am telling. Circumflex is a notorious vessel. The ostium is a notorious part in doing the left main bifurcation. So again, there is very bad condition of the circumflex. Now you have no option putting a stent, and in this case, the culotte technique is very important to bail out. As a bailout technique, you just dilate it, put a stent from the left main to circumflex, and then recrossing in the LAD, and after doing a final pot, final kissing and final pot, you can get a good result. So this is the final result. I think this is acceptable result. So in nutshell, so to conclude my talk, so LCX ostium again I am telling it is basically Achilles heel in the left main bifurcation, doing a left main bifurcation. This is these crux. So we always feel that what will be the fate of the circumflex ostium? What strategy we are taking? So isolated left circumflex ostium is a very difficult subset to treat because we are doing the circumflex, and nobody wants that after doing a side branch or circumflex, the main branch will be compromised. There is a LAD will be compromised. So this is the main concern. So our threshold should be very high for the coronary intervention of a circumflex ostium. And physiologic assessment is very important. Only seeing the angiogram, it's a tight lesion. I don't prefer to do a case, particularly in a chronic stable angina. You must show in a physiological imaging, physiological way, there's a objective evidence of significant myocardium ischemia is there. Then you will only treat the circumflex ostium. And if angle is conducive, that is, if angle is 90 degree, then yes, if there is a no plaque in the your left main or distal left main on the LED ostium with a 90-degree conducive good angle, you can try a flush position, flush nailing of the stent in the circumflex ostium. Otherwise, don't try to put the stent in the perfectly in the ostium. Definitely, it will actually miss. Either it will miss the ostium or it will go in the left main, and later it will compromise the main vessel LED. So inverted provisional technique should be the default choice. This is my opinion, particularly when the angle is not conducive, is a narrower angle. And yes, imaging not always possible in our country. Not all lab having your IVAS or OCT. So, but imaging should be done, because as my previous speaker was also stressing the fact that imaging can show that it's a isolated circumflex or isolated LED ostium. They are basically not possible. There's some plaque distribution in the distal left main or LED or side branch also. And DCB is now an emerging option, particularly if there's already a stent placed in the circumflex, particularly in two-stent bifurcation technique. Some operators are doing actually isolated circumflex de novo lesions, doing a good cutting balloon and then putting a circumflex, but there's no significant data. So this is not a platform to promote this concept of doing a DCB in the your circumflex ostium isolated lesion. But yes, DCB is emerging, and I don't know, after 2 to 3 years, if I am to again give the talk, there maybe DCB can be an option there. And this is my conclusion slide. Thank you very much for your patient hearing.
Hello.
Thank
There is
you.
a question. There is in the meantime, we have heard about the Jabo technique for osteal stent placement. What is your comment about that?
Sir, I did my DM in 2011. At 2011, I entered to in PG hospital for DM, and it is 2023. So 11, 12 years have been passed. I have seen no operator doing Jabo. I have seen no operator doing Jabo for the last 12 years. Because the Jabo technique, yes, theoretically it is very good. You are actually placing the side branch where from the distal start, but the stent, even after doing that, it is not sure that you can place the stent perfectly at the ostium. Number one. Number two, there is always a chance of distortion of the stent and displacement of the device stent. So there is number two. And number three, particularly in the current generation stent, when the starts are very thin starts, 60, 65 micron, 60 micron, it is not possible to do Jabo. So this is my opinion. If a thick start stent, you can all try. But in the current generation stents, very thin start, Jabo is not possible. And I have not seen any operator in my career doing Jabo in living in the actually.
Thank you for nice presentation. Actually, every day we are facing this type of problem, especially isolated LCX lesion in cath lab. I am from Bangladesh, Professor Mustafa Jaman. Already you have discussed elaborately how to do in this scenario. My question is, DCB is a good choice, but DCB can cause also osteal actually different complication also. Then how can one proceed at that time? Because we know DCB is a good choice, but dissection may be helped by DCB also.
Sir, actually issue of any, if you treat any osteal lesion, be it a LED osteal lesion, be it a circumflex osteal lesion, be it a RC osteal is very tough and fibrotic, any lesion. So we know what is the problem of the ballooning. There's always chance of recoil, and actually it can be a mess for your work. So that is the issue. The DCB in the osteal, I don't think it should be a recommendation, because there's always a chance of your recoil in the early recoil, and also if there is a dissection and if the dissection protrude in the left main, this is very problematic. So only doing a circumflex osteal lesion with the DCB is very new thing, or too early to comment that it is a very, and it should be a future. But regarding the dissection, in case of DCB implantation, some operators who are actually doing regular DCB implantation, they actually encourage dissection. They say that if there's a dissection, then the drug will be very much in your lumen and the intima. So the effect will be more. So mild dissection without any flow limitation, with a good flow, still DCB you can do, but in any osteal lesion, how much safe it is to leave the dissected ostium, either LAD or the circumflex, is a very questionable thing, I think.
Yeah, everything actually, this is still no problem because DCB is the only one solution, but the operator skill and everything is very important also. But you have mentioned everything. Actually, in cath lab, we are facing this problem, especially isolated L6 lesion. So the current philosophy of stenting is to reduce the metal burden, and DCB is a good choice here. But there's no good study still. RCT is still now. But DCB, if we available, we can use. But always we must protect the Letman and LED also. Thank you.
Actually, this group, Anthony Colombo doing the cases or particularly osteal lesion, even the circumflex, but the restenosis is very high because of shear stress. So in that case, he prepared the mouth of the circumflex initially by NC balloon, which followed by the cutting balloon, Wolverine balloon use. If the bed is prepared, well, that case is DCB very effective.
Yeah.
Is Anthony Colombo advocated. But one thing is that when the size of the LMCA is big size and the circumflex not too much grown. So in that case, small size, that case is definitely, we have prepared the mouth of the ostium, definitely with the cutting balloon. Then a T-stent should be given because I cannot do the crossover from the LMCA to circumflex because size of the vessel is indifferent. That is an important issue. But in cases of the provisional stent, when the circumflex impinge and it physiologically even FFR positive, that cases, even in spite of the kissing balloon, some flow limiting obstructions there. That cases, we have to do the upfront T-stent or clot is the answer.
Sir, actually, if any crossover strategy, if you are actually doing a LAD to left main to LAD or left main to circumflex, you should have a very clear concept about the stent you have in yourself and what is the expansion limit. So you should have a very clear concept. So without knowing that, suppose LAD is 3 and left main is 4.5, so you have to know that this size, this stent must be available. Otherwise, I should not do the crossover strategy. So that is a very important issue. The operator should know that what stent he has available in his shelf. So number one. And number two, says regarding the T-stenting, again, T-stenting is very appropriate when the angle is 90-degree angle. The angle is more narrower angle, so it is difficult to place the T-stenting. Similar issue, either the stent will be protruded in the main vessel or you will miss the upper part of the ostium. So this is a important issue. And one thing in the primary angioplasty setting, if you found this like that, so I think it is my experience. If a primary setting, you have to put better to, if you can restore the TME3 flow, if putting the stent in the ostium, either a LAD or circumflex and give a good acceptable result, then leave it. Because in the primary, you are doing a crossover, you are doing a post dilation. The more you do ballooning, more thrombus, more problem. And time is a very issue. So primary should be very prompt and very swift. And you have just ensure the TME3 flow. This is my opinion. If you cannot actually leave it, then okay, you go for a crossover. Otherwise, try to leave it in the ostium. So this is my opinion.
So the L6 ostial and LAD ostial lesion is a very notorious place because LMCA, LAD and circumflex, we have to take care of all three. And when circumflex is sizable and you are putting a stent, you have to think of whether it is impinging into the LAD or LMCA ostium. And imaging is a must in these cases while positioning the stent. About drug-eluting balloon, only there can be it can be considered when left circumflex is a smaller vessel and putting stent across LAD and ostium, giving a higher metal burden may be more hazardous. Otherwise, only a drug-eluting balloon dilatation and coming out in a LMCA bifurcation lesion is a very dubious question.
Thank you.
Any question?
Thank
you, Dr. Major.
Thank you, Priyam. Our next topic is transeptal puncture in left atrial appendage closure system. Dr. Soumukhanti Datta.
So good evening, everyone. Today's topic of mine is transeptal puncture of left atrial appendage closure. So left atrial appendage closure has reached its journey starting from the 1950s, when we started puncturing the interatrial septum just to measure the left atrial pressure before we have done the MVR, that is the mitral valve replacement or any kind of surgical procedures. But nowadays it has expanded its arms, that is the transeptal puncture is needed, starting from the electrophysiology study to the appendage closure to left ventricular assist device placement, and the most important, the PFO closures. And these days, the mitra clip as well as the transeptal repair of the prosthetic valve leaks through the plugs. So we all know how does the left atrial appendage occlusion helps us to prevent the thromboembolism, because it is the only cul-de-sac that is responsible for the thromboembolism starting from the left atrium to the left atrial appendage. It is the most important structure that generates the clot within the left atrium. So we can basically skip the VK, those patients who are not willing or not be able to cooperate with the PT-INR maintenance, and the oral anticoagulant therapy is not suitable to them, early CKD or in advanced stages or in patients with cancer chemotherapies. In those patients, definitely it is a reasonable approach to all of them, and it is possible by implantation of the occlusion devices through the percutaneous approach or through the other approach, both surgical as well as percutaneous, that I shall be discussing in my later slides. So starting from several devices, before the devices starts, we should know the left atrial appendage anatomy. So it consists of, most of the cases, two lobes. Almost 40 to 50% of the left atrial appendage consists of two lobes. It may be unilobe or multi-lobe, that is 2, 3 or 4 lobes, but most of the cases it consists of two lobes. And the anatomy, mostly the chicken wing, followed by the cactus, and the other windsock abnormalities or variants are there. So we have several devices in our armamentarium in our hands, starting from the Watchman Boston device, and the most important these days is the Watchman FLX device. So what these two devices differs? If we go with the Watchman device, it consists of 10 struts, and the Watchman FLX is a compact structure consisting of 18 struts, which tightly negotiated within the left atrial appendage. And most important thing, it is recapturable. We can recapture it if it is not positioned within the left atrial appendage, and we can replace it again. Abbott started its journey with the ACP, that is Amplifier Cardiac Plug, followed by the Amulet device. Amulet is extensively stable, and I have experience of using this Amulet device at least 3 or 4 patients, and they are quite stable after implantation of this Amulet Abbott device. So before going to the anatomy proper, the left atrial appendage occlusion, it not only prevents the thromboembolism in atrial fibrillation, but also helps us in preventing the prescription of long-term maintenance as well as the window period of VK. We all know, but it is most likely to prevent the bleeding score as well. Those patients who are not able to take those high-risk NOACs, or preferably in patients with the non-valvular AF or in patients with valvular component also, if the PT-INR window period is not maintained. So the growing evidence with these devices, both the Watchman as well as the Amplifier devices, resulted in several guidelines, and it has recommended as a class 2B recommendation for the left atrial appendage closure in patients, those who are having contraindication of anticoagulation, be it a VK or NOACs. And the Amulet, what we are fond of, is the second generation Amplifier LA appendage closure device compared to the ACP. The Amulet device has more anchoring hooks, as I have already discussed, and it is almost having a stability in the left atrial appendage. So without wasting much time, straight away I shall go to the anatomy proper. I have already discussed it consists of several anatomical variants like windsock, cactus, chicken wing. Chicken wing is the most important, most common one. So
most of us perhaps be familiar with the thing that the left atrial interatrial septum, generally we do it with the Mullin sheath as the PTMC procedure and through the radiographic approach. So the needle most often used as a stainless steel needle, the broken borough needle, which is the most commonly used in Medtronic ink with the, and the needle is hollow tube, which is 18 gauge tapering with a 21 gauge needle. But it is preferred to go with the St. Jude BRK standard needle in case of left atrial appendage, because it has two things. Number one, if we use the BRK needle, it has an angulation of 19 degree, and if we have a large left atrium, we can shift to the BRK1 needle that has a tip to shaft angulation of 53 degree. So larger right atrium, it is always preferred to go with the BRK1 needle that sits in the interatrial septum, and it's easier to puncture the interatrial septum in the proper place. So we should always know where to puncture for this placement of the left atrial appendage closure device. It is the inferior and the posterior part of the left atrial fossa ovalis, and through this needle, it is easier to puncture. If you can see, there are various angulations here with the BRK devices. BRK normal has a short angulation, and BRK1 has a almost 60 degree, near about 50 to 55 degree angulation, which are we feel generally comfortable to go with these devices. After the puncture, we generally advances the Mullin sheath, and generally it is done at the 4 to 5 o'clock position to have the appropriate position as we are doing in the PTMC or any other procedure in the interatrial septal puncture. The left atrial entry is confirmed by the reddish blood of the left atrium, and obviously the pressure tracing in the left atrium, it is important. But before going to puncture in the 4 or 5 o'clock position, the optimal position of the needle is to be confirmed by the RAO and the LAO view that I shall be discussing. So through the radiographic approach, we generally drop the needle down from the SBC, and obviously we put a pigtail for the safety profile. And after the second drop, that is from the SBC to RA and the RA to fossa ovalis, which is the common situation we generally are familiar with, we generally puncture the needle, the broken borough or BRK needle accordingly to have a safety, not to puncture the aorta or any other sandwich effect. So after the puncture, generally the inferior and the posterior puncture is needed because it is the straighter approach to reach the left atrial appendage. If we do it higher, the sheath may be kinked. If we do it lower, we may not reach the left atrial appendage properly. So the appropriate puncture is extensively important. As we all know, if we go through the anatomy of the left atrial appendage, the most important thing to exclude the left atrial appendage clot before we go to the left atrial puncture. Because suppose we have punctured and I have put the wire and I have put the sheath in the left atrial appendage without knowing it contains of clot. So I may dislodge the clot and it consists of immediate thromboembolism. So two things is mandatory. Number one, to exclude through the TEE or transthoracic if we can able, and preferably in the TEE, that is the transesophageal approach, to exclude the clot. And the most important thing is the pericardial space evaluation is mandatory, because a chink of pericardial effusion, and if I go from the right atrium to the left atrium through a pericardium, the sandwich phenomenon, and ultimately may lead to the pericardial effusion, huge pericardial effusion, which may not be reversible. And the most important thing, the assessment of the length of the mitral valve to the ratio, which I shall be discussing in my later slides, and the closer relation of the left circumflex artery, because it is the most approximate and the closer position from the left atrial appendage. So these are the closer anatomies. The left atrial appendage through the transesophageal approach, generally we evaluate in the upper esophageal at the 0 degree view. So if I analyze this picture, the left atrium to left atrial appendage generally is straight unless and until it is a cactus or the chicken wing, and it is closer to the left upper pulmonary vein. So it is always easier to put your sheath or wire first in the left upper pulmonary vein, then drop it down to the left atrium. You may inject a few amount of contrast media to confirm your position, whether it is in the left upper pulmonary vein or in the left atrial appendage. Then definitely wiring is important, and gradual progression of the sheath to the left atrial appendage. up to 10 to 12 millimeter advancement, because the placement of the left atrial, whether it is the ampulager plug or the watchman device, the length assessment is important where I should release the device. Because to release the device, it is generally recommended that 10 to 12 millimeter gap from the ostium, that means the LA ridge to the left atrial appendage, is generally necessary. And it is close to two things. Number one, the LCX artery and the left upper pulmonary vein. So we have to take care of these two things. The 4-chamber approach in the transesophageal approach is absolutely necessary to measure the height of the puncture, because generally it is done within the 2 to 2.5 millimeter of the crux. That means the mitral or tricuspid crux anatomy. If I go higher, then I may be able to reach the wire, but the sheath will be kinked. And when I push the device, be it a watchman, be it an ampulager, then suppose it may be impinged into the lobe, but it may not be retracted again. So this kind of situations may not close the left atrial appendage properly. So the absolute height where the left interatrial septum is to be punctured is necessary, and it is to be done within 2 to 2.5 centimeter from the crux. If we put it higher, it may be we may not be comfortable to reach the left atrial appendage. If we do it lower, it may hinge in the other pulmonary veins also. So another view, starting from the 90 to 0 degree to 120 to 135 in the mid-esophageal approach, generally gives us the right data of the left atrial appendage anatomy, whether it is chicken wing, whether it is cactus, or whether the some other anatomies, and the lobe is important, because I have put a ampulager device in a small lobe and there is another large lobe sitting in beside, it may not be occluded properly. So the lobe evaluation as well as the anatomy evaluation is important, and this is to be done in the 120 to 135 degree mid-esophageal approach. Now, coming back again to the interatrial septum, generally the puncture is done in the bicaval view. We all are familiar with the bicaval view. It is a mid-esophageal 90 degree with a slight right turn. It is being done. In the bicaval view, generally we can see the IVC and SBC simultaneously with both the atrium, starting from the left atrium to the right atrium. And in the bicaval view as well as the 0 degree and the 45 degree view, we can evaluate where to puncture, and the indentation of that needle is generally easily visualized in the bicaval view. So the anteroposterior approach as well as the inferior-superior approach is to be determined by these views. Now, the most important thing is the 0 degree and the 45 degree transesophageal view. In the 0 degree view, the left atrial appendage, the length from the left upper pulmonary vein can be evaluated, and generally it is released from the 10 to 12 millimeter until and unless the left atrial appendage is too large. If it is large, the length can be progressed to 10 to 15 millimeter also. And if it is carved in the ostium to the ridge, generally the length may be shorter also. So this 0 degree and 45 degree mid-esophageal evaluation is necessary to hinge, to release the device and to measure the length of the disc to the device. Now, the most important views which I shall be discussing for the puncture, it is the bicaval view and the short axis view of the transesophageal approach. So in the bicaval view, we can easily delineate the superior as well as the inferior, that is the SBC and the IVC. And generally it is being done closer to the IVC, that is the inferior rim closer. And in the short axis view, it is done in the posterior part of that. So with these two views, generally for the left atrial appendage closure puncture, we do it in the inferior and the posterior part. Now, the length is important, the height is important, the height is important, and the most important thing is the anatomy of the left atrium and the closer proximity of the L6 artery as well as the left upper pulmonary vein. And the puncture, as I have already discussed, is generally done in the 5 or 6 o'clock position. If the right atrial anatomy is larger, if the right atrial is quite big, you may rotate your needle, broken bow needle to 6 or 7 o'clock position as well. So this is the slide which is showing that the optimal transeptal puncture sites of the left atrial appendage closure. The medial and posterior and the low transseptal puncture allows a straight approach to the left atrium. If we do it too high, the transseptal puncture more than 3.5 to 4 centimeter above the mitral valve plane.
Dr. Datta, please sum up.
Yes, sure. So intracardiac echocardiography will help us in evaluating this kind of puncture as well. And the most important challenges we all should know that even if we puncture, we may not progress our seed or the Moulin seed because of the septal fibrosis, because of the lipomatous hypertrophy and these kind of situations. And in that case, we may use for advancement of the seed, the coronary balloon or any other balloons you may use to progress the seed if it is not crossing properly. Nowadays, the most important thing, the energy radio frequency transseptal kit is available, which is easier, which makes us easier to puncture as well as see the site of the puncture, as well as with the energy impulses, we can do it very easily without any damage to the nerve tissues. So this kind of recent advances in the septal puncture generally helps us to advance the guide wire also, and without injuring neither the left upper pulmonary vein or any other pulmonary vein or the left atrium, or there is minimal chances of causing tamponade as well. So the take home message from today's topic is that transseptal puncture is absolutely necessary. Generally TTE or transesophageal approach is necessary. Cardiac CT helps us in evaluating not only the lobes as well as the anatomy of the left atrial appendage. We must have a experienced hands for septal puncture, but generally over the time and the recent advances have helped us. And these two views, that is bicaval view, transesophageal, and the mid-esophageal short axis view, helps us in evaluating the anatomy. CT guided puncture may be to some extent needed, but generally echo is sufficient enough to reach our left atrial appendage, and the clot as well as the pericardial effusion before the procedures is the most two important things to be excluded. Thank you very much.
Thank you, Dr. Dutta. While choosing the amplazer device or Watchman device, do you go for imaging in all cases, either CT or
No, not necessary. Not necessary, sir. Always not necessary. If I feel difficult in approaching the left atrial appendage, then I inject some kind of dyes like that. I have put a video also, sir. So generally after puncture, the needle straight away goes to the left upper pulmonary vein. It has to be dropped down again, and you can see the left atrial appendage. Then the wiring is being done, and you can slowly release the device. Once it's having an onion-like structure, the first lobe is released, then pull it back, and automatically the second flap is released. So it is easier if you are able to do all these things. So the anatomy evaluation is absolutely necessary, sir. And after the device placement, the one should exclude the damage of the left circumflex artery. So it is not recommended always, but it is safer to have a coronary angio done so that we are not damaging the circumflex artery or left upper pulmonary vein.
You mean angio after putting the device?
Yeah, I do angio after putting the device.
Thank you. Any question from the floor? Thank you, Dr.
Thank you, sir.
Datta, for your nice presentation. Thank you.
Thank you. Thank you.
Thank you so much. We end the session over here. Thank you so much to all the chairpersons as well as the moderators. We move on to the next session, CTO session. I would like to invite as chairperson, Dr. Ranjan Sharma, Dr. Debobroto Roy, Dr. Shantanu De, Dr. Saroj Mondol, Dr. Shapon Haldar, Dr. Mahesh Chaudhary. Requesting all of you to please grace the stage as a chairperson. Also, as a moderator of this particular session, I would like to invite Dr. Kaushik Shur, Dr. R.K. Gupta, Dr. Ashish Sinha, Dr. Shantanu De, Dr. Lipika Odhikari. Requesting all of you to please grace the stage as the chairpersons and the moderators. And the first speaker of this particular session, Anti-Grade Approach, presentation by Dr. Shobhik Kanjilal.
Very good evening. I'm sure that we are not late in the session. We have a wonderful session on CTO, and this is a very a topic worth questioning by everybody whether we should do CTO or not, because there's nothing as a confirmed data which suggests that you should open the artery or not, because the risk and the benefit are always balanced on the table. So this is a very interesting topic where we're going to learn about the CTO, and we have a very good panel. And and
but the first presenter is Dr. Souvik Kanjilal, who will speak on an anti-grade approach. Souvik, floor is yours.
So good evening, everybody. Thank you, Chairman and Chairpersons. Today, my topic will be on anti-grade approach for the CTO PCI. Well, as interventional cardiologist, almost everyone has witnessed so much development and improvement in the success rate of CTO PCI over the last 2 decades. Think of the success rate in almost 15 or 20 years back, when it was only 20 to 50%. But these days, it has exceeded almost 90%. Well, the reasons are many, but the most important things are the techniques and improved devices, which has helped us to gain such success. But I think the most important thing is a better understanding, the strategy which we should adopt, and the understanding of different techniques actually helped us in achieving that success. Well, among different techniques, anti-grade techniques, anti-grade wearing is the most commonly adopted techniques in less complex cases. Well, anti-grade wearing means we put in a wear, we try to penetrate the cap, and we try to maintain the intraplaque status of the wear till the distal cap is punctured. Well, there are many other methods of anti-grade wearing as well. We'll discuss later on. And it has been found that the proper knowledge of both anti-grade and retrograde approaches is very much essential to get the maximum success rate. Well, adopting hybrid approach actually helped us to gain maximum success, to make the CTO PCI safe procedure, and throughout the world, it has achieved significant importance while treating a patients of CTO. Well, the most important thing is getting a proper anatomical assessment of the CTO, and that is done by dual injection of the arteries, except in cases where we have intra-arterial collaterals or bridging collaterals. Well, while assessing the CTO, we need to understand whether some complexities are there or not. And by complexities, we mean if the proximal cap is ambiguous, if the distal target is very poor, and we also need to assess the interventional collaterals and the major side branch at the distal tip. Well, ambiguous proximal cap means the location as well as the course beyond that occluded part is not very understandable. Well, if these complexities are not there, then we can go for an anti-grade approach. And for that anti-grade approach, we again assess the total length of the CTO. If the CTO is less than 20 millimeter, we can adopt the process of anti-grade wear escalation. Well, this is, of course, not the absolute one. We can always change the strategy midway if we think it is necessary. And if the total length of CTO is more than 20 millimeter, then straight away we want to adopt the anti-grade dissection and re-entry strategy, also known as ADR. So regarding the angiographic assessment, we need to assess different things before starting the process and before selecting the wear. Well, the proximal cap assessment is the most important thing to decide upon which wear we should start with. Proximal cap means if the proximal cap is blunt, then we need to have a penetrating wear with heavy tip load. Similarly, presence of calcification in the proximal cap or the presence of branches near the proximal cap again means that we need a penetrating wear. The shape of the proximal cap is also important. If we have a tapering shape proximal cap, then we may not require that penetrating wires, rather less heavy tips. Tip wires with polymer jacket might help in such cases because we might face lesser resistance while penetrating the cap. Well, the CTO body length is another important issue. As I told earlier, if the body length is more than 20 millimeter, then it's not advisable to go for anterior wear escalations. Similarly, the presence of calcification and tortuosity again will rather dictate us to go for dissection based strategies. Well, distal cap and landing zone. This landing zone means the area of main vessel which is beyond the distal cap and just before the onset of origin of major branches. If the landing zone is not proper, then the retrograde strategy is advisable. And again, the collaterals, the presence of collaterals, their courses, their caliber, their entry and exit points, all are important in assessing the strategy. Well, we need to have a proper procedural setup, as we understand that these days, most of the CTOs can be performed with 7 French guide catheters. In fact, bilateral radial access can also help in such cases. And another thing is that we need a good passive guide support. For that, for left coronary system, we can use Voda left, we can use XP or EBU. And for right coronary, we can use 3D curve right art catheters or ampulas the left. Well, regarding initial wear selection, as I told earlier, it's a very important thing to start with. We consider using a low medium tip wears to start with, of course, when there is a tapered proximal cap, when there is a longer body and there is presence of tortuosity, because using penetrating wears in such cases, like in a longer body or tortuous artery, might cause problems. Whereas we can think of penetrating wear straight away if the cap is blunt, if there is heavy calcification in the proximal cap as well as the body of the CTO, if there is bridging collaterals, if the occlusion is very short and with minimum tortuosity. Well, I'm not going into the details of the nitty-gritty of different hardwares because my next speakers will be talking about this, but these are the different types of wear from which we can choose to begin the penetration process. Well, there are some light and medium weight wears like Fielder XTs and Fielder XTR for retrograde. We can use Pilot 200. Now, these are the medium and low weight wears with polymer jackets. Whereas penetrating wears like Confianza Pro 12, Asahi wears, these are wears which are used when we encounter calcified and blunt caps. Well, after penetration of the cap, it is important to cross the CTO body. Well, there are different methods by which you can do. Well, after penetration, it is better to introduce or push in the microcatheter in and exchange the penetrating wear with a lesser weight wears. And this is known as de-escalation, because if you want to use the penetrating wears further down, there may be some complications, especially if the artery is tortuous. So escalation and de-escalation is a method by which you can use antegrade wearing. Similarly, parallel wear techniques, we are all conversant with this particular thing, parallel wear techniques. That means if there is any inadvertent entry of wear in the subintimal space, we can keep that wear and can take another wear over a microcatheter and try to pass that wear through the plug. And another method is antegrade dissection and re-entry. That means this is a dissection-based method, and we can use it with wear-based methods or device-based methods. Well, wear-based methods are no longer very much encouraged these days, unless if you try to bail out an antegrade wearing technique. That means if you have entered to the subintimal space inadvertently, then you can try to knuckle the wear and pass the wear through the subintimal space. But the problem with this wear-based technique is that the re-entry is not very much guaranteed. In fact, you don't have a control over the re-entry. It might go into the major branches, distal, the distal part.
Conclude.
Yeah, definitely, sir. I don't have much. Yes. So you don't have no control over the re-entry. But the device-based is rather more advisable these days for anti-grade CTO crossing. For the device-based, we have, as we all know, the crossboss and Stingray system, as well as the recross system. And this is a recross device. This is nothing but the over-the-wire dual lumen microcatheter. It rather gives us some control for the re-entry. Well, the Stingray balloon is rather more important for a dissection-based device. It needs a crossboss catheter, which is a blunt dissecting catheter, which passes through the extra plug intima in a controlled dissection manner, and it helps to deliver the Stingray balloon. This Stingray balloon is actually a flat balloon, 10 into 2.5, with two exit ports at the tip. Now, before re-entry, we need to align the Stingray balloon so that the exiting wire does not puncture the adventitia. For that reason, we need to collinear, make the 2 points of the exit and the surface of the balloon in a collinear plane. Well, this is a video which shows how to proceed with this crossboss and Stingray technique. Now, the crossboss catheter is passed extra plug through the subintima till the distal cap is pierced. Then we remove the crossboss catheter, we deliver the Stingray balloon, we inflate at 4 atm pressure and try to bring in the Stingray wire. This Stingray wire is a micro bulb at its tip, and this wire usually tries to cross the distal lumen. But if there is a significant atheromatous plug between the exit port and the distal cap, then we can use some penetrating wires like confianza. Well, after the distal wire is delivered, we try to exchange this wire over the microcatheter, and a workhorse wire is placed in place of it, and the remaining part is carried out in a normal manner. So these are the different methods of, in a very short and in very simple way of anti-grade CTO technique. Well, my take-home messages will be that there has been advances in different equipments and techniques that has led to the success, but we need to be familiarized with these specific techniques and equipments and understand which technique is used in which situations. Well, anterior wire technique remains the predominant strategy for the CTO of less complex lesions, and many CTOs can be dealt with dissection-based strategies, especially these ADR-based strategies can offer a very safe and efficient means in selected patients. Thank you for the patient sharing.
Thank you. How often you use CT angio to guide whether you are going to do antegrade or retrograde?
Yes, sir. So when the cap is ambiguous, then we can use some adjunctive methods, like you can use intravascular ultrasound to clear these anatomical ambiguities, or you can use CT angiography prior to the operation to assess the tortuosity or the length of the CTOs.
So particularly in case of the antegrade technique is very common procedures in cases, particularly when lesion is visible according to the CTO score. That is very important issue.
Right.
And you have to measure whether the length of the CTO and whether associated calcium and scoring that should be calculated. We have taken. But my question, why actually common microcatheter that the fine cross is commonly used in cases of the antegrade approach. Why it is commonly used?
So this is because of its deliverability and it's because of this.
My impression that is that I come across an abstract, Jack, that is the less dissection. Because you see, if you use the other wire, it is sharp. It causes the dissection. But here, the whole lumen is covered up by this microcatheter fine cross.
Thank you, Souvik. May I now invite Dr. Aftab Khan to have his presentation on the various CTO gears. We are actually running behind the schedule. We have to hurry it up. Dr. Aftab.
Yeah, so I think Dr. Souvik has already taken part of my work away. So some of the slides that he's already shown would cover some of the hardware that we are going to use in our CTO. But again, I'll try and keep it within the limit and make sure I don't exceed the time. I'm sorry, we do not have a keynote presentation available with us. So, okay, so I think just skipping to the we have.
Is it not moving? Yeah.
Okay, it's there. Okay. So I think we are just going to go to CTO gears and what do you do? So I think the basic thing is, as Dr. Souvik has already said, I think it's setting up the case, and it requires you to do some planning, get some hardware in with you along when you start. Earlier, we had we had to cut out your guides when you're doing an anti-grade to get your retrograde geared now. But now you have these short guides also, so you don't need to necessarily cut your guide anymore. You need to have your guides with side holes and have to have the long sheaths also. So if you have tortuosity in your femoral arteries and you don't have a long sheath in place, you've crossed the artery and then you're struggling to get your material in. That doesn't make much sense. So often making sure that you have a good access, making sure that you have long sheaths when you're using a femoral access is something that's imperative when you're setting up your case. I think it's all comes down to guide wires, and I think it becomes quite murky and quite dizzy. I think if I just put up this slide and I say we have done the work. So this is how our mind works. When we have guide wire classification, we have all these wires and we really don't know what to use, when to use. I think it's important to just stick to 1 or 2 wires. So do not try and fill your brain with too much of wires. Be comfortable with 1 or 2 wires and then use those wires and get more comfortable with it. It does not mean that you necessarily have to know all these wires, to have all these wires in your shelf. And I think just to start off, I think there are 4 important features which are required for our wires. We need to have a coating wire. So when you have these polymer coating wires, they give you the slippery feeling and they help you to pass through these small micro channels. And then there are these channels which are, these coatings which are hydrophilic and hydrophobic, and these work over the working tip of the wire. And then there are the core material. You need to have the core material to understand. And I think the best example of this is the Gaia wire, which does not have a transition. It is just a single core as compared to the other wires, which often have a transition, which makes it difficult for you to have a torque response. And you must know the tip strength. You must know the tip load of the wire, because as you escalate your wire, if you don't have a good penetrating force, you need to do a wire escalation, and you escalate in terms of your wire penetrativity also. So when you classify them simply into 2 wires, 2 major groups, one is a polymer coated wire and one is a non-polymer coated wire. And the polymer coated wires are the ones that we use, which have a polymer jacketing. And what it has is that it makes it very slippery. So you can get your wires in, but then again, it loses your torque control. So you do not have much of a feel. It will just go through, but it does not give you the feel or does not give you the tactile sensation. And therefore, it's good for tortuous lesions or lesions where there are microchannels. So when you have a microchannel, these are the wires, or the polymer coated wires are what you'd want. But then you don't want it for the calcific lesions or the dense fibrotic lesions, because what will happen is that they'll deflect off the calcium and then they tend to go subintimal. So before you've started a case, if you have a subintimal passage, then you're in a false playing field right from the beginning. And so you don't want to do it for cases where you have dense calcium or calcification. The other group of wires are those we talked about, are the non-polymer coated spring tip wires. And here again, you have two types. You have the hydrophobic and the hydrophilic material coating. And these are the ones that are useful for the calcific or the blunt tips where you really want to penetrate. And again, these are the ones which are also good for the parallel wire technique. So you've got your wire down to one of the false lumen, and now you want something that gives you tactile feel, something that lets you penetrate rather than the slippery wires that you have. And again, amongst these are the 3 ones, as I said, hydrophobic, hydrophilic. And again, these are the ones Crusade and the Miracle series and the hybrid series, or the Confluenza, the Conquest Pro. So again, I think what comes down to the tapered versus non-tapered. So when you have a small micro channel, to have a tapered wire sometimes make it easier for you to enter these channels. But if you have a blunt of a non-tapered wire, sometimes it just makes it difficult. And therefore, the tapered wires are the Fielder XT and the Confluenza series, and these are the ones which make it easy. So again, broadly classifying them, I think this is the slide that I look for. A hydrophilic wire is one where I'd use for a proximal tortuosity. It gives me a good feel. It does not give me a feel, but it slips through. And again, it's good for the micro channels. And a non-coated wires are ones which are used for blunt tips, where I need good control for parallel wires or something that will give me a good torque control. The wires, I think in the earlier days, we had only very few wires. The Pilot series was one that used to struggle with. But again, I think the Gaia series has made life very easy for all of us. And I think all of us have benefit from these wires. The advantage of these wires is the ability to torque these wires. So if you've gone into the false passage, you can always pull them back and get into another lumen without causing too much of a problem. And again, I think you must know about the first, second, and the third, and the tip load of 4.5 grams with the Gaia third. And it has what we call as the slip coating. And this also makes it easy for us to slip through the lesions. So again, when it comes to antigrade, I think Dr. Shovik has already shown us, this is what I would look at. If I have a start with a fielder XT, and then if I have a vessel with a known course, I would want to go with a tapered, a stiff wire. And if I don't know the course, I want to be ambiguous. There, I may not want to take a very stiff wire. I would take a wire which is softer because I can do a knuckle with this wire. So a Pilot 200 or a fielder XT are the ones which are normally used for retrograde knuckle also, or an antigrade knuckle. So there you would want something that is softer. And for my retrograde, this is my escalation. So I start with the fielder XT and then escalate to a higher wire. And then if you want a penetration at the end, you'd use a Conquest Pro. So we have the wires that we talked about. And then what we come to is microcatheters. These are also extremely important for us. There are many roles. You can use it for giving a strength to the wire tip. So you can use it for increasing the pushability of a wire. It also helps for wire exchanges. It can do a wire exchange with it. You can use a wire reshaping with it. You can do microchannel injections. You can use it to dilate the channels also. And again, when you're doing a retrograde, you must get it across the septal to prevent the septal from laceration. So again, this could be a simple, a huge list. You start from the general use. And as Professor Panja said, you have the fine cross to start with. The over-the-wire balloons is something that is not used anymore. But I think in our old days, this is the balloon that we used to be dependent on when you were doing a CTO. And this is the only balloon that we had. It had advantages, but it had certain disadvantages. The advantages was because there was a balloon, you could use it to dilate the channel also. But the disadvantage is that it could not be torqued. Now, with most of the micro catheters that we use two types. One is the basic, which is a non-braided. And this is what Professor Panja was referring to, the fine cross of Terimo. It's been there for many years. The only difference or the disadvantage that we find is that it's a non-braided. So you cannot torque it when you want to rotate and push it ahead. It is not good for torquing. You cannot push it ahead. So it has to be by push and pull rather than by rotating or torquing, which is the advantage that we have with the other braided microcatheters. So the braided microcatheters have made life easier for us because it gives you the advantage of pushing ahead by torquing. So the Turnpike series, the Turnpike Spiral, the LP is used mostly for the retrograde and for the antigrade also, but it's mostly for the retrograde. And the Corsair series. Now, this is again, the Ashai guys have done a wonderful job in getting us these wires and these microcatheters. Now you have the Corsair Pro, and you can look at the distal shaft. It's just a 2.6 compared to a fine cross. But the advantage of this is, as compared to the right side, you can see this. It has a very tapered tip. So, and the proximal part where you use it for torquing, that braiding is much better as compared to a fine cross. And then you also have the caravel that can be used. Now the caravel is usually used as a retrograde. We usually use it for retrograde. Again, you can see that the crossing profile is very, very small. And again, this is a non-braided catheter. So when using a caravel, again, it's a push and pull or a seesaw technique rather than a torquing technique. And again, you have these Corsair Pro XS, which is the latest of the series. We don't have it in India as yet, but the Corsair Pro XS has the benefits of Corsair Pro along with caravel. So you can do it has a braided along with a very, very small tip crossing profile. And so this is what would be a great leveler in terms of crossing. Other than that, we also have the Mamba series from Boston Scientific. The advantage of Mamba is that it has an integrated tip. So unlike the Corsair and the other ones which have a different tip, so when you're doing a extreme torquing, you can sometimes be fearful of breaking off the tip. Where the Mamba is one continuous tube, it does not break off because it's an integrated tip. And therefore that concern of breaking the tip does not exist with the Mamba. The other thing that you also need is for device for exchange. And this happens when you have because you're working on single length wires. And there's a dedicated balloon, which is known as the Trapper Exchange balloon from Boston. And this is much short, it has a 2 French diameter. So it's much thinner than even a balloon. And it can exchange from a 6 French, or you can have a 2 millimeter balloon to a 2.67 balloon for an 8 French. So this is a dedicated balloon for exchanges. And again, you can have another one, which is known as the trapping balloon. And there's something known as the trap liner. So a trap liner is a combination. It has the benefits of a trapping balloon along with an extension catheter. So the proximal part of the balloon has this balloon in the bit part, which can be used for trapping. And this is it has a guide liner in the tip. So the same balloon can be used to get a guide liner as well as exchanges without the need for an additional balloon. And of course,
1 minute to.
Yeah, the old days that we were doing the hydro method of removing a wire. Well, this is not so much encouraged anymore because you can lose your wire at this stage. The other wires are the twin pass wires and the other catheters that Dr. Shovik has already talked about. We have the Sasuke and the Kaneka Crusade, which are also used for exchanges. And of course, I think this has been extensively spoken by in my last speaker. You have the crossboss and the stingray. And again, as he said that you must realign it to the way that you can see the artery and then do a puncture. You must have bailout devices also with you. So one must have the coils and the covered stents and the pericardiocentesis the kit along with you. Of course, making sure that you use all these methods to break out your techniques. And emerging guiding catheters can also be used to get a good CTO puncture, even ambiguous caps. You have the Atlantis from the Boston Scientific, and you have the Volcano from San Diego. The advantage is that the solid state or the Volcano has a short tip. It has a 10.5, unlike a Boston, which is a 23 millimeter leading tip. So these are some of the catheters that can help you in your procedure. So I'll stop here. Thank you for your patient hearing. Yeah.
Thank you so much. Wonderful display of armamentarium. We have the third session. We will have an update on CTO by Dr. Monojit Lodha.
So thank you, Dr. After extensive coverage of the tools of the CTO. But one thing you should keep in mind also, thrombin should be ready in our cath lab, because some cases perforation thrombin is essential to save the life. Thank you for excellent presentation.
So Manojit, start your presentation, please.
Good evening, everybody. Respected chairpersons. Today we are going to discuss the CTO update. Basically, it is a very vast topic and it's very difficult to summarize in 8 to 10 minutes, but I would like to make justice in next 8 to 10 minutes. So first, let us know what is CTO. We all know what is CTO is defined as 100% occlusion of a coronary artery when there is non-collateral TIMI zero flow, and the duration of the CTO is more than 3 months. When the duration of the occlusion is more than 3 months, so we define as CTO. And in total coronary angiography, we find the CTO incidence is around 14.57%. So around 15% of the total coronary angiography, we find CTOs. But in CABG cases, if we find the total CABG cases, more than 50% of the cases are at least one CTO. Whereas in cases of angioplasty, in CTO patients, we do only in 5% of patients, we do attempt angioplasty. Whereas around 50% of the patients of CTO are left on medical management. So why this apathy to do CTO? So as I said, CAG, there is a 15% of patients CTO, but only angioplasty is done in less than 5% of cases. What are the hindrances in CTO angioplasties? So one of the major hindrances is a low success rate. As we have said, that in conventional angioplasty, the success rate is more than 95% to 98, 99% nowadays. But in cases of CTO angioplasty, the success rate is still lagging behind. Initially, it was around 25 to 30%. Now it has improved to around approximately 90% in experienced centers. So the CTO angioplasty, the another hindrance is the steep learning curve. You have to give really good enough time and have a real experience to learn, master the CTOs. And we know during the CTOs, there is consumption of time, there is dye, more radiation exposure, more cost. All these are a great hindrance in the development of the CTO. And there is a higher complication rate in CTO. CTO, usually the complication rate is approximately 1.5%, whereas in conventional non-CTO PCI, the complication rate is less than 0.5%. So this is a big hindrance in the development of the CTO. And most important hindrance in the development of the CTO is the perceived lack of benefit. Because even in the interventionist belief that there is no major benefit of doing CTO angioplasty, and we don't have good enough quality data to prove that CTO angioplasty do help. So this is what is the basic hindrance in the development of the CTO. So now in next slides, we will discuss how we have improved in last decade in CTO. CTO is the final frontier for any coronary interventionist. So what has improved in the last 4 or 5 years? If we see the procedural outcome even in all-come registry or in non-experienced center still is 55 to 60%. Whereas if you go for the experienced center in the randomized trials or Whereas if looking for the registries from the experience centers, we can find that the success rate can be as high as 90% or 89% in the recharge Japanese CTO trial. Also, they have seen the success rate of 88%, where they included patients more than 3,000 patients with CTO. So in experience centers, the success of CTO angioplasty has improved from 55-60% to 90%, or even nowadays recently the trial has been published where the success rate was more than 95% from the experience center. So it takes time to learn CTO, but if you are comfortable with both integrated and retrograde approach, then the success can improve from 60% to 95%. And if we see the complication rate from the Japanese trial, the complication rate also 0.53%, which is as good as non-CTO PCI. Also, if we see from the Europe CTO trial, then the complication rate was only 0.5%, which was as good as non-CTO PCI. So the complication rate has drastically improved in the experience centers, along with the improvement in the success rate. So why this success has improved over the time? So my previous speakers has already told about why this success has improved, because there is improvement in hardwares. We have now microcatheters, which has led to improvement in the success of the CTO PCI. There is CTO wires, dedicated CTO wires. Then there are dedicated balloons. The guide supports has improved. So all this has led to improvement in the success of CTO success PCI. Then there is image guidance, which has led to improvement in the CTO success, which is IVUS guided, or it may be OCT guided sometimes, and in the CT angiography. These images has really helped to understand us the better about the CTO and improve the success rate. And most importantly, I believe is still the improvement is because of the improvement in the skill set. Because we have learned about CTO over the last 1 or 2 decades, and we have improved, we have tried CTO, then because of this improvement in skill set has led to improvement in the success of the CTO PCI. So skill set, I think, is despite all the hardware, despite all the image guidance, it is the skill of the operator, it is the perseverance of the operator that is most important. So if we see the CTO guide wires, my previous speakers have already told there are basically 2 types of dedicated CTO guide wires. One are polymer jacketed guide wires with tapered tip are like Fielder XT or XTA, and straight tip guide wires like Fielder FC or Whisper or Pilot series. The Pilot 50, 150 or 200 and moderate stiffness. That non-polymer jacketed guide are like if we go with the low tip stiffness, that's Cyan, Cyan Blue, whereas high tip stiffness are Miracle series, which are used in flat, when there's flat stamp, we can use high tip guide wires. Whereas the tapered guide wires are Crossit, and high tip stages are Gaia 1 to 3, which I will discuss. So these are the different type of Gaia series. Gaia, I think, is basically a game changer in integrated CTO angioplasty. Gaia has increasing tip load and tip microcatheters increasing from Gaia 1 to 2 and 3. It is a composite core that leads to increased torqueability of the guide wire. And it is a microcone tip, so that leads to more penetration power. And it has it is pre-shaped, and its tip is durable, and it has good tactile feedback, which is very important in integrated PCI. And moderate penetrating wires, when vessel course is known, then it is a Gaia series is very good, and it can be used both for drilling and penetrating strategy. So Gaia is basically a game changer in CTO PCI. So if we see CTO hardware, what is the improvement? There are many microcatheters available. Sir has already told about the different microcatheters and the advantages of the different microcatheters. It provides better support, increases wire stiffness, and thus enhances its penetrative capacity, allows reshaping of the wire tip, and allows easy guide wire exchanges. And sometimes when you are sure that it is in the true lumen, you can give injections to localize. So microcatheter are preferred over OTT W balloons, and I will not go discuss the details about the different type of microcatheters. We know there is stringray and crossbows to integrately dissect and re-entry. So now there are different societies which has given different algorithms for crossing CTO. So basically, if there is an ambiguous cap, their distal vessel is underfilled, and there are good collaterals, which are good septal collaterals. And if the collaterals are straight away, we can go with the retrograde technique. Otherwise, most of the time we prefer to go with the integrate technique. And integrate technique, we should carefully analyze the angiogram. Angiographic, careful analysis of the angiography is the key to success of CTO integrated angioplasty. So apart from that, there are the EuroCTO algorithm is also there, which again says that we have to do the dual injections most of the time. If there is an integrated collaterals, then only we can leave away with the dual injection. Otherwise, dual injection is a must for CTO PCI. And if there is an instant CTO, then probably we go with the integrate directly. If there is not an integrate, there is no instant CTO, then if we should look for the proximal cap ambiguity. If there is a proximal cap ambiguity is not there, then we can go with the integrated angioplasty. If the proximal bias is there is ambiguity, then we can localize with the imaging technique. But if if there is not visible proximal cap, then we should go with the retrograde PCI. So this is the elaborate technique. And we should also know when we should stop angioplasty. So when there is more than 3 times the EGFR, the dye used is more than 3 times EGFR, then we should probably stop. If the radiation exposure is more than 5 GY, or if the procedural time is more than 3 hours, then it is probably time to stop. So this is another algorithm which has been recently published. It is a global total occlusion series, and it has shown it is more or less same with the proximal. If there is again non-ambiguous proximal cap, then probably integrate CTO. If the proximal cap is ambiguous and the distal bearing facial is also very visible, not properly visible, or if at the distal cap it has bifurcation, then retrograde CTO can be attempted directly.
Manojit, you have to conclude.
Yeah, yes. So. I will just one slide. Role of IVUS. It can help in identification of ambiguous cap. It helps us in identifying intraplaque versus extraplaque tracking. It helps us to know the plaque composition, vessel sizing, as well as stent optimization. So these are the different series which has shown there is a significant improvement of if you use IVUS, as well as in the success rate, as well as decrease in the TLT. Late luminal loss was less when IVUS was used. So these are the IVUS various ICT. OCT has limited role because forceful dye injection can increase the dissection plane. So the role of OCT is in CTO is very limited, but still in localizing the ambiguous cap or stent optimization can be done with the OCT. This is the coronary CT angiography is quite helpful because to know the tortuosity of the vessel, to know the calcification of the vessel, and nowadays CT angiography can be integrated in the cath lab to guide us the procedure. So I will not go into the management of complications. So my take-home message is the main indication CTO PCI is symptom relief. Ischemia relief trial is going on, which will be published by 2028, and it will give us the whether there is an advantage in the definite other clinical endpoints. But till now, the definite indication of CTO is symptomatic relief. The meticulous pre-procedural planning is essential in any CTO angioplasty. IVUS facilitates the CTO recognition and improved long-term outcome, and there is systematic approach to complication minimizes adverse outcome. So we have to be very careful in planning the CTO operations. So CTO is proverbially the end of there is a light at the end of the tunnel. So if you go through the tunnel, you will get the light. So CTO is like that only.
Okay, thank you very much indeed. Only one question I ask, that is the several trial, more than 8 trial is there. The Euro CTO, decision CTO, and several published and JACC intervention also show that there is survival not improved, mortality not improved, MACE not improved, and symptomatically, particularly angina is also not improved. Only the interaction, some interaction CTO, LAD only. What your comment that?
Yes, actually, if you see this Euro CTO trial and all the symptomatic relief was there, angina relief was there, the requirement of the anti-angina drugs has come significantly down, and the 6-minute walk distance has also improved, but there was no improvement in the survival. That's why I'm saying ischemia trial will be a game changer. It will be published by, I think it will be published by 2028 or 2027, and that trial will give us the result whether there is an improvement in the survival, whether there is an incidence of decreased ILR or not, because this till now the trials which has been done has been small percentage and the follow-up was very small time. So these trials are not adequately powered enough to show us the benefit of the survival or not.
If there is a retrograde filling, no, sufficiently, that case is controversial. Better not to do this because it's symptomatic along with the medical therapy.
Sir, even if there is an adequate retrograde supply, then even it is as good as 90% obstruction. Whatever 90% obstruction is integrated, then the flow is as good as 90% obstruction. So for symptomatic relief, still CTO-PCI can be attempted. Otherwise, whether there is a survival benefit or not, or ejection fraction will improve or not, these results will be published. We will be very firm to say after ischemia trials results comes out.
Again,
so we are waiting for the ischemia trials.
Cases. Yes. Okay, thank you very much.
Thank you.
Okay. So we close the session here because we are running almost 20 minutes behind the schedule. Thank you, my co-chair, and all the delegates present here. Over to you.
Thank you so much. We end the session over here. And moving forward to the next session, IVL and Orbital. As chairpersons, I would like to invite on the dais Dr. B.B. Bharti, Dr. D.P. Sinha from Bhagalpur, Dr. P.K. Hajra, Dr. Indranil Datta, Dr. Gautam Datta. Requesting all of you to please grace the stage as the chairperson. And as moderator of this particular session, I would like to invite Dr. Bapaditya Kumar, Dr. Devobroto Bera, Dr. Suchit Mojumdar, Dr. Rajat Kaur. Our first speaker, Success Stories of LVL, presented by Dr. Shubhashish Chaudhary.